Hello, good morning everybody. We start with the first lecture of the 39th refresher course of CME Miraj IMA. And to introduce Shruti Paramshetty, she is to talk on an approach to the patients of rheumatological disorders. She is a daughter of Miraj soil and she did her primary and secondary schooling in Miraj. She did her UG MBBS in Bharati Vidyapit Medical College and Hospital. She did her MD Medicine in the same college. She has done a fellowship in clinical immunology and rheumatology in Chandre Rheumatology and Immunology Center and Research, Bangalore in January 2020. Currently, she is a consultant at Rheuma Care Rheumatology and Immunology Center, Miraj. She has variety of publications, of which national journals have 7. She has done 2 presentations in Lupus Cora 2021 held in Venice, Italy, of which first was early diagnosis and intervention is a strong indicator of achieving minimal disease activity in patients with SLE. And she has also one more presentation of incidence of CME virus in patients with connective tissue disorders. She is a principal investigator in a study which is assessment of immune status in immunosuppression patients to monitor those patients and help in balancing between the infection and disease control. I would request Shruti Paramshetty to please start her lecture.
Shruti, just 1 minute. Before I go actually for the lecture, there is a kind announcement which everyone should bear in mind. This applies to the speakers also and this applies to the delegates also. Actually, the lecture would be for 30 to 35 minutes, followed by the Honorable Chairperson's comments on the lecture, and 5 minutes are allotted for question and answer. If we abide by this time, I feel that we will be able to complete the schedule as per we have jotted yesterday. Thank you. Shruti, you can continue.
Thank you, sir. Thank you, Chairpersons. And first of all, I would like to thank Chadda sir and Riyad sir for giving me the opportunity today. We all have been taught about the various systems, how do we approach it, but in our training process, we are always not taught about how do we approach to a patient with rheumatological disorder. So today I'll be talking on how do we approach a patient with rheumatological disorder. Like Fatak sir said, it is not just joint pain and not just NSAIDs and steroids, it's much more beyond that. So first we'll see how do we approach a patient who presents to us with joint pain. When a patient with joint pains comes, there are certain factors that must be taken into consideration. That is, if the joint pain is of acute onset or a chronic onset. If it is of an acute onset, there are various conditions. Not all joint pains will be chronic. So depending upon the type of joint pain, if it is an acute onset, there are various conditions where joint pain can come, and if it is a chronic onset that is more than 6 weeks, there are various conditions where we can see certain joint pain. Then always see for the symmetricity of the joint pain. If the joint pain that is there, if it is symmetrical or if it is asymmetrical. Symmetricity means if both the joints, that is both elbows, both knees are involved. If it is asymmetrical, that is it will be either a knee joint and an elbow joint. It will be either an ankle and a knee joint. So always see for the symmetricity in the joint pain. Then after that, we must always see if the pain is either inflammatory or non-inflammatory. So in this, how do we see if it is inflammatory? Inflammatory joint pains usually presents with early morning stiffness, or the patient will complain about pain or stiffness after any period of rest or inactivity. So these things should be considered, whereas in non-inflammatory pain, they won't have any early morning stiffness or any rest pain. So always consider these points when a patient with joint pains comes to us. And then see for if the joint pain is persistent or recurrent. Persistent means the joint pain is there continuously for a period of more than 6 weeks. But if it is recurrent, means there are episodes of symptom-free. There is no joint pain or swelling. And after an episode of being symptom-free, the patients will again have a recurrent episode of joint pain and is present. Then apart from the acute onset inflammatory and how the pattern of involvement of the joint should be taken, when the patient with joint pains come, always have a joint assessment done to the 68 joints. We should see for the 68 tender joint counts, whereas 66 swollen joint counts. These are the joints which must be examined. Swollen joints are just 66 because we cannot measure the swelling or assess the swelling in the hip joint. So it is tender joints are 68, whereas swollen joints are 66. So always assess these joints when a patient with joint pains come. Then see for the pattern of the involvement of the joint. That is, if the proximal joints are involved or the distal joints are involved. Then also see for the additive, if the patient presents with only elbow joint pain, see if the patient after few days he complains about the next joint pain, that is the joint pain is getting added. Always see if the there is additive nature of the joint pain. And then see if it is a migratory, that is the pain is migrating from one joint to the other joint. These all will give us a history about the probable diagnosis that we are thinking about. Then see for the pain as if it is a monoarticular, oligoarticular or a polyarticular pain. Monoarticular means single joint involvement, oligoarticular means up to 4 joint, and poly means more than 4 joints. So always see for these kind of presentations when a patient comes with joint pain. When a patient with monoarthritis comes to us, always have the differentials of inflammatory or a non-inflammatory kind of a joint pain. If it is a inflammatory, always think about the crystal-induced inflammatory kind of a joint pain, that is gout or CPPD, and then look for other infective etiology like septic arthritis, tuberculous arthritis. Then sometimes chronic like rheumatoid or SLE can also present with single joint pain. In case of a non-inflammatory joint pain, that is always considered osteoarthritis, any trauma, osteonecrosis, and these all can come as a non-inflammatory single joint pain. And of course, in case of chronic polyarthritis, consider rheumatoid arthritis, psoriasis, SLE, seronegative spondyloarthritis, and rarely gout can present as polyarthritis, and osteoarthritis can also present as polyarthritis. Moving on to the first case, here we have a 25 years old female who presents with sudden onset of polyarthritis for 3 weeks duration. She gives a history of 2 days of fever prior to the onset of joint pain, and patient also had some transient rash at the time. When she came to us, she had joint pain for the past 2 to 3 weeks, and there was tenderness in her joint and swelling in her joint, and her tender joint and swollen joint counts were 12 and 6. She had come, we investigated her with the basic tests like CBC was normal, her inflammatory markers were on the higher side. So the next thing is, what do we do next in this patient? Like I said, it is an acute onset of pain, that is, it is within just 3 weeks, or you can call it acute or subacute. It is not, and the patient gives history of fever prior to the onset of the joint pain. So this likely gives us a history of an infective etiology or any viral etiology. So always in such patients where there is acute onset of pain, always consider the diagnosis of any viral or infective etiology. rather than considering rheumatoid. Of course, rheumatoid can present as acute onset of joint pain, but before considering it directly as rheumatoid or any connective tissue disease, always consider viral etiology earlier. So what is viral arthritis? It is an infected synovial tissue during a systemic infection or by provoking an immunological reaction that involves the joint. We all know there are just few, we label all the viral arthritis either as chikungunya, but there are various viruses that can cause arthritis, and the most common are parvovirus. Of course, these are pediatric population mostly seen, but we should not forget that they can have presentations in the elderly. Parvovirus can present as symmetrical arthritis involving all the joint pain, and it is acute onset. And most of the viral arthritis which are just self-limited or treated by everyone and they feel better are mostly the parvovirus infections that are seen. Then hepatitis B can also present as arthralgias, arthritis with rash. Rubella infections can present. Then there's chikungunya that doesn't need any say. You people have treated it more than what I have done. And then HIV can present as various arthropathies, arthralgias, vasculitic kind of presentation. Then HIV related drug myositis can be there. So HIV has varied rheumatological presentations, and then of lately we have seen quite good number of post-COVID arthritis, which is also again labeled as chikungunya. But if you take a proper history or get a COVID antibody test done, we can see that these patients had COVID infections, and following that they had developed COVID arthritis. Then comes reactive arthritis. This occurs following any infection, that is genitourinary or gastrointestinal infection. And the most common organisms are Salmonella, Shigella and Campylobacter jejuni. And for genitourinary are Chlamydia. And this reactive arthritis, patients gives typical history of urinary tract infection or any vaginal infections. Following that, they present with joint pain. In reactive arthritis, the joint pain is usually limited to the lower limb. They present either as mono or oligoarticular kind of joint pain. Second case, here a 21 years male, he presents with a history of ankle joint pain since 5 months, and for that he was treated on and off with steroids. He also gives history of lower back pain, and since 2 weeks he gives history of pain in the right knee associated with associated with pain in the right knee associated with swelling. So in this case, like we see, it is a chronic onset of joint pain that is for 5 months, and he has asymmetrical joint pain, that is at a time the knee is involved, at times sometimes the ankle is involved, and he doesn't have typical axial symptoms of spondyloarthropathy. So there are patients who can have asymmetrical joint pain and present as spondyloarthropathy, and in this patient, when we evaluated, his HLA-B27 was positive with inflammatory markers being on the higher side. So spondyloarthropathy can be either axial spondyloarthropathy as well as peripheral spondyloarthropathy. Axial spondyloarthropathy can be radiographic as well as non-radiographic, and peripheral can present as reactive arthritis, psoriatic arthritis, undifferentiated spondyloarthritis, or any inflammatory bowel associated spondyloarthritis. So what is axial? So what is this axial and non-axial spondyloarthropathy? non-axial is the peripheral spondyloarthropathy, and what is radiographic and non-radiographic SPA is, in radiographic SPA there is evidence of sacroiliitis on X-ray, whereas in non-radiographic SPA we cannot see any changes of radiographic changes on X-ray of sacroiliitis, but an MRI can show an active sacroiliac inflammation. So when a young patient presents to us with history of back pain for more than 3 months and age less than 45 years, always consider a spondyloarthropathy kind of presentation. The patient can have HLA-B27 positive and can have any of these features like inflammatory back pain, arthritis, enthesitis, psoriasis, uveitis, dactylitis, CRP, and the patient can either have one of the imaging findings, that is on X-ray patient can have sacroiliitis, or MRI can show sacroiliitis.
टाइम द्यायला पाहिजे की तिथं तिनं जर खाली 10 मिनिट 30 मिनिटं जर रेकॉर्ड इथे तर अडकायला लागले.
So the next slide, psoriatic arthritis. People usually we do rheumatoid factor and anti-CCP, ANA, and we don't check for the skin of the patient to look for psoriatic arthritis. So always see for the skin manifestations in psoriatic. These psoriatic arthritis are usually presented when the psoriasis is in hidden areas where patient is not aware of it, like in the scalp, the nail psoriasis. So always take into consideration of a possibility of nail psoriasis, and you can call a patient of psoriatic arthritis when he has current history of psoriasis, or a past history, or a personal family, anybody has psoriasis, or either he has this dactylitis kind of a nail changes where the finger changes where the swelling is like a sausage appearance, and he can have radiographical changes. Always remember, when we do an X-ray of a hand, we get a clue about what kind of joint pain or what kind of arthritis it is. If the patient has rheumatoid arthritis, usually the PIP joints are involved and the damage is seen in the PIP joint. In this X-ray you can see the DIP joints are involved. You can see a penicillin cup kind of appearance, as well as the DIP joint is destroyed. Of course, DIP joint is affected even in the osteoarthritis, but there are few radiological changes which we can see in psoriasis, which that is DIP will have a swan deformity where it will give us an idea that it is a psoriatic kind of arthritis. Next case is 24 years female comes to us with a history of joint pain and swelling in the wrist joint. She has a typical migratory kind of a joint pain, that is pain is present in the knee and the wrist joint followed by elbow or the knee, and this pain and swelling is limited for a very short duration of time. It is not for a prolonged period of time, and by the time she comes to the doctor the swelling has gone. This kind of a presentation is there since 1.5 years. She has no history of fever or any trauma, but her lab investigations has come negative for all the tests like rheumatoid factor, anti-CCP, ANA. Since it was single joint pain, we even underdid uric acid levels, which was also normal, but her inflammatory markers were on the higher side. So in these patients, always see these set of patients can be called as palindromic rheumatism, which is recurrent episodes of transient episodes of acute arthritis with periarticular inflammation, which do not cause any residual damage. In these patients, the rheumatoid factor anti-CCP can be positive in some patients, and they have typical migratory self-limiting kind of a joint pain with high inflammatory markers, and there is no joint damage, and the treatment for this palindromic rheumatism is similar to what we treat a rheumatoid arthritis. Next patient is 34 years female who comes with a history of joint pain in all the joints, polyarthritis. She also has pain in her back, neck, calf muscles, like possibly all kind of pains she has. And these are the typical kind of patients who comes to us with multiple joint pain, and she doesn't have any history suggestive of connective tissue disease like oral ulcers, hair fall, any eye symptoms. Her personal history is normal, but her sleep is disturbed. So when we investigated her, her lab parameters are also normal. Her HLA-B27 is also done, which is normal. Her inflammatory markers are normal. So in these patients, always consider the diagnosis of fibromyalgia, where there is chronic widespread musculoskeletal pain associated with fatigue, unrefreshed sleep, cognitive complaints, depression and anxiety. So these patients can come with such complaints, all vague aches and pains, and they will probably have all kind of pains, all positive history to whatever questions you ask. So always consider these are the areas where we should see for fibromyalgia, that is in the upper part of the body, right and left side, and lower part, and in the axial spine. So there are 19 areas where we have to check for the tenderness of the joints, as well as the patient will also complain of fatigue, not able to sleep well at night, depression, abdominal pain, headache. So these all points should be considered into making a diagnosis of fibromyalgia. So when a patient with joint pains come, take into the consideration these points. If the recognize the pattern. If the joint pain is predominantly in the lower limb, consider spondyloarthropathies. If it is in the axial, again consider spondyloarthropathies. If small joint symmetrical involvement is there, consider rheumatoid, SLE or psoriasis. If it is asymmetrical, consider again spondyloarthritis. If there is combination of both PIPs and MCPs and the wrist joint, consider rheumatoid. And if it is DIP involvement is there, elderly, consider the diagnosis of osteoarthritis. Moving on to the next thing, not all ANA is SLE. Whenever a patient with joint pain is done, usually they are after doing rheumatoid factor, anti-CCP, we tend to do ANA, and when ANA comes out positive, we label them as SLE, but not all ANA are SLE. There are various other rheumatological conditions where ANA can come positive. So this is one of them. ANA can be seen in Sjogren's syndrome, systemic sclerosis, polymyositis. ANA can be seen in mixed connective tissue diseases, in autoimmune hepatitis. And remember, ANA can come positive in a general population where patient doesn't have symptoms. So always remember to do ANA only when the patient has a typical history of when you suspect a connective tissue disease, and don't get ANA done in all the people. And ANA at the dilution of 1:80 is more standardized rather than 1:40. So when do you suspect a patient with connective tissue diseases? When patient with skin complaints like photosensitivity, purpura, lividoreticularis kind of rash, when these patients come, always suspect connective tissue diseases. If patient has dryness of mouth, dryness of vagina, aphthous ulcer, dryness of eyes, alopecia, joint pain, muscle weakness, patient presents with mononeuritis or polyneuritis, patient has abdominal pain, Raynaud's, digital ulcers, and patient complains of fever and weight loss, always considered for connective tissue disease in such patients. Next case is a 19 years old female who comes with a pain in the ankle and wrist joint since 6 months, and she also has pain, fever on and off since 1.5 months. So for this joint pain, she was never given much attention, but what got her attention was she started having fever which was not responding to any antibiotics. She also started developing oral ulcers and she had hair fall. She also had a cervical lymphadenopathy. So she was evaluated with the local physician, and her blood picture had this kind of a presentation where she had anemia and pancytopenia, looked like a typical viral presentation, and she was evaluated extensively for any infective etiology, but all turned out to be negative, and she still continued to have fever, not responding to any antibiotics. So when she came to us, we got her ANA done, which was positive 3+ with nuclear speckled pattern. We did an ANA profile, which was SM, SMRNP, and SSB and RIP, and her complements were low and her urine had trace proteins. So always remember, when you see a pancytopenia with fever, consider an etiology of connective tissue disease, because she had symptoms of oral ulcers as well as hair fall. And remember that sometimes there are criteria to call patient as lupus. So this is the criteria of how to diagnose, classification criteria for lupus. ANA should be positive by 1:80 dilution, and the patient should have either of these symptoms with a score of more than 10. That is, patient should have fever, leukopenia, thrombocytopenia, any psychiatric kind of manifestations like delirium, psychosis, seizures, alopecia, oral ulcers, pleural effusion, pericardial effusion, any renal involvement, musculoskeletal symptoms, then immunological complements. Her autoantibodies for dsDNA and Smith should be positive with antiphospholipid antibody. Always remember, there are various other autoantibodies which are lupus specific, and just not ANA and dsDNA will give you the diagnosis of lupus. There are various immunoblots like SMRNP in these patients which we saw. They all are lupus specific autoantibodies, and remember, in this classification criteria that has come recently in 2019, they have said that to make the diagnosis of SLE, ANA should be positive. But there are various ANA negative lupus where ANA is negative, but patient has other features like low complements, thrombocytopenia, leukopenia. On basis of that also, the diagnosis of lupus can be made. Moving on to the next thing. Patient comes to us with oral ulcers. Again, it is just not lupus. There are various other oral ulcers which can present, that is Behçet's. Behçet's can typically present with aphthous ulcers, which is painful, and in Behçet's the ulcers are present even in the genital areas. Along with that, patient presents with uveitis, whereas in lupus ulcer is non-painful for first thing, and it is usually located in the hard palate. If the lupus ulcer is painful, and it can be most likely a discoid ulcer.
Herpetic infection common है oral cavity
Next is when to suspect a Sjogren's syndrome. In Sjogren's syndrome also, patients can have ANA positivity, and they can also just present with polyarthritis. Patient can also have associated dryness of eyes, dryness of mouth, poor oral hygiene. They'll have brittle teeth. They will have cutaneous vasculitis, and they can present with these things. So not necessary patients with Sjogren's always presents with parotid gland swelling. They can present with polyarthritis also. Then patients with Raynaud's scleroderma, they can present with Raynaud's before the changes of skin thickening happens. So when the patient presents with Raynaud's
Graton patch.
Always have a diagnosis of a connective tissue disease or a scleroderma kind of a presentation. They'll have skin thickening, digital ulcers, and you will see the loss of nail folds or the wrinkles over the skin. When the patient with Raynaud's presents to us, always exclude any obstructive etiology or other etiology like drugs, occupational hazards, or any neuropathy like carpal tunnel, and then see for the connective tissue disease like scleroderma, mixed connective tissue systemic lupus, myositis, antiphospholipid, and sometimes thyroid cryoglobulinemia can also present with Raynaud's. Then patient can present with dermatomyositis kind of presentation where they'll have aches and pains in the joint. They'll be not able to differentiate between the pain in the muscle and the joint, and they will keep on complaining about the muscle pain, joint pain rather than the muscle pain. Patients will have skin rashes. The first picture shows the patient with dermatomyositis. How do we differentiate between the rash between the dermatomyositis and the lupus is that in lupus the sparing of the nasolabial fold is seen. In the second picture we can see, whereas in the first picture the nasolabial fold is also involved. So this is how we differentiate with a patient with dermatomyositis. These are again the rashes. How do we differentiate between lupus rash and a dermatomyositis rash? In lupus rash the knuckles are spared, whereas in dermatomyositis the knuckles are involved. So these are the various autoantibodies that are present in patients with various connective tissue diseases. So if a patient with SLE is there, ANA can be positive with the dsDNA, RIP, SM, SC1Q. In systemic sclerosis, centromere, topoisomerase, polymerase, THO can be present. In myositis, JO antibodies, MDF5, TIF, can be positive, and these all can have ANA positive. So just ANA positive doesn't mean lupus. It's always suspect for other connective tissue diseases also. There is something called as undifferentiated connective tissue disease, where patient has symptoms of connective tissue disease, that is either manifestations of lupus like hair loss, joint pain, photosensitivity, oral ulcers, or like rheumatoid where patient has joint pain, neuropathy, then Sjogren's kind of dryness of mouth, eyes, and scleroderma like Raynaud's. But patient doesn't fit into any criteria of any of these diseases. So, but patient will have ANA positivity. So these patients can be labeled as undifferentiated connective tissue disease, and they can evolve into further any one form of the connective tissue disease. Then moving on to next is mixed connective tissue disease. So to call a patient with mixed connective tissue disease, patient must have anti-RNP antibody positive, and patient must have Raynaud's phenomena, swollen joints, and the patient must have either one of the symptoms of SLE, systemic sclerosis, or a polymyositis, that muscle weakness, increased CPK, or systemic sclerosis kind of findings like sclerodactyly, ILD, and SLE like polyarthritis, erythema, facial erythema, lymphadenopathy, or any serositis. So this is when patient has one or more symptoms of a connective tissue disease, that is when we call it as mixed connective tissue disease. So when a patient with joint pain presents to you, always think about the associated conditions, like if patient has arthritis with systemic features, that is, patient if has arthritis with systemic features, always consider adult onset Still's disease, SLE, or vasculitis. Arthritis plus skin conditions, consider psoriasis or dermatomyositis, lupus. If arthritis plus enthesitis, consider spondyloarthropathy. Inflammatory back pain with arthritis, consider angstpon. Again, arthritis with vasculitis, consider any form ANCA-associated vasculitis. Arthritis with eye involvement, again consider rheumatoid, spondyloarthropathy, vasculitis. Again, if patient has arthritis with any ENT involvement, consider vaginous granulomatosis. Arthritis with lung involvement, consider SLE, vasculitis, dermatomyositis, systemic sclerosis. If arthritis is present along with renal involvement, again consider vasculitis, SLE, and if patient has arthritis and CNS involvement, consider lupus or antiphospholipid antibody. Thank you.
Thank you. It's a wonderful lecture. She tried to cover almost all areas. We will take one or two questions, if any. My question is, if patient is having HLA-B27 positivity, do all patients develop ankylosing spondylitis?
No, sir. Not all. Few can develop frank spondylitis.
What ANA test will you prefer, whether it is ELISA or immunofluorescence?
Immunofluorescence is standardized, sir, more than ELISA.
ELISA will be required for follow-up or what?
No, sir.
It is
Immunofluorescence, there is, even for the classification of SLE, they have specified that ANA by immunofluorescence is standardized. ELISA is almost not used.
And then when to do complement test?
When you suspect lupus, to see for the disease activity, always do complements. Low complements will suggest high disease activity of the patient.
Yeah, we will conclude this session. This is a big area she tried to cover in such a short period of time. ANA, what some conclusions are, ANA is a screening test and that should be coupled with clinical picture or additional tests. There are diagnoses that requires understanding of the basic histopathology. At the same time, thorough history taking is most important. And you will have to take into consideration frame during which patient has developed all these symptoms. One thing is certain, never jump to the diagnosis, you may be wrong. So with this, I conclude this. I congratulate Dr. Paramkriti for a wonderful lecture. Yeah.
Thank you, Dr. Shruti. I also thank Dr. Uday Pathak and Dr. Ajay. I hereby request our honorable chairpersons to felicitate our honorable speaker with a memento and a floral bouquet. I call the volunteers. The volunteers, please volunteer for the presentation of the bouquet at the auspicious hands of our chairperson to our honorable speaker. Chairpersons, be there on the stage. I request our Honorable President Sir to come on the dais to felicitate our chairperson and the other chairperson, Dr. Chaudhary. Thank you all. Now we proceed to our second lecture by Honorable Dr. Roy Patankar sir. I call Dr. Roy Patankar sir on the stage, and the topic he is going to discuss with us is LAB 2050. And for this session, we are having chairpersons, Dr. Sunil Malgavi sir, please occupy the dais, and Dr. If Sudhanma Pathak is there, please come on the dais. I hand over the mic to Dr. Malgavi sir and Sudhanma for the formal introduction of our honorable speaker.
Good morning, friends. Good morning, friends. I am very much privileged that you have called me to chair the session of my friend, Dr. Roy Patankar. We know each other from 1991. He is a very good friend of mine. He is very famous surgeon, international figure. He is practicing in Mumbai. He did his MS general surgery from KM Mumbai. Then he had been to UK for GI. He did his GI PhD in GI surgery. He is having his own hospital, Jain Hospital in Chembur, Mumbai, which is a multi-speciality hospital and big. He is GC member of ASI India. Thank you.
Thank you, Dr. Malgai. It's a privilege to be here speaking to you on this dais. I have two disclosures. एक तर मी मूळचा सांगलीचा आहे. My father was from City High School, so I consider myself to be part of Sangli Miraj. And the second disclosure is I am not an intelligent doctor like Dr. Param Shetty, so I have no classifications and very busy slides to show you. You know, my slides on? Slide correct करता माझ्या? मला हाच माईक द्या. स्लाइड चालू करा ना. So my topic today is laparoscopy 2050. Where was laparoscopy when we began our career in 1990, when I started doing laparoscopy, to where I am today and where I think I will be in 2050, provided I live to that time. Yeah? No, correct. So, I think it's easier doing a laparoscopic surgery than getting a LCD projector to work, especially in a meeting. Thank you. In the words of Shushruta, can we have this tube lights turned off? Tube light band karana ya. Thank you. There can be nothing more magnificent than the art of alleviating human suffering. So currently, whether you are a busy gastroenterologist or a surgeon, you have so many new technologies and so many new weapons. You are a bit like this, deciding which weapon to use for which disease. I don't know, some of the youngsters will not have heard of this, but when we were young, a long time ago, we had something called Star Trek. And Star Trek, this is Captain Kirk, and he said, my God, Jim, we can't leave him in the hands of 20th century medicine. Those butchers will use needles and knives and cut open his belly and chest. It's still the dark ages. You have no idea what those barbarians will do. So this is pretty much where I was when I finished my MS in general surgery in 1990 from KEM Hospital. And there was not much laparoscopy available in India. I had to go to the United Kingdom to do this. The first documented incidence of a laparoscopy was in 1901. Look at Dr. George Kelling, no gloves on the hand, local anesthesia. He's putting a scope in the abdomen of a person with tuberculosis in the United States. Much to the humiliation of general surgeons, the first laparoscopic appendicectomy was actually done by a German gynecologist. I'm sure no surgeon wants to admit this, but the gynecologists were ahead of surgeons in that time. The flip side of that was this was considered an unethical operation, and Dr. Kurt Sem's degree was suspended for 1 year by the German Medical Council. It took Philip Murray and many other people in the rest of Europe to take up laparoscopy to allow Kurt Sem to come back into medical practice. Philip Murray in 1987 was the first documented laparoscopic cholecystectomy in France, but what is now proved has only once been imagined. So what was considered unethical today has today gradually become the gold standard. And this is how we have moved, right from the time of laparoscopic cholecystectomy. We are now doing laparoscopic liver resections, esophagectomies, and the future is very, very different. So these are various things that we can do. I'm going to give you a glimpse of what we can do. This is inguinal hernia. I can't remember when I did my last open inguinal hernia. We do on the average about 150 hernias a year, and I think maybe 2 or 3 of these will be open hernias when the patient is not fit to undergo a spinal anesthesia or a general anesthesia, because whoever has a pulmonary complication we do under spinal anesthesia, but almost all hernias are now laparoscopically, at least in our center. Particularly for bilateral hernias, for recurrent hernias, for elderly, typically we will discharge the patient the same evening or the next morning latest, and we expect the patient to return to work in 3 days. This is not because of the skill that we have, but the basic, because it is much less invasive than making an open cut to put in a mesh. So we cover all the hernial orifices, surgery, and we discharge the patient within 12 to 24 hours, depending on how long it has taken us. Deep perforation, free gas under diaphragm. This is the surgeon's bread and butter in emergency. But unfortunately, this organism, H. pylori, came about. We started knowing about it, getting better treatment, and surgeonच्या पोटावर लाद बसली, H. pylori. Still, we do get patients of deep perforations. And I remember early days of my career, anesthetists would tell us, high-risk patient, elderly patient, please do open. Now my anesthetists are after me that you have a high-risk or elderly person, please do a laparoscopic surgery under general anesthesia. We do want open surgery, we do want pulmonary complications post-op, and look at the kind of wash you can. This patient had come to us after a 4-day history of abdominal pain, and you can see extensive contamination. It's as if the surgeon's eyes are entering the abdomen, allowing you to give a wash not only in the pelvis, interloop, or the liver, or the spleen, and suturing the perforation actually is the smallest part of this operation. Many times I allow my fellows to close the perforation, but I give the wash myself. But because this is the important part of the operation, and that is what reduces the morbidity. So this is how the wash and the perforation is done. I'm not going to show all my videos to you, just giving you gastrojejunostomies. Again, once upon a time, pyloric stenosis has now become unusual. We do mainly GJs for advanced malignancies when we do a palliative lap GJ. We have also now started doing endoscopic GJs, but that's scope for another lecture. I'll not show you this video. Coming on to the more unusual things, this is a young girl of 14 who came with a large diverticulum of the esophagus with a achalasia cardia. Normally, 10 years ago, I would have done a thoraco-abdominal laparotomy. From the left chest, I would have resected. This diverticulum is about 8 centimeters above the cardioesophageal junction. But you can see the kind of magnification you get in this. You need endoscopic skills and you need laparoscopic skills, because during laparoscopy, I am putting an endoscope into the esophagus, confirming where my lateral border is before I disconnect and divide the diverticulum using staplers. So newer technology is made life much simpler for the advanced minimal access surgeon, like you can see being shown here. So this is esophageal diverticulectomy. Duplication cyst, another unusual thing. A 21-year-old lady came with a large mass in the epigastrium, which was cystic, attached to the stomach. And you can see I am dissecting, you see the left lobe of the liver, but this would have been a laparotomy and a partial gastrectomy. This is what you do. Patient usually can be sent home within 48 hours. So as you acquire better skills, as technology gets better, your indications keep expanding. I think gallbladder and appendix and hernia is less than 50% of my practice today. 10 years ago, it was 90% of my practice, and I'm sure in the years to come, it will be 20-25% of my practice. This is how a esophageal duplication cyst is done laparoscopically. Coming on to the chest, I think part of my earlier training was open chest surgery. We used to do a lot of pneumonectomies, bullectomies, both for malignancy as well as for tuberculosis. And it can be quite a major challenge. So this is a patient who has a large bulla. This is what we call vanishing lung syndrome. It's due to alpha-1 antitrypsin deficiency. Patient develops multiple bullae in the chest. They recurrently rupture, causing pneumothorax, and patient tends to have multiple ICDs put at different times. So what we're doing, this is all the adhesions of the previous ICD site where the bulla is adherent to the chest wall. So what we do here is what we call lung reduction surgery. We do a thoracoscopy, put a scope into the chest under one lung anesthesia, and do a peripheral stapling of the lung to reduce the volume of the lung, to remove all the peripheral bulla in this situation. After that is done, we do what is called a mechanical pleurodesis, because this is an autosomal recessive condition which is going to progress. However good you do it, 5 years down the line, new bulla will form, another will rupture, will cause pneumothorax. So we want the lung to come and stick to the chest wall, which is why we do a mechanical pleurodesis. Now, one of the problems of having a thoracoscopy is that the lung can leak air. So we have many, you see the staple line that I have, and I'm putting what is called tissel glue. It's a special glue that we put on, and it doesn't cost much. It costs some 8,000-10,000 rupees. But if you have a patient who has an air leak from the lung, it's going to take you 3 weeks to pull out the ICD. Huge amount of morbidity is involved in this. So these are multiple things that are now available to actually decrease the morbidity of surgery. As I tell my fellows, the cleaner and gentler the act of the operation, the less the patient suffers, the smoother and quicker is convalescence, and the more exquisite is healed wound. I worked for some time with Dr. Udwadia. And one of the things he has told me is stuck in my memory is the best post-operative care is what you do on table. Spend that extra 10 minutes taking care of the minor things on table, you will not have post-op problems. And I believe that is so true. I think Dr. Desai is here, who does a lot of oncology, and Miraj Sangli, but this is where we are going. The smaller liver metastases, less than 1 centimeter in size, you can use a laparoscopic ultrasound probe to pick them up. And it's now routine practice in our centers. Before I do a Whipple's or a total gastrectomy, I will routinely do a laparoscopy to make sure we are not missing small metastases, because this makes the patient inoperable. I would then give him neoadjuvant treatment and then take for surgery later. This is where we are currently doing. In colorectal surgery, I think there is not much controversy. I think it is as good as open colorectal surgery. We have a lot of work a lot of my work is lap colorectal, and I'll show you some of the things that we have done and published on this. I know Dr. Desai does a lot of CA rectum, but you can see the vision that you can get. Imagine a fat patient like me, a male patient, narrow pelvis, lots of fat. You don't get this kind of vision in open surgery. You can see me going to the root of the IMA, taking out all the lymph nodes, and this is the kind of vision that you can get, and oncologically it is as good as you can do with open surgery. CA esophagus. I think one of the things that we used to do is to do a 3-field esophagectomy. Laparotomy, then open the chest, open the neck, and do anastomosis in the neck. This is what we do. This is the azygous vein. Nowadays we are doing azygous sparing, but you can also clip the azygous, take out all the lymph nodes along the azygous, do the thoracic mobilization of the esophagus thoracoscopically, removing all the lymph nodes. Then laparoscopically we make a stomach tube, and the only incision will be in the neck, where the whole specimen comes into the neck, and we do a neck anastomosis for these patients. So this is what my patient was 20 years ago. And this is what my patient is today. 3 small holes, 10 millimeter, 12 millimeter one, and 2 of 5 millimeters. So this is where we are going. There's a famous saying, God put the pancreas in the back because he didn't want surgeons messing with it. So this is a patient who had a distal pancreatic tumor, a cystic tumor of the pancreas, which typically comes in the body and tail. This is a young lady of 35 years old, picked up on a routine ultrasound for back pain, and you can see a large cystic mass in the pancreas. It is important that this doesn't need lymph nodal dissection. We routinely do an endoscopic ultrasound, do a FNA, do cytology, do tumor markers. We knew that this was a cystic tumor which had malignant potential, but there are no nodes to dissect in this. What we do here is to do a spleen-preserving distal pancreatectomy. Remember, the splenic artery and vein run just above the pancreas. We separate this off the pancreas, and then you can see me actually excising and removing this tumor. All you do is make a 5 centimeter Fannin steel incision or a McBurney incision just to deliver the specimen out. If you have an elderly lady, I would actually open the pouch of Douglas transvaginally to extract the tumor. So in a CA rectum, I open the pouch of Douglas from below. So abdominally, she has no scars except the port sites that you see. So this is where we are going. The top left picture is a picture from St. Thomas's Hospital, London, where the theatre was. Why is it called a theatre? Why is the operation theatre called a theatre? Because it was where surgeons would have people watching them. There were many theatres in England had galleries. The spectators would go to the first floor and watch the surgeon in the center. And this is where we are slowly coming at in this. I think every surgeon today has to be an endoscopist. There is no question. If you are a minimal access surgeon, you need to know endoscopy. And one of the problems we face is seeing these small nodules when you do a diagnostic laparoscopy before doing a Whipple's or a gastrectomy. So we are not sure whether this is burnt out or what it is. There is a concept called narrow band imaging, which all the endoscopists do using blue light endoscopy. And we now modify this. This is a slide from 2009, my first patient that time. And we can see me doing a narrow band laparoscopy. And this is how you will see the neovascularization to determine on table whether this is an inflammatory pathology or a malignant pathology. We now have magnification endoscopy coming. I'm sure Dr. Kulkarni is here. Many endoscopists have started doing FICE, magnification endoscopy, chroma endoscopy, and I'm sure that the same things are going to come into laparoscopy practice very soon. But you have to make a beginning somewhere. I often hear from people that in my town there is not much scope for this. Believe me, I work in the northeast part of Mumbai. In those days in 1990, all patients would go to South Mumbai for major surgery. All the affording class, the complicated class would go to South Mumbai. That's where Jaslow, Bridge Candy, JJ were. Now that doesn't happen. I have people coming from the whole of Maharashtra and Karnataka and Gujarat to me. So develop a center of excellence. You always begin small and then build yourself up. It has many other implications, not only about doing malignancy. So this is a patient who had a GI bleed. What I have done is I've done laparoscopy and inserted my gastroscope from the jejunum and going toward the pylorus. You can see the active bleeding. The patient already had a mesenteric angio. This is the pylorus seen from the duodenum side. I'm putting my scope reverse. This is a NJ tube that my anesthetist had put. I'm pulling the NJ tube down into the jejunum because we wanted to feed this patient. This patient had turned out to have an indeterminate kind of high-grade lymphoma. But you see the number of the whole small bowel is full of these nodules, which turned out on immunohistochemistry as a high-grade lymphoma, which is very poor prognosis. So these are many applications of laparoscopy. So in case you start doing both laparoscopy and endoscopy, this is where the future will take you. This is not a pregnant lady. This is a lady who came to us with a walled-off pancreatic necrosis. You can see the CT on the right side. The whole small bowel is completely crushed, and these patients, this is my first patient which I did in 2005. I'm doing an endoscopic drainage. My colleague, Dr. Miraj IMA did this. He's doing this cyst into the stomach. He puts a balloon, a pretty routine. I think in 2021 this is routine. In 2005 when he first did this, it was not so common. So we drained about 5 liters of fluid into the stomach and then took this patient up for a laparoscopic necrosectomy. So a lot of things have changed. This is the necrosectomy picture. This is inside the bed of the pancreas. You can see the stents that my colleague had placed prior to my laparoscopy. So pretty much what limits you is your imagination. Marathi एक शब्द है सत सद विवेक बुद्धि. As long as it applies to your surgical logic, you have the technical skills to do it, and you have the infrastructure to back you. This is where the future will be. You can see the amount of pancreatic necrosis, that we hardly do any pancreatic open necrosectomies now after this has come into being. So whether you are a family physician in Miraj or you are in Bridge Candy Hospital in Mumbai, you have to come through these phases. All of us like to stay in the comfort zone. We need to come into the fear zone. We tend to find excuses. We lack self-confidence. My patient पैसे भरणार नाही, technology मिळत नाही, trained लोक मिळत नाही, technician चांगली नसतात. Those are our excuses we make not to venture into something new. Only when we come out of that, you come to the learning zone and the growth zone. When I was a lecturer in KM, they told me big surgeons make big incisions. We had my teachers would make an incision from xiphisternum to the pubis. मोठं incision करायचं 30%, 40%. That is the index of where we are. It's now big surgeons make 4 incisions, some make only 1 incision. So this is what we started doing in 2008. This is my demonstration and live workshop we did in 2008 where we do a single port cholecystectomy. This has not caught on too much because it's technically more challenging and the benefits to the patient are limited. Only thing is you have a young girl who doesn't want scars, who's yet to be married, and we get a lot of these very rich people coming to us. A single scar like this, which is about 2 centimeters wide, and you can get, by a subcuticular suture, you get away without her seeing anything seen at all. So this is the concept that has changed. When you pick up any new passion or technology, I remember this. चलता रहूंगा पथ पर, चलने में माहिर बन जाऊंगा, या तो मंजिल मुझे मिल जाएगी या अच्छा मुसाफिर बन जाऊंगा. So I always feel that we may not reach where you want to be, but you have a goal and an aim that will take you where you are. Is this all applicable to what I am telling you? In Miraj, my mother was from Pandharpur, my father from Sangli. So I come from peripheral Maharashtra and I have seen how difficult it is. So robotics in India is always going to remain a niche area. It is expensive. I'm sure in 5 years I'll be doing robotic surgery in my center. We are already on the way of purchasing a robot. But the applicability to the vast patient is not going to happen. Unless a technology is available to 90% of my patients, that technology to me is useless. So you need to think about how to bring down the cost. We have made multiple instruments like this. We make instrument bags which cost us 2 rupees. If you can see the top, some of you will identify this as a Sense-Stick and Blackmore tube. This used to be used for GI bleed. We use this to make a retroperitoneal access. When I want to reach the kidney or I want to do RPLNDs, I use the esophageal balloon which is quite stiff. The bottom is a Malicot's catheter with a condom attached to it. This is a suction tip with an 11 number blade welded to it. So you can replace your disposable instrument by making these innovations to bring down the cost of laparoscopy. But the world is going towards telesurgery. This is what is called the Lindbergh's operation. This man is Jacques Maresco. I've had the pleasure of working with him for 6 months in Strasbourg. He was sitting in Strasbourg doing a laparoscopic cholecystectomy in Lagos in Nigeria. Broadband, controller robotics. So this is transcontinental. And my biggest fear is Sharad Desai doing a cancer surgery in Mumbai take away my practice. But that may happen in the years to come. Indianization. I work in Himalkasa every year with Prakash Amte, and the tribals there have a lot of portal hypertension because from childhood they are drinking this mahua liquor. So you have 20, 25, 30-year-olds who come with upper GI bleeds. The closest hospital is Chandrapur. They have no money. They speak Bhil Gond. They don't speak Marathi. To reach Chandrapur, half of them die. So what we have done is we have trained his son in upper GI endoscopy. He sends us the videos on broadband. We are able to report it and tell him which can be managed in Himalkasa, which have to be sent to Chandrapur by the ambulance. So we have Gadchirila, we have so many tribal backward areas where it may not be the Lindbergh's operation doing transcontinental, but certainly rural can certainly be in. So this is the old age theatre, but in future you may have an operating room with no people. The patient may be the only human being inside the theatre. You have a robotic surgeon, you have a robotic assistant, and you are a robotic anesthetist. I'm sure in my day and age this is going to happen. Coming here, I made this slide sitting here. In any conference like today, there are these various kinds of personalities. They are the stalwarts, who are mainly only in the stalls outside. They don't come inside to hear lectures. Then there are the spiritual people who spend a lot of time in the CME banquet dinners but don't attend the main lectures. Then there are the outstanding. I can see people standing outside there chit-chatting. They are the outstanding doctors. Then there are the sleeper cells. Sleeper cell is phone silent करायचं and मागे झोपायचं. And then there are teetotalers, तो फक्त चहा पिऊन गप्पा मारायसाठी येतात. And the last group, which I hope I don't face today, is people who like to ask questions. So the empires of the future, the empires of the mind. I'm going to tell you where the future of surgery is as I perceive it. This is where we are heading. We have image-guided surgery, we have 3D printing, we have Watson, your stem cells, your infrared imaging, and your robotics. This is already evident in functional neurosurgery. We have vital dyes which are given intravenously. These dyes will be taken up preferentially by nerve tissue, and the patients, for example, you can have an awake patient while the neurosurgeon is operating on them, and actually to make the patient speak or do motor functions while a certain part of the brain is being resected. So this is what is color-coded surgery. We are using this in CA rectum surgery when we do ICJ. I'm not going to play the videos. See, when I teach my fellows, I tell them for an anastomosis of an intestine to get joined is like a marriage. You need two things. You need to give the marriage nutrition, and you need to give the marriage lack of tension. The same thing applies to the intestine. If the two ends are brought together without tension, and there is enough blood supply as in nutrition, that marriage is going to be successful. Lack of tension that we see on table. How do I know the vascularity is good? We use what is called indocyanin green routinely in practice, and that helps to tell us whether that is there is adequate vascularity of the anastomosis. So this is just some of the videos that, and these are videos from our center, they don't play, but you can see the green color of this that confirms to you that there is adequate vascularity in ICG, and you are sure where it's going to happen. So this is what we are already doing. We have what is called near infrared imaging. The ICG dye costs only 1,200 rupees, and usually in one list we will use the same vial for about 10 patients. So shared cost is maybe 200 or 300 rupees per patient. It's a one-time cost of the camera, but in one patient, if I can afford a defunctioning colostomy, the quality of life improvement is enormous. What is going to also happen is virtual augmented reality and intra-op image guiding. If you see Professor Marasco's theater in Strasbourg, there is an MRI machine in the OT, not images coming to OT. So while you are operating, the MRI is guiding you, and this is particularly important when you are doing laparoscopic or robotic surgery for the liver. And I'll show you how this is actually being done. The patient's pre-op anatomy is fed into the computer, into the robot, So the robot knows exactly where the tumor is in relation to the portal vein, the common bile duct, etc. This is the Jack Marasco doing the surgery with a tab which is covered with a plastic sterile sheet. If he goes too close to the bile duct, the robot stops functioning. It will not let you cut the bile duct, it will not let you cut the portal vein that is fed into it. If manually you want to override it, there is a safety mechanism that you must remove, only then the robot will allow you to cut near the portal vein. So it keeps a 2 millimeter distance from portal vein and the biliary radical. This is how surgery will become safer. You can resect small tumors from within the liver, sacrificing minimal tissue. The concept of removing the whole right lobe of the liver may soon be gone. This is the concept of augmented reality. Soon you will have cybernetic surgery. On table, you will have these images of the resection margin. Normally what we do is send the margin for frozen section just to confirm there is no malignancy there. But this is where we are going. The surgeon will not only be a radiologist, he'll also be a pathologist, or the pathologist will have to come to OT to identify that. When I was training, we had these 3 different things: laparoscopy, endoluminal surgery, percutaneous surgery. Percute surgery was done by the radiologist. They would put pigtails, biopsies, etc. Endoluminal surgery was done by medical GI, and the surgeon would do laparoscopy. Soon, I think in 10 years, you'll have this come together, and you'll have a GI professional who will do not only GI surgery, laparoscopic surgery, he will do basic endoluminal surgery and can also do percutaneous surgery. This is where I believe the future is heading, and as a young surgeon, I still like to call myself young, is where we are going. Just see some of these new technologies that are coming. This is what is called the eye knife. The eye knife is originated by a guy called Professor Takats of Imperial College, where when you're cutting with the knife, the vaporized smoke is being analyzed to see if there is any malignancy in that smoke. If you are cutting and there is malignancy in that smoke, the eye knife will halt. That means you are cutting through cancer, your margin is not okay. You need to move your margin a little bit further away. So these are where technology may be taken. I'm just giving you a brief overview of where I think we will be. Artificial intelligence. I think our planning commission says we are short of doctors, but I think what really we are is short of algorithms. I extensively travel in the United States, and there are extensive algorithms. If you're a medical resident or a chief or a fellow, a 50-year-old obese man like me comes with chest pain, it will tell you what to do. It will say ECG, ECO, cardiac enzymes, depending on what it shows, the algorithm will tell you ICU, ward, POPD. You have no choice. You have to follow the algorithm of that institutional software pathway. So what we are probably going to have in the years to come is artificial intelligence replacing it. You have a patient of RIF pain. It will ask you what are the LMP of the patient, does she have urinary symptoms, are the periods okay, and it will give you an algorithm where to follow. पांढरे केसाचा फायदा निघून जाईल. The algorithm will replace your human experience. It's not going to completely replace it, but 90% of your work in the future will be algorithm dependent, which will cut down on medical errors. We have what is called Watson. IBM has got a computer which is currently being tested in the United States, and that every new thing that comes in literature is fed into Watson. So if you have somebody who comes with a lower back pain and tingling in the leg, Watson will tell you what to do. And this, I believe, will cut your mistakes. So you have to, as a surgeon, in whatever you're doing, you've got to make a conscious choice every day to shed the old, whatever the old means to you. Come out of your comfort zone. This is extremely important. So laparoscopic surgery is going to be a lot more just than cutting a knife that I'm seeing here. The genomics will maybe replace some of cancer surgery. I'm sure the oncosurgeons here will know a lot of this, but there is customized therapy coming with customized doses. Many times now our medical oncologist will send some tissue for genetic analysis, look for KRAS, look for wild type gene to decide whether chemotherapy will be effective for this patient. Or should he have biologics? Should he have customized treatment? That's where we're heading. So blind chemotherapy for every cancer may soon be passé. Stem cells may often be important in treating malignancy. I think I've come to about 30 minutes, so I'm going to stop here. But let me tell you, ladies and gentlemen, this is not the end. It is not the beginning of the end, but merely the end of the beginning. I'll leave you with this. मुश्किल नहीं है कुछ दुनिया में, तू जरा हिम्मत तो कर. ख्वाब बदलेंगे हकीकत में, तू जरा कोशिश तो कर. आंधियां सदा रहती नहीं, मुश्किलें सदा रहती नहीं. मिलेंगे तुझे मंजिल तेरी, तू जरा कोशिश तो कर। राह संघर्ष की जो चलता है वही संसार को बदलता है, जिसने रातों से जंग जीती है सूर्य बनकर वही निकलता है। थैंक यू वेरी मच। Can you have the lights on? Light on.
Thank you very much, sir, for such a lucid presentation. And you took just 27 minutes. 3 minutes we are short.
My
And
stopwatch said
it's-
30, so I stopped.
Yes. And always it's a pleasure listening to you. I have listened to you as an intern in 2004, as a GI surgery resident in 2009. I have seen you operate in 2011 at Hyderabad at ICON. And now it's really a pleasure to be a chairperson for your talks.
Thank you.
Now we are open for question and answers. Is there any question from the audience?
Sujay, you can have that mic.
So regarding notes, I wanted to ask I mean, in future or in current scenario, how frequently you are seeing gallbladder surgery being done transluminally?
Notes is pretty much given up across the world. We also went through period of notes. We learned from GV and did a few notes, cholecystectomies, appendicectomies, peritoneal biopsies. We trained on a pig model first, then started doing on patients. But the efficacy has waned. That's why I didn't talk about it too much. And I don't see it coming as well. But that's another reason for laparoscopic surgeons to have endoscopic skills, because as I said, we'll be GI professionals. So I think this is very, very important. I'll just give you one more word advice. To be successful in practice, I know you're new to Miraj and you're building a big practice. You need 3 things in life to be a successful practitioner. You need gray hair like Dr. Malgave. You need big paunch, and you need very large piles. Because if you have gray hair like Malgave, people think you're a wise man and they trust your judgment. If you have a big paunch like me, they think you're a prosperous man and you won't fleece them. And if you have piles, you have a permanent look of pain on your face and the patient feels you're concerned for him. So learn these 3 things, you'll go far in Miraj.
Any other question? Somebody can give mic there, or can you come out here?
I was hoping that laparoscopy 2050 prashna yenar nahi.
Meanwhile, I request Pailwan brothers to come in the hall
Hello?
for the arrangements. Pailwan brothers.
Hello. Wonderful presentation, sir. Thank you so much for coming. Sir, I would like to ask how far do you think we are away from primarily AI-driven robotic surgeries?
I think it's going to come, and I have no doubt seeing what they're doing in Strasbourg. I go to Strasbourg every alternate year, and there is not only MRI machine, there's a robot. The robot will tell you or prevent you from making mistakes.
Yes.
So I'm sure in the years to come, how long it comes is going to take. Basic is technology comes with a cost. And I think, as I told you, any technology, if I can't apply it to 90% of my practice, that technology to me is useless. I don't want to be a rich man's surgeon. I want to do volumes, and I want to be able to treat the whole spectrum of patients who want to come. But I think AI will come in clinical medicine. In a GP's practice, in ICU, in a post-op round, I think AI will take this individual judgment, this advantage of gray hair will go away. I think AI will tell you what to do and what protocols you need to follow. And the years to come, I think medical councils will accept those as appropriate. They currently don't do it, even in the United States. But in the United States, you need to follow a clinical algorithm or what your institutional algorithm tells you. There is no independent variation. If you have perforative peritonitis in Mayo Clinic, believe it or not, in a non-immune suppressed patient, it is ciprofloxacin and metronidazole in Mayo Clinic. And that is the institutional protocol. If you cannot use anything different unless the man is on steroids, he's immunosuppressed, or you have a culture which shows something else. I think India काल जो मला medical rep भेटून गेला तो चांगला antibiotic असं असतं.
Okay. Thank you, sir.
I have a question, sir. With too much of AI, too much of data, and too strong a connectivity, maybe after 30 years, will a peripheral surgeon will be reduced to more of what we give an analogy like there are big servers and peripheral clients. So already it's happening in pancreatic cancer where there is too much centralization, centers of excellence operating too many volume, and those with low volume are not getting much of hands-on. So it reflects in the results also.
So slowly it will occur in all realms of laparoscopic surgery, because I see in future, maybe after 20 years, there will be proctorship, all data connected to servers and big centers proctoring the students.
My thinking actually is the reverse of you. Today you have centers of excellence in different parts of the country. You have a urology center in Nadiad in Gujarat, which is 100 kilometers from Ahmedabad. It is probably the best urology center in India. You have Dr. Palnivelu in Coimbatore. People from Mumbai go to Coimbatore for surgery. You have Nageshwar Reddy in Hyderabad. You have Randhir Sood in Medanta. It is centers of excellence. See, Nadiad as a town is smaller than Miraj. They have a 250-bed kidney hospital. They do on the average 40 renal transplants every month. There are 60 urologists and nephrologists working there. So my thinking reverses yours. Yes, it is volume driven. I think if you're doing less than 15 Whipples a year, stop doing them. You work in a center and start developing your own practice. But that need not be in bigger centers and bigger cities. It is for young people like you to develop volumes, to become centers of excellence in your city. Why should work go there? Why should we big server and small server? Why should, I see a time when Sharad Desai can do a surgery in Mumbai. If he is so good on HFN, why can't he do a robotic surgery in my center? So it could be the reverse. What depends is you, your training and your brand, how you build your brand. And that's where we lack as surgeons. In cities like Mumbai, the corporate hospitals will govern. That's why individual doctors, individual hospitals must build their own brand in order to take on these corporate hospitals. Only then you get volumes, you get teaching programs, you get fellows, you get publications. That's when you get peer approval. It's no good saying कि मी मिरज में 200 सर्जरी महिन्याचे करतो. तू पब्लिश किती करतोस? तू प्रेझेंट किती करतोस? तू ऑडिट करतोस का नाही? मग बोलूच नकोस. So as young people, you have to be able to come onto the national stage to attract that work to you and develop centers of excellence. So my thing is reverse. If you are got the motivation, determination, you acquire skills. I still spend at least 15 days a year in some center acquiring a new skill. I may or may not be able to do it in my center, but 15 days a year I have to go and spend time somewhere in a center of excellence. India, abroad, wherever. I wanted to learn thoracoscopy, I went to France, a high volume center. In 7 days I saw 15 lungs. So go, train yourself. Now life has become simpler to travel. You have YouTube, you have broadband. It's not like when we trained in 1990. So in fact, my thinking is reverse is yours.
Yes. Thank you.
Okay.
So, thank you, sir, for this section. And nice question answers.
बायकोला दाखवायला काहीतरी घेऊन जाऊ दे ना.
नक्की.
Sir, please be on the dais for a moment. I request our honorable chairpersons to felicitate our honorary speaker, Dr. Patankar sir. It was indeed a very beautiful lecture, excellent kind of a teaching and excellent kind of a message which he has left to the young generation also and for us also. Aditya. I request our President sir, Dr. Chadda sir, to felicitate our chairpersons, Dr. Sunil Malagave and Dr. Sudanva. I call upon Pailwan brothers for the arrangements on the stage. Pailwan brothers, please hurry up for the arrangements on the stage. We are going for the formal inaugural function.
It's my pleasure to inform you that there will be one entertainment program at the afternoon. कोरोनाच्या कटू आठवणींना गुड बाय करत आनंदी व मन ताजेतवाने करणारा प्रेरणादायी कार्यक्रम झी मराठी हास्य सम्राट आणि हे तर काहीच नाही फेम प्राध्यापक अजित कुमार कोष्टी यांचा कार्यक्रम हसवणूक हसवणूक दुपारी ठीक 4 वाजता. तर सर्वांना विनंती आहे की आपल्या मित्र परिवारातर्फे आपण उपस्थित राहून या कार्यक्रमाचा आनंद घ्यावा. धन्यवाद.
नाही ते जाणार आहे नको म्हटलं तो मग सतीश पत्की आणि ते मोहन मगदूम ह्या दोघांना वरती बोल. श्रुतीला बोलवायचं श्रुतीला बोलवायचं वरती काय गरज नाही. दोघं आहेत बस आणि तुम्ही आहे कुठे. हॅलो. Now we go for the inauguration program. The honorable guest who is here is our senior most physician, our guide, our PG teacher, Dr. Soltu sir. I request our honorable president sir, Dr. Chadda sir, to escort Dr. Soltu sir on the dais. I request our honorary secretary, Dr. Riaz Mujawar sir, to escort Dr. Takle sir, our second guest of honor today. I request Dr. Mohan Magdum sir to be on the dais. And also I request Dr. Satish Patki sir to be on the dais. For this program, we have a MMC observer, Dr. Sanjay Qureshi sir. Dr. Sanjay Qureshi sir, please come on the dais.
प्रत्येक कार्यक्रमाची सुरुवात आपण दीप प्रज्वलनाने करत असतो. अज्ञानाच्या अंधकारावर प्रकाशाने मिळवलेला विजय हे त्याचं द्योतक आहे. शुभम करोति कल्याणम आरोग्यम धनसंपदा शत्रुबुद्धी विनाशाय दीपज्योती नमस्तुते. मी सर्व मान्यवरांना विनंती करतो की त्यांनी दीप प्रज्वलन आणि धन्वंतरी पूजन करून या सदरच्या संयमीची सुरुवात करावी. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our elegant spirit and realizing our responsibility as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly in the Committee of Nations. Long live IMA. कैलासवासी लता दीदींच्या गीताप्रमाणे ज्योत से ज्योत जगाते चलो, ज्योत से ज्योत जगाते चलो, प्रेम की गंगा बहाते चलो, प्रेम की गंगा बहाते चलो.
I call the Savini.
I request all delegates to stand. We are going for the IMA prayer.
If you are having souvenir with you, just open the page number 8 and you can follow me with the IMA prayer. May everybody be happy. You can repeat. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Jai Hind, long live IMA. Thank you very much.
Our honorable guests can occupy the dais. Because we are meeting after a gap of nearly 3 years, there ought to be some good incidences and ought to be some bad incidences. And the bad incidences which took place during the last 2 years, we lost so many of our dear colleagues and seniors. And some of the names which have been printed in our souvenir, we lost Dr. P.K. Pradhan sir, our senior most physician. Immediately within months we lost Pradhan madam also. We lost our eminent speaker, our philosophical guide, Dr. Eric David, who was working as an associate professor in Oneless Hospital. I lost my dear friend, pediatrician, Dr. Rajesh Shah. We lost Dr. Arun Thansabkar, ex-director of Oneless Hospital and an anesthetist. And recently we lost Dr. Vinay Arvatgi, an orthopedic surgeon and a faculty at our Bharati Vidyapit Medical College. Apart from this, there may be few names which I must have missed from the list. But this IMA forms a platform to pay condolences to all those heavenly souls who have departed from us and are no longer present in this IMA hall. But I definitely know that their souls are with our IMA and they have done a tremendous contribution for the long living of IMA. And above all, as we know, on February 6th, we lost our legendary Gana Kokira Lataji Mangeshkar. In the memory of Lataji Mangeshkar, I have put a quiz in the souvenir, and there are about 25 questions which are printed over there. You can answer at your leisure. That can be a kind of condolence or that can be a kind of tribute to our late Lataji. So, in memory of these departed souls, again we need to stand for a few seconds for paying gratitude and for paying condolences to the departed souls. Thank you, everyone. Please sit down. Now I request our Honorable President, Dr. Chadda sir, to felicitate our Honorable Eminent Professor, Dr. Sotu sir, with a floral bouquet and a memento. As a part of culture of Miraj, the sitar culture of Miraj, the classical legendary sitar is being presented to our Honorable Professor, Dr. Sotu sir. It's indeed a privilege and a big honor for the IMA that we have Sotu sir with us as a chief guest for this function. I now request Dr. Chadda sir and Dr. Riaz sir to felicitate our other chief guest, Dr. Takle sir, Dilip Takle sir. Dr. Riaz sir, please hand over the Honorable Sitar as a tradition of Miraj. I request our volunteers for floral bouquets to our eminent guest speakers who are here on the dais. Dr. Chadda sir, please welcome Dr. Satish Patki sir with a floral bouquet. I request Dr. Riaz sir to felicitate our another guest speaker, Dr. Mohan Magdum sir. And also the occasion to thank our MNC observer, Dr. Sanjay Qureshi, who is very much part of our Miraj IMA. Here we complete our floral bouquet program. Now I request our Honorable President sir to give a presidential address to the August gathering.
Respected Dr. Shodru sir, Dr. Takle sir, and today's our guest speakers on the dais, Dr. Satish Patki and Dr. Mohan Magdum, Secretary Dr. Riaz Mujawar, and our MMC observer, Dr. Qureshi, and respected IMA members. I am very happy to have you here on this 39th refresher course. Last couple of years, we could not hold any meeting because of the COVID. And after this big lapse, I am very happy all of you to be here. Now, speaking about our chief guest, Shodru sir, and Dr. Takle sir, the words will not be sufficient. We were lucky enough to learn under them, and Dr. Shodru sir, very punctual, devoted, he was a real missionary. Many times he used to be there before the intern houseman reaches to see the patient, and he was a sort of a walking medicine. His every word used to be useful to the PG students and almost everybody. I remember when I was intern, I brought my father to Wanless Hospital. He was pulseless, and he saved my father. It was exactly 1981. That time I was intern. And he has saved so many lives. Dr. Patankar, who was here, he was talking a lot about the progress made in the field of medicine, robotic surgery. But during the era when there was no ultrasound, no CT scan, no MRI, his inspection, palpation, percussion and auscultation that was much more superior than any medicine, than any equipment or any device. And in that era, he worked and he saved a lot of lives. He was like a god to the patients, not only to the patient, but to the PG students. Takle sir also, we work under them. He is a good teacher, down to earth. And what I have noticed is during my tenure as a president, whenever you call him for meeting, he is present before anybody else. He is a guide. In the cases of difficulty, he guides us. And even though he is so senior, I mean, he is always available for the consultations. My friends, executive committee members, they took a lot of pain to make this program as success, including Pailwan brothers. I thank all the IMA members, executive members from bottom of my heart. Thank you very much. Thank you. And I also thank Dr. Chute and Dr. Mani for doing an excellent job. Thank you.
As every year, we have a souvenir prepared for us. Already the souvenirs are in the bags, but it has to be formally released on the dais. I request the souvenir committee members to be on the dais, and at the hands of our honorable guests, would like to officially release the souvenir on this auspicious day. The souvenir committee consists of Dr. Praveen Kulkarni, Satumya, Dr. Sudanova, Dr. Prabha Qureshi, Dr. Prakash Amnapure sir, Dr. Rahul Gosavi sir, and Sudanova is already there.
आपल्या मिरज आयमेला साहित्याची सुद्धा एक अद्वितीय अशी परंपरा आहे. आपल्या डॉक्टरमध्ये छुपे असलेले काही लेखक आहेत, कवी आहेत, त्या सगळ्यांचे लेख या सोव्हिनियरमध्ये इन्क्लूड आहेत. या ठिकाणी सोव्हिनियरचं प्रकाशन सोहळा संपन्न होत आहे. डॉक्टर प्रवीण कुलकर्णी आणि सोव्हिनियर कमिटीचे खूप खूप अभिनंदन. आणि माझे सन्मित्र डॉक्टर चिदानंद चिवटे यांनी सांगितल्याप्रमाणे यामध्ये कैलासवासी लताजी मंगेशकर यांच्यावरती एक क्विज आहे. आपण ते सोडून आमच्याकडे उत्तरं पाठवून द्यावीत. कुणाचं सगळ्यांची उत्तरं बरोबर येतील त्यांना आम्ही आयनेतर्फे बक्षीस देऊ. धन्यवाद.
कुठल्या तरी पानावरती उत्तरं देखील छापलेली आहेत. कृपा करून ती हुडकायचा प्रयत्न करू नका. प्रामाणिकपणे सोडवायचा प्रयत्न करा. धन्यवाद. Now I request our honorable chief guest Dr. Sotu sir to address the conference.
Dr. Chadha, President of IMA, other members, organizers, all the people who are assembled here, and the speakers. I was just came in half an hour ago. Dr. Patankar was speaking. Looking to his lecture, I felt it is a time for us to retire, because things have changed so much, which we have not heard. And just to imagine what is going to happen in another 10, 15, 20 years. You are sitting in the room, possibly in the house, robotic surgery, telemedicine, all these will come in. I have completed almost 50 years. Now I imagine what we were practicing earlier. As a student, what I learned and what I taught in the college as a teacher and what I am practicing, There are a lot of changes taking place. There is always a controversy about the investigation, what investigation do, when to do. But things these are complementary. Clinical medicine and the investigation are complementary. They help each other. I remember a time in a mission hospital, there used to be what is called a list of surgery next day. That used to, there are column where diagnostic laparotomy. What is the meaning of it? It is the ignorance of the diagnosis. So we could not do it, so we'll open and see. That is no more available now. Things have changed. I remember we used to tell any pain in the abdomen, a peptic ulcer and appendix. Nothing more than that, because the investigation facilities are also minimum. But over the years, the new technologies, sonography and different modalities of investigations have come. There is a lot of criticism about the investigation. See, just to have a sonography, there is so much of money. But they do not realize a person who is without diagnosis will remain 8 days just trial and error because we have no other modalities. But with sonography, I remember we used to gallstone means it has to be fatty, otherwise gallstone should not be diagnosed. That was a way we were thinking, but that is no more true. So it was a learning process for us. So these new gatherings where new technologies, new methods, new diagnostic avenues will definitely help us to understand. But at the same time, cost is going up. Not only for the treatment, even the medical education has become very expensive. I was just talking to a few of the collector who is a doctor himself here. I was just asking him, why did you change from medicine to the IAS or administrative? He just laughed, he did not require. It is obviously people feel either it is too difficult to practice the way things happen now, or this IAS may be better. Many doctors come here in the administrative service, I have seen. So things are changing. Earlier, I remember now our education was completed in 5 years course, 20,000, 25,000. That just you cannot imagine. Just a visit will cost you 20, 25,000 now. One of the student, he was taking routine EKG for everybody. I just, why are you doing it? There is no indication. Sir, I have a bank loan of this much, and if I don't pay in time, I will be in trouble. So I realized it is difficulty. This is a problem always. See, things have changed. Now this when I was in Madras for a training in cardiology for 6 months. It is a big cardiology ward wherein there are cardiac cases are admitted. It was a central government hospital. During a round, he will examine the heart, and I remember a case where this patient the patient had hemiplegia. The cardiologist who I was accompanying him, he examined, then he told me, you will look into this case, because he did not know much about neurology. So things are changing. Tomorrow, if anybody asks me about gynecology, we are taught basics in the college MBBS study. Once you change your profession to different branches, your attention is going to be concentrated on more on a particular system. That is why things are changing and we have to change. Now question is, there was a lot of controversy in the past when a CT came in the 80s or 90s. There was a lot of discussion among the neurologists whether we should do all hemiplegics, should do CT or not. There were for, some are against it, because cost was very high at that time. But now we realize it is very essential for doing all neurological cases like hemiplegia, because some small hemorrhage may mimic thrombosis. So unless you have a definite diagnosis, the plan of treatment will change. So that's why this controversy gradually disappears. I just remember now what is going to be 20-30 years. I may not be there at that time, but that is we escape from this reality. But all the things, what I see, this is one side of practice. Practice is also changing. We are facing a lot of problems when a patient comes to you. A serious patient has come and conversation or understanding with the patient, talking to the patient is very essential part, because they must know what is what we are going to do, what is the outcome. Many times it so happens, you talk to them, at the end of conversation, ask him, तुम्हाला समजलं का सगळं? Patient serious नाही ना, काय होत नाही. In spite of telling his pulse is low, he is not conscious, he is not going to survive, it is difficult. But ते विचारणार तुम्हाला काय dangerous नाही ना? This is what it is. So sometimes you do not understand what they have understood. After a few days, somebody else comes. He will ask, काय झालं त्यांना? परत repeat everything, it's same thing. This is what is happening. Many times, all of you know, drugs are available to doctors at a cheaper rate, hospital rate. For example, low molecular heparin and streptokinase. When you give nearly 50% of the cost is available to doctors. I remember I used to do that. Whatever hospital rate used to come, I used to pass on to the patient. One of the patient asked, "Sir, एवढं कमी ना तुम्ही देताय, हे fake drug आहे का?" What answer you have? That means you are trying to do something good. This is what the reaction is. Other person said, "कधी दिलंच नाही तुम्ही." Then how are you going to convince him? Since then I started doing. The vial is to be broken in front of the patient, and vial is handed over to the relatives who is accompanying him. So these are things are changing. Once I had gone for a meeting, I had a call from the hospital. There is a patient who has come, who is dead on arrival. The relatives were insisting that you should take him inside. Then he is already no, you try. See, this is how things change over the years. I think everybody has to go through this problem in different ways. My personal advice to everybody, whenever a patient comes, seriousness, condition, cost has to be discussed initially so that they should not blame you later. I'm also happy to know some of our students have done excellent in their field. Dr. Patki is one of them. Dr. Khadilkar Satish is the Dean of the Mumbai Hospital. Oak, he is one of them. And always I remember these people have done so excellent. It is proud to be a teacher of the students. And I always felt good student, resident is a good teacher to a teacher, because he is reading continuously for his exams, and teacher may not be that up to date. So that is why these are the good teachers to the teachers. So I am very happy to be here. There are a lot of new faces for me, and some of them are my students and colleagues. So I wish the function success, And I thank the organizers calling me to be a chief guest on this occasion. Thank you.
Hello. Thank you, Sotu sir, for the advice you have given to all of us. I now request our Honorable second Chief Guest, Dr. Takle sir, to address us.
Good morning, all IMA members. Today's Chief Guest, respected Sotu sir, our IMA President, Dr. Ajit Chadda, Dr. Riyaz Muzawar is our Secretary IMA Miraj, Dr. Patki sir from Kolhapur, Dr. Mohan Magdum, endocrinologist from Pune, Dr. Sanjay Qureshi, our MMC observer, and all the IMA members and executive committee members. First of all, I thank all the executive members as well as President and Secretary for calling me as second guest for this particular function. We have gone through so many problems last 2.5 or 3 years since the 2019. We have had a lot of rain, lot of floods, lot of problems in that time. Then after that, the other natural calamity was COVID pandemic, and so many things happened in last 2-3 years. We were not able to meet with each other for any of the group activities. And this is after now almost 2 years we are meeting together in this particular CME program, 39th CME program in IMA Miraj. I am really very happy to associate with our respected Professor Dr. Sotu sir. For many years in the Wanless Hospital, we worked together, and his guidance and his advices made us to this particular status of our life. I am also thankful to Dr. Ajit Chadda, who also was my colleague in those days when I was working in the Wanless Hospital. We used to have very good and very nice life in Wanless Hospital, and with lot of devotion we worked there for many years, and then we came out and practicing outside. I now will ask all these 2 years we were sitting at home and just observing the different webinars and all those different monotonous lectures, and now we are free. Now our government has declared that we are free of COVID, so we need not use mask and all that. So that is a very happy news for all of us. But still there is a little threat of COVID, so we have to be a little bit careful. I congratulate Dr. Chadda and Dr. Riyaz for this 39th annual CME program, and I wish them all the best for this CME. Thank you.
Without wasting much of our time, I directly go for the vote of thanks by our Honorary Secretary, Dr. Riyaz, because at 12 o'clock we are supposed to go online for Dr. Sanjay Oak's lecture.
Good morning all. I am privileged to honor a vote of thanks today on the behalf of IMA Miraj. It was indeed a great experience to conduct MIMACON-2022. On the behalf of IMA Miraj, I would like to thank Dr. Sotu sir and Dr. Takle sir for accepting as a chief guest. I would like to thank all our guest speakers and chairperson, Dr. Sanjay Oak sir, Dr. Satish Patki sir, Dr. Mohan Magdum sir, Dr. Roy Patankar sir, Dr. Suti Premsetti sir, and Siddharth Dhamsi to accept our invitation and making this academic quiz successful.
I would like to thank my fatherly figure, respected Ajit Singh Chadda sir, for their constant encouragement, timely advice, and support me whenever needed. I would like to thank, special thanks to Chadda madam, who's able to give our backcrafts to all the delegates who attended the CME, and these backcrafts are prepared by autistic children of the school. I would like to thank Dr. P.M. Kulkarni sir and team for making a very good souvenir. I would like to thank all IMA members, executive members, all delegates for making this CME successful. I also like to thank Dr. Vijay Kumar Mane sir, Dr. Chute sir, and Dayananda sir for becoming a master of ceremony and making this CME smoothly. Also special thanks to Pailwan brother, who's working day and night, not only for the CME for last many years, to making our IMA all events successful. I would like to thanks Mr. Mai for arranging the all sound system, Mr. Khan making this YouTube, our CME online on the YouTube. I would like to thanks all sponsors, and I would like, again, I would like to thank all of you to making this CME successful. Thank you.
Thank you, sir. The inauguration program is over. I call all the delegates and the chief guests to occupy the front position. With a few minutes for the arrangements, I announce the next speaker.
So I'd like to invite Dr. Chute sir and Mane sir on the dais. Yes. I request Chadda, Sotu sir and Chadda sir to felicitate Chute sir.
I call again the Pailwan brothers. Riaz. We go to the next lecture by Dr. Satish Patki sir, and the topic is IVF technology, what's new? Till the stage arrangements are made, I announce the chairpersons. The chairpersons are Dr. Somshikar Patil sir and Dr. Iqbal Tamboli.
आहे का तर चहा आहे का बाहेर काय गरज नाही मी इथं येणार आहे म्हणे हॉलमध्ये
There is one announcement. The soft drinks are served in the hall only, and immediately we are going to start our next lecture.
Good morning. We'll go to the next lecture. It is none other than Dr. Satish Patki. I'm very privileged to introduce my very good friend, Dr. Satish Patki. We have been together as postgraduates in BJ Medical College, Pune, and since then I know the way he has developed. He has brought in the international technology, the highest that one can achieve at that time to our area, especially in this area. So he has done a very yeoman work in the obstetrics and gynecology and especially the infertility. I request Dr. Iqbal to introduce him formally.
Good morning, everybody. I welcome Dr. Satish Patki, a stalwart in the field of infertility. A name which I know after Dr. B.N. Chakravarti is Dr. Satish Patki. His huge work in the field of stem cells has made him an outstanding figure in this field. MD from University, Pune University in 1985, practicing in Kolhapur since 1987. First test tube is 1978, and he started his infertility practice in 1995. The first IVF center in Kolhapur and southern Maharashtra. People all over Maharashtra used to rush to Kolhapur. Whenever I used to travel from Mumbai to Kolhapur, I used to see a lot of passengers and used to ask me, Kolhapur kadi yenar? Where are you going? Patki Hospital. Usually now we see trains full coming from Kurchi, Athni to Miraj. The same way people from Mumbai, Pune used to rush to Kolhapur. Still they are for Dr. Patki. He has 60-bedded PG institutes recognized by MUHS, Shivaji University and Ministry of Science and Technology and Government of India. Today he has completed 10,000 babies born of assisted reproductive techniques in this institute. Give him a big clap. First gynecologist in the world to document presence of stem cells in human endometrium and breast milk. More than 25 publications and 200 presentations in national and international conference. He has various feathers in his caps. National award, international award, Anandai Joshi Award, Kolhapur Bhushan Award, Fire Foundation Award, felicitated maybe by many chief ministers and all. So Dr. Satish Patki, we invite you on the stage to listen the precious words in the field of infertility.
Respected chairpersons, co-chairpersons, at the outset, I am very much thankful to IMA Miraj and my special friend Dr. Ajit for giving me this opportunity to present our work in the field of IVF. Today, I am going to actually cover the infertility management when I started my practice in 1987. And what was the situation that time and what is the situation at present, and from the success rate of hardly 15 to 20%, how come we have reached the success rate of 70 to 80% in cases of IVF, which I want to reveal. When we started in 1987, the only drug which was available for the patient of infertility was clomiphene citrate, nothing more than that. In 1988, the HCG, human chorionic gonadotropin, along with abdominal sonography, as Sotu sir was telling in his talk, that sonography was not available that time. It came in clinical practice in 1988, and that too was abdominal sonography. 1990, we started using HMG, HCG plus abdominal sonography. 1992 actually was a game changer when the transvaginal sonography came into the practice, and that started giving us the clear visualization of the ovaries, the developing follicles, the uterus, the uterine blood flow and all that. In 1993, GnRH agonist came into the practice. 1994, I went to NUH Singapore to have an IVF orientation program. But that time also the science was very basic and the things were not up to the mark. 1995 we started our animal lab in our own hospital with hormonal assays. It was very difficult to get even T3, T4, TSH levels also in a place like Kolhapur. We used to send the blood samples to Mumbai, to Metropolis overnight and then get the report next day. And with these efforts, we had the birth of first IVF baby of Kolhapur and southern Maharashtra in 1996. So we started learning from the basics and we started with the animal experiments. Those were the days when the mobile phones were not available, no internet, nothing of that sort. Even biotechnology and information technology was in a very primitive stage, and hence to get some orientation, we started with these animal experiments. We used to bring these animals, mice from Pune, the female mice were given injections of PMHG, that is like HMG in human beings. That was, we used to give those injections intraperitoneally to see the development of the follicles, because we are not knowing how the eggs look like under a microscope. So we used to give these injections, and then after giving the injection of HCG trigger, we used to open the animals, and then we used to find out that eggs. We used to see the oocytes of those eggs, these mice, and then fertilize those eggs into the laboratory. And then we started doing the ART lab as such. So now I would like to show you the ART setup, what it should be in 2022. Before going for the setup, I will tell you what is the air quality. See, this is the OPD picture of our hospital. There are about 200 patients which we see every day. In this particular atmosphere, if you see the particulate count, that is called as particulate count. So if you measure the particles in a 1 cubic feet area, that means 1 feet height, 1 feet breadth and 1 feet long, in that the number of the particles which are counted reflects the quality of the air. Now in this sort of OPD, even if you keep all the atmosphere clean, the number of the particles is in the tunes of crores. Per cubic feet, the number of the particles is in the tunes of crores. It means that with each and every particle, there are associated some bacteria, some viruses, and hence the laboratory should be away from the OPD premises. So these are the various modular air classes which we can see. This is a regular conventional operation theatre where if you measure with that particulate counter, you will find that there are 1 lakh of particles. Now what is required for IVF setup is you should have class 10,000. It means that in 1 cubic feet, the particle count should be 10,000 or less. In a working platform, that is on the laminar airflow, the particle count should be less than 100 because you are handling the gametes, human gametes like oocytes, sperms, and preparing the embryos, culturing the embryos in the laboratory. So that class should be class 100. So how to achieve this all atmosphere in the laboratory? So the laboratory has to have a certain design. It should be away from the overcrowded places. It should be away from the heavy traffic roads also. Because the petroleum fumes and the car exhaust, they have VOCs, volatile organic contaminants. Because of that, they are toxic to the embryos also. So it should be away from that. There should be larger areas with compartmentalization. Areas of clinical activities should be separate from the laboratory area, and entry should be restricted. There should be continuous availability of the electricity with the help of not only UPS but with the generator backup also. In a place like Kolhapur, yesterday only we had a load shutdown for 4 hours continuously. So in this situation, we must have a backup of electricity. Now this clean room environment, the flooring should be jointless, roof should be jointless, walls should be jointless. Painting should be also avoided because these paints are also toxic to the development of the embryos, and there should be air handling units to manage that clean air. So these are some of the pictures of our lab. You can see that these are the special walls which are made up of PCGI material. The doors of, these are the walls of our IVF culture room. You can see that they are made up of stainless steel. The angles or the corners are also avoided over here to avoid the accumulation of the dust over there. These are various incubators. You can see the walls of the laboratory. These are the various laminar flows. This is just a picture of a short video of our IVF laboratory. We have got many CO2 incubators, 2 ICSI machines, various inverted microscopes, and the air is managed by these HEPA filters. And because of that, if you measure, these are the continuous monitoring of the air inside the laboratory. You will see that the particle count is less than 10,000 and the VOCs are less than 2 to 3. Then only you will get a correct development of the embryos in your laboratory. These are the HEPA filters you can see over there. These are various incubators. This is the particle counter monitoring which is done every day, and now we will have a small trip inside the laboratory. Now in this laboratory, the various compartments are created for various procedures. Like intrauterine inseminations or IUI, there is a different laboratory. For IVF, the procedures like ovum pickup, embryo transfers, there is a different operation theatre. These are various types of filters which will give a clear and clean air inside. So you have a different type of compartmentalization. This is an IUI lab or andrology lab where the sperm washing procedures is done. I am going to show you how the sperm washing procedures are done. These are various types of incubators and centrifuge machines which have a temperature controlled centrifuge machines also, and incubators and various microscopes. You can provide pictures, you can provide the videos of all the gametes and the embryos. These are the microscopes. You can see the inverted phase contrast microscope under which you can observe the sperms. You can check the motility, you can check the velocity of the sperms also. So you have got a clear picture. This is an andrology laboratory. This is an IUI OT where the washed sperms are injected in the uterus at the time of ovulation. So this is a separate OT which is used for IUI only. Now microbiological monitoring also has to be done like a regular operation theatre. VOCs, which I told, certain antiseptics like ethanol, glutaraldehyde, anesthetic agents, outside smells. So this all should be avoided, and it has to be monitored by that VOC meter. So ideal VOC should be less than 10. So this kind of 2.2 type of VOC should be present. There are various CO2 incubators. These carbon dioxide incubators are the heart of the IVF laboratories because we culture the embryos. We take out the oocytes, we take the sperms, and then they are fertilized and they are kept in the CO2 incubators. There are various kinds of incubators in the lab, like these are box type of incubators, CO2 incubators. Recently, these small working incubators have also come into the practice, like these, where they are kept on the laminar flow. You can monitor their CO2, you can monitor their temperature also. The temperature is also very critical because the 37 degree is required for the gametes to prepare, actually give rise to a good healthy embryos. So even the microscopes also, they have got a stage warmers. There should be temperature controlled centrifuges. So even all small working incubators, so all they maintain the temperature. You can see over here that this is actually a stage warmer. So even when you are keeping the embryos, the dish on the microscope, it will have a temperature of 37 degrees. Now we will go with this background of IVF lab. What is an IVF procedure, how it is done? The indications of IVF in vitro fertilizations are absolute indication where the natural pregnancy is not possible. Like patients who have got bilaterally blocked tubes, so no chance of natural conception. Patients have extensive endometriosis, severe male factor. The sperm count is hardly 1 million, 0.1 million, hardly few sperms are seen in the sample. Natural conception is out of question. Obstructive azoospermia. Patient has got azoospermia, no sperms in the semen. Postmenopausal patients, obviously patients who have exhausted ovaries, POF, and relative indications where you can try certain other treatments like IUI or other medical modalities, but when they fail, you have to go for IVF, like elderly patients, failed IUI, unexplained infertility and all. Now in the steps of IVF, what is done in the steps of IVF? First step is induction of ovulation. So we give various types of injections like HMG, FSH, recombinant injections to stimulate the ovary to have multifollicular development so that the ovaries will produce many number of follicles. Once they are monitored under sonography and with the hormonal levels of estradiol and progesterone, and once the eggs are mature, the follicles are mature, then those oocytes have to be retrieved out of the body. That is called as ovum pickup operation. Then fertilize those eggs with the sperms of the husband in vitro, in laboratory, culture them for a period of 5 days to prepare the best embryo, that is called as blastocyst, and then finally transfer that embryo back to the uterus, maybe in a fresh transfer, or you may freeze and transfer it later on. So this is the steps of IVF. Follicular events we will see in short briefly. See, this is the ovary you can identify. This is the internal iliac vessel, and the ovary is sitting just on the top of the vessel. So you are monitoring this follicle, and once the follicle is mature, there is a LH surge which you can see, and this is the time when you should go for ovum pickup. These are the multiple follicles because of the gonadotropins, and at the same time you have to monitor the endometrium also. So this is the endometrium at the beginning of the cycle. You can see that this is a thin line endometrium, very thin line endometrium. As the follicles they go on growing, they will produce estrogen, and under the influence of estrogen, you will see that the endometrium has become a triple layer endometrium. If you analyze it carefully, sometimes you see the endometrial peristalsis also. This peristalsis is seen when the estrogen levels are at peak. So you have to identify sonography as well as by doing various hormonal levels. Now this is the procedure of ovum pickup. In this procedure, the patient is already given the drugs for induction of ovulation for 7-8 days, and once the follicles are mature, then you give a trigger of either HCG or GnRH agonist, and then this procedure of oocyte retrieval is carried out. This procedure is done with the help of transvaginal sonography under short general anesthesia. The procedure takes hardly 15 to 20 minutes, and each and every follicle is punctured with the help of the disposable needle, and this fluid is collected. Each and every follicle is punctured, and you go on collecting that fluid, and that fluid is sent for embryological checkup to see actually how many eggs are there in that fluid. So this procedure is a daytime procedure. A patient is called in the morning NBM. You do that oocyte retrieval. On the same day, patient will go back. So this is a oocyte retrieval, and afterwards this fluid which is collected from this oocyte retrieval is sent inside the embryology laboratory. So the embryology laboratory has to be adjacent to the operation theatre, so that that fluid will immediately go for screening. So these people inside, the surgeon is sitting outside, but they should have communication with the surgeon so that they know that number of oocytes they are getting out of that ovum pickup. So this is screening is done under a stereo microscope, and the best quality of the oocytes are identified. And then those oocytes are kept immediately into the incubator. The purpose is to maintain that temperature and pH of 7.4 exactly for those oocytes. At the same time, the sperms, the semen sample from the husband is taken, and the sperms are washed. Why they are washed, why raw semen is not used, is because it has to be get rid of that seminal plasma. That seminal plasma is actually not good for the fertilization. Now this is the procedure where you can see the sperm washing. The semen sample which is collected in a container, to which certain culture media are added. These culture media are basically various salt solutions, mixed salt solutions like Earl's balanced salt solution, which are supplemented with proteins. In the olden days, we used to prepare those culture media in 1980s and 90s, but now they are commercially straightway available. So these culture media are added to the sperm sample, the semen sample, and then they are the solution is mixed, and then it undergoes a process of centrifugation. With the help of the centrifugation, after centrifugation, you see actually a pellet at the bottom, and the good sperms, they come up. So therefore, this is called a swim up procedure. So the good sperms will swim up into the culture medium, and they will be obtained in the supernatant after maybe 20-25 minutes. And then those sperms are added to the oocytes which are retrieved earlier. So the fertilization will take place inside the laboratory. So you can see that this is the pre-washed semen sample, where you can see lot many sperms are there, but all of them are not motile, all of them are not good. there are abnormal sperm, some dead sperm, some debris. So all is at the background. But after you wash the sperms, you will see that all 100% sperms are washed. All 100% sperms are active. The abnormal sperms are removed, the debris is removed, so that you now use these only healthy active sperms for the process of fertilization to get good healthy embryo. So now if you see the microscopic events in that, this is actually the mature human oocyte at the time of retrieval. You can see that this is the central oocyte which is surrounded by those cumulus cells or granulosa cells. See, this is the oocyte at the time of retrieval, to which one egg you have to add about 50,000 of the sperms. So out of those 50,000 sperms, only one will enter into the oocyte and fertilize that oocyte. So this is the oocyte 24 hours after the fertilization. This is the oocyte after injections also. And you can see this is the first evidence that the egg is fertilized. You see the two nuclei, these are called as two pronuclei. One is called as female pronucleus, the another is called as the male pronucleus as a result of fertilization. Then you will see the syngamete, both the pronuclei will come together, and then the division will start. So by the end of about 48 hours, you will get a 4-cell stage embryo, and at the end of 4th day, you will start seeing this is a blastocyst. And this is the inner cell mass from which the body of the fetus is going to develop, and these are the peripheral cells, tropoplastic cells, from which the placenta is going to develop. And this is the fully developed this blastocyst, which you can see in the laboratory, and this is ready for embryo transfer, which you can transfer back to the uterus. So this is the blastocyst. This is the fully expanded blastocyst, and sometimes you see actually hatching of the blastocyst. This is the zona pellucida, and the blastocyst has come out of that zona, which is ready for implantation. Now ICSI is an indication which is a one step ahead of IVF, where the sperms are very low in number or absolutely zero because of the obstructive azoospermia, where the sperms can be retrieved by the procedures like PESA or even testicular aspirations, and these sperms are then manipulated with the help of the microscope, and this is called as micromanipulation. This is a micromanipulation unit. You can see these are the needles which are used for micromanipulation, and they are so thin that they are about 100 times thin than the human hair. They are not visible with the eye. Initially those pipettes, these are the needles which we use. This is side which is called as holding side, and this is an injecting side. So what is done is initially the sperm is immobilized and the sperm is aspirated in that injecting needle, and this is the oocyte. Oocyte is picked up with the help of this holding oocyte, this holding pipette, and this is an injecting pipette. And then during the ICSI procedure, what you can do is with this injecting needle, which is straightway going through the zona, going inside the oocyte, and some of the cytoplasm is aspirated back, and then that sperm is deposited back into the cytoplasm. So this is the procedure of the ICSI, and then you can create the embryos out of that. This is one more procedure which you can we are using at our place. This is called a SUSI also, subzonal insemination, where about 2 to 3 active sperms are injected in the subzonal area. They are live sperms, so they are injected. So out of those 3, one will go inside and one will fertilize. So this is called a SUSI procedure. And after once the embryos are formed, they are frozen. Nowadays we are doing embryo transfer of the frozen embryos. So those embryos are loaded in the catheter and then they are replaced in the uterus. So the terminologies of the pregnancies are biochemical pregnancy. When the patient comes 14 days after embryo transfer, you check for beta HCG. If it is positive, then it is biochemical pregnancy. Clinical pregnancy, when you see actually the gestational sac with the fetal cardiac activity, and the real success is take-home baby. That means not only biochemical pregnancy or not only clinical pregnancy, patient should take good healthy baby at the end of the 9 months. That is the real success of the IVF procedure. So this was our first IVF baby born in 1996. So let us have a quick look of the various milestones. This was the first IVF baby born in our hospital in southern Maharashtra in 1996. This was in 1997 the first IVF twins. This was a patient from Russia who had undergone 18 attempts of IVF in Europe and Russia, and failed unfortunately, and she came to us, and on her 19th attempt of IVF, she conceived and she delivered a child in 1997. That girl is now 25 years old, and that event is recorded in the Limca Book of Records because the successful pregnancy on 19th attempt itself is a record of the millennium. So that is recorded as a Limca Book of Record. This was in 1998, a 54 years old patient delivering the IVF baby with the oocyte donation program. This was the first frozen embryo transfer baby in 1998. This was an ICSI baby, IVF triplets, and even in IVF patients with absence of uterus, the surrogate mother technology was used in a cases where the patient had vaginal atresia, absence of the uterus, and Mullerian agenesis. However, her ovaries were good. Her ovaries were good on laparoscopy. So the eggs were retrieved, fertilized, and they were transferred, the embryos were transferred to the surrogate mother, and that was the case in 2006. Now I will show you some of the interesting cases. IVF for the tubal factor. The patient had multiple laparotomies for various reasons. The tubes were blocked like this, you can see, and then the patient conceived with IVF with twin pregnancy. At the time of cesarean, you can see that both the tubes are blocked, and these are the twin babies. This was a case of endometriosis extensive on the fundus, both the tubes blocked, patient conceived with IVF. Patients with absence or non-functioning ovaries, like this was a patient with a Turner syndrome, where the ovaries are absent, the patient had good uterus, but the ovaries are absent. The oocyte donation program, the husband's sperms and the donor oocytes and the fertilization and the embryo transfer was done. You can see at the time of cesarean, the ovaries are not seen over there. So this patient could deliver a child because of that oocyte donation program. Even in postmenopausal patients, where the patients they do not have functioning ovaries, there also with the oocyte donation program, patients can have a child. This was one more patient of 54 years and conceived with IVF and had a baby. This was one more patient of 50 years old having twins babies. So surrogacy also has got a definite role still in the cases of genital tuberculosis. This was a patient where HSG, you can see that the uterus is entirely damaged because of the infection. There is no space for implantation. You can see extensive intravasation, blocked tubes, so natural pregnancy is not possible. So such cases, they need actually the surrogacy. Multifetal pregnancies in IVF is also an issue because normally we transfer about 2 embryos. So some of the patients, they develop twins. In some cases, when we transfer 3, they get triplets also. So how to tackle those situations also? So these are the twin babies. We are following all the babies who are born at our place. So embryo reduction is a procedure. Embryo reduction is a procedure at about 12 weeks of gestation. When you see 3 gestational sacs, then injection of Kesol is given in the fetal heart by transabdominal sonography, and then you actually see the baby which is not growing then onwards. So this is a triplet pregnancy which was converted into twin pregnancy, and ultimately finally the patient delivered twin babies. This was a quadruplet pregnancy. The reduction was done and it was resulted into triplet, and the 3 babies were born. So at the time of delivery, you can see actually the behind the placenta, this was the small fetus which was reduced at about 12 weeks. This remained as a fetus papacious. You can see this small fetus papacious. Recently we had one patient of unusual IVF triplet. That patient had triplet, the reduction was of the first was done at 12 weeks. And the patient was interested in continuing with the twin pregnancy. At 30 weeks of gestation, suddenly the FHS of the second fetus disappeared and it resulted into intrauterine fetal death. The cause which was found was true knot in the cord, and the third continued and was born at 34 weeks, which is live. So you can see that this fetus was reduced. This was IUD at about 30 weeks, and this was 34 weeks baby which was born. So such kind of things are done to reduce the number of the fetuses, because the perinatal mortality and the maternal complications are also high with multifetal pregnancies like twins, PIH and all that. We had actually a get together of all twins and triplets born in our hospital in 2013, and it was again recorded in a Limca Book of Records. So now with this background, in the next 10 minutes, I will be finishing what is new in IVF. The thing is, we want to improve the success rate of the procedures. So how can we achieve that? To improve the implantation, because the problem is either there is a problem of the guest, that is competent embryo is not there, or there is a problem of the host, that receptive endometrium is not there. So we have to correct either the guest or the host, wherever is the problem. So can we improve the quality of the guest? That means the quality of the embryo. So for that, we have developed one machine in which the embryos are cultured in that incubator and they are continuously monitored. Like a baby is monitored in the NICU, you can monitor that embryo which is growing, and that culture has to be done at a hypoxic environment. That means 5% oxygen, so that their growth is excellent. So here, this is an instrument. This is called as time-lapse monitoring of the embryos. We are monitoring those embryos, and this is actually on-stage incubator. This is a very small incubator in which the embryos are grown, and there is a facility with the help of the software program. You can go on taking the photographs of those developing embryos. Maybe you can give the order maybe of every 4 hourly, 6 hourly, 8 hourly. So for 5 days, you go on taking the pictures of those embryos, and then you can make a film, video film of that, and then you identify which embryo is growing. So this is a series of the pictures of the embryos, and this actually you can see the result of that development of the embryo, which you can monitor. Time to time monitor actually the embryo. You can see that the one cell is divided into 2, 2 into 4. So for normal monitoring, you have to take out the dish and monitor. Instead of that, continuously it is monitored even if they are in the incubator. The pictures are continuously taking place, and you develop a video, and at the end of the 5 days, you can select which embryo is developing at a faster rate and which embryo will have a maximum potential to have a successful clinical pregnancy. So you can either select or you can deselect the embryo depending upon the development. Second thing which we are nowadays we are doing is, before the embryos are transferred, you can analyze the genetic or chromosomal testing of that particular embryo. So only those embryos which are healthy, transfer those embryos, otherwise reject those embryos, and this is called as pre-implantation genetic testing. So this pre-implantation genetic testing is done by 2 ways. One is called as invasive and second is non-invasive. Earlier we used to do invasive testing, where you can see this video in 2019. This a blastomere is taken outside. This is a blastomere biopsy which you can take and send that sample for chromosomal study. So you will know whether it is a euploid or aneuploid and all that, and then accordingly you select it for transfer. In last year, in 2021, on the World IVF Day, we announced the non-invasive technology. The embryology, this embryo which are cultured in the culture medium, in that culture medium some DNA is coming out of that embryo. So that culture medium is sent for chromosomal study. So in that, without disturbing, without traumatizing the embryo, you can check what is the genetic makeup of that embryo, and you can transfer that embryo. So the healthy embryos are transferred. So this is from the embryonic side. Now from the mother side, can we improve the endometrial receptivity? That is also important, because it is a seed and soil concept. The seed has to be good, the soil also has to be excellent. Then only it will result into the growth of that particular plant. So endometrial receptivity evaluation, there are various research projects which are going on in our hospital, and the chapter is contributed in the textbook of assisted reproductive technology by us. In that, there is a definite period of implantation window in a menstrual cycle. These are only 3 days in which the embryo is actually attracted by the uterus. Even if you have got excellent embryos and if you transfer before this, it will not be implanted. And even if you transfer it afterwards, it will not be implanted. So you have to identify that implantation window, and for that, we had undertaken an electron microscopic study of the endometrium. So you can see these are the glands actually. This is the endometrium, which is seen about 4,000 times magnified, and you can see that these are the pinopods. So if you see the pinopods, then it is a sign of actually a good sign of implantation. These are the glands which you can see, actually the glands like wells over here. You can see those wells. This is a good sign of implantation. It means that the receptivity is at the top level. You can see the developed vessels also. You can see actually the coiled vessels which we just used to read in the books. You can see those coiled vessels. These are the big pipe-like vessels. There is an angiogenesis at the time of implantation. So you can identify those vessels under the electron microscopy, and then you select the day of embryo transfer. And if we can widen the window of receptivity, so for that certain drugs are also developed at our center. And for that we have developed one test to test that molecule whether it is actually helpful for implantation. Because at implantation what happens, this is the endometrial culture, you can see these are the endometrial cells, and when the embryo wants to go bury inside the endometrium, there is an injury over there. This injury, the embryo will go inside, and then it has to heal and again form a monolayer. So this you can study by a time-lapse microscopy which I showed. This is actually endometrial culture. These are the endometrial cells you can see, and a scratch is made over there. And the molecule which we want to study, whether that molecule is of angiogenetic or not, whether it will be helpful for implantation, in that actually you can see the healing of that endometrium. So you can see from both the sides the cells are coming and that wound is healed. So this molecule is good at the time of implantation. So likewise, to summarize, if you have got the best oocyte, you have to select the induction of ovulation protocol in such a way that you get the best oocyte. You select the best sperm also by various microscopic techniques. Finally, you prepare the best embryo, and with that embryo, you can freeze that embryo for a certain time, and you can transfer it later on also. And you can transfer maybe after 3 months, 4 months, 6 months also. There are patients who actually freeze their embryos who are coming from abroad. They freeze their embryos at our place, and then they come later on maybe after 2 years, 3 years for embryo transfer also. There are situations like young patients where we could get 10 or 15 oocytes, 10 blastocysts are formed, all are frozen. You transfer 2 embryos, the patient successfully conceives, delivers a child, and once the child becomes 3 years old, 4 years old, again the patient comes back for the transfer of the embryos which were frozen 3 years back. Again you transfer, you can get the pregnancies. So you have to have the best embryo, you have to have the best endometrium, and then you will get the highest implantation rate. We were struggling for getting pregnancy in 1994-95. The pregnancy rate was hardly 15 to 20%. And now with the advances of this PGTA, with the advances of endometrial studies, and with the advancement of time-lapse imaging, the success rates in selected cases, even out of imagination, they have gone to the tune of 75-80% also. So this is what actually the development has occurred in last 35 years where I am practicing. And in the last 6 months, now we have delivered more than 10,000 IVF babies. In the last 6 months, we have delivered 300 IVF babies from June to December 2021. Thank you for the patient audience. Thank you.
So thank you, Dr. Satish, for the wonderful story of your development from the very basics to this state-of-art, which is of international level. And it is nothing less than a scientist's effort, perseverance, and continuous quest for the new and the better techniques. So we are very fortunate to have you here. If there is a time, we can allow questions. I would like to know from the Masters of Ceremony whether we have time.
एक दोन क्वेश्चन घेऊ शकतो. We can take 1 or 2 questions.
If there are any questions, one question we can have. So probably the things.
Yes, yes.
So I thank Dr. Satish
Thank
for
you, sir.
a
Thank
wonderful
you.
talk.
Thank you, sir.
And hand over the mic to the...
Yes.
you are telling twins and triplets. Is the population is going to increase?
Yes. So therefore, actually, the multifacetal pregnancy is a big challenge for the gynecologist also, because it is associated with preeclampsia, PPH, abortions, and whatnot. So our target should be actually the birth of a single healthy baby. So therefore, now we are coming to the level of single embryo transfer. Earlier we used to transfer 3, but now if you select the embryo which is genetically healthy and the endometrium is also appropriately prepared, transfer only single embryo, the couple will have a single baby.
It was a nice, informative lecture, sir.
Thank you, sir. Thank you.
And one story about this, sir, I want to share. एका पुस्तकात मी वाचलेलं होतं की डॉक्टर सतीश पत्के सरांचं हिंदी चित्रपटसृष्टीतील पहिला सुपरस्टार म्हणून ज्याचा उल्लेख केला जातो ते राजेश खन्ना यांच्याबरोबर मैत्रीचे संबंध होते. आणि सर तर इन्फर्टिलिटी मधले सुपरस्टार आहेत असं म्हणायला काय हरकत नाही. तर आय रिक्वेस्ट आवर चेअरपर्सन डॉक्टर सोमशेखर सर and Dr. Iqbal Tamboi to felicitate sir with bouquet and memento. I request President Dr. Ajay Singh Chadha sir to felicitate our chairman.
Thank you very much, sir. The next lecture is an online lecture by Dr. Sanjay Oak. If the arrangements are completed, I would request upon the chairpersons for this session. Dr. Shishir Gosai sir, please come on the dais, and Dr. Sharad Desai sir. And the topic by Dr. Sanjay Oak would be medical practice challenges today and tomorrow. Hello. If it is a by-way communication, I request our honorable chairpersons to interact with the honorable speaker.
Yeah, good morning. I am ready and I can see and hear.
Sir, are we audible?
Absolutely, absolutely. I can see very vividly our IMA hall. I can hear every word. It has been a pleasure.
Hello.
Can you hear me?
Hello, Dr. Oak.
Yeah, can you hear me?
Can you listen me?
Absolutely.
Yes.
I can hear you. Can you hear my voice?
Yes, yes.
And can you see me?
Can everybody hear him? Okay. Good afternoon, Dr. Oak. I am Dr. Shishir Gosavi. Hello.
Namaste, Shishir.
I am fine. How are you? Meeting after a long time. Nice to see you.
Yes, alive in COVID.
Yeah, after COVID. Yes. So today's topic, Dr. Sanjay Oak will be speaking in medical challenges. Dr. Sanjay Oak is a very famous pediatric surgeon from Mumbai, and he is a fellow of Royal College of Surgeons of Edinburgh, Fellow International College of Surgeons, Fellow of Association of Surgeons of India. It's a big biodata actually he has got. Fellow of National Academy of Medical Sciences, Fellow of College of Physicians and Surgeons. And he has held many important posts in Mumbai also. He was Professor Pediatric Surgery in 1999 onwards. He was Dean of Nair Medical College from 2005 to 2008, Director of KEM Hospital, my college also, in fact, 2008 to 2012, Vice Chancellor of D.Y. Patil University. Then he is Director of serving KMFTH since January 21, and he is a Director serving at Ushakkal Hospital, Sangli also. He is a renowned pediatric surgeon for nearly 37 years of clinical standing in the faculty and rich experience of health sector administration for nearly 16 years. Now, most important thing I would like to mention here that regarding the Corona Task Force, in the month of April 2020, he was appointed as Chief of Task Force of Maharashtra by Government of Maharashtra. Dr. Oak was then instrumental in getting repurposed medicines in the forefront, planning management protocols, conceptualizing the field hospitals, designing the screening methods with pulse oximetry as tool. He was then included in the national protocol design team and interacted with central representatives of various organizations. He has received many awards. The most important and very prestigious Dr. B.C. Roy National Award for Medical Excellence in Development of Super Speciality, Hariom Ashram Prerit Rangacharya Award for Original Research, Dr. Babasaheb Ambedkar Award for Social Contributions, Lokmanya Bal Gangadhar Tilak Puraskar for Social Contributions in Public Health, Yolgonda Patil Award for Social Contributions in Corona Work, and Sakai Samman for Corona Contributions. I won't take much of your time, and here I would like to mention that Dr. Oak has passed from Miraj Medical College. So basically he is from Miraj, and we are proud that he has achieved so many things in his life, and all the best for him. And now we will go to Dr. Oak and listen to his words. Thank you, sir.
Thank you, Shishir. मिरजेच्या IMA हॉलशी अत्यंत हृद्य अशा आठवणी जडलेल्या आहेत. 1977 ते 1986 हा सगळा कालखंड मिरज मेडिकल कॉलेजच्या विद्यार्थी दशेचा आहे. आणि शिशिर मला अजूनही आठवत आहे की 1985 साली मी MS करत होतो आणि माझ्या आयुष्यातलं पहिलं कॉलेजच्या बाहेरचं जे मी प्रेझेंटेशन केलं होतं, सर्जिकल प्रेझेंटेशन, ते ह्याच IMA हॉल मिरज मध्ये केलेलं होतं आणि त्याच्यामुळे या हॉलची खूप हृद्य अशा आठवणी माझ्या जोडलेल्या आहेत. कमिंग टू द टॉपिक ऑफ टुडे, let me share my screen and I hope that I can continue in PIP seeing you also. So can I share the screen, please?
Anybody is here to?
Yeah, I'm doing it. Just a second. Can you see my screen?
Yes, we can see.
Okay, right. So the topic that has been allotted to me by Ajit has been a very close personal friend in Miraj and then subsequently when I did his MCH from Mumbai. And that is medical practice challenges. कोणती आव्हानं, कोणत्या अडचणींना आपण आता सामोरे जाणार आहोत. Lot of things have changed in the last 2.5 years and because of last 2.5 years. I think Corona gave us an opportunity to pause and ponder. It also changed the priorities of life. Remaining alive was expensive. I have myself got Corona thrice, Alpha, Delta, and then Omicron BA1. And on 3 occasions I was admitted in 3 different hospitals. And the second one, Delta, put me on a ventilator for a span of almost about a week. So therefore I write, जब जिंदा रहना ही दुश्वार हो गया तो जीने की असली अहमियत समझ आ गई. We never bothered about breathing, but Corona taught us the importance of oxygen and clean air. Whatever we are doing for the environment, sustainability now has become a topmost priority. And that's also been the theme sentence of WHO Day, which was celebrated about 2 days back. And that says, our world, our planet. I think I listened to Satish's wonderful discourse, and earlier to that, our revered Sotu sir's inaugural speech. And it is always the first consultation that makes the whole difference. Corona underlined the significance of early referrals and early first consultations that made the difference between life and death. And this was probably for the first time an effort was made that protocolized management will come into being. It also made teleconsultations a reality. I've been in health sector administration since 2005, but I think the maximum education I have got about health sector management that has happened in the last 2 years. By the virtue of telemeetings, we have talked to Harvard, we have talked to Oxford, we have talked to all the vaccine manufacturers around the globe. But equally, I have been able to communicate with virtually every Zilla Parishad, every Taluka Panchayat, and even every Gram Panchayat in the interiors of Maharashtra, where I would rightfully say that I learned a lot of things of practical healthcare management. Payment gateways are newly opened up because you may not see the patient first hand across the table, and therefore you would receive your remuneration by an e-portal. The most important difference I think it made to a dean and director or a VC like me is community medicine and epidemiology are now second to none. And if you ask a young MBBS graduate as to beta, what do you want to become? An answer about 20 years back used to be, I want to be a surgeon like you. No more. Now, in fact, the infectious diseases and intensive care, these are the two hot topics of pursuit, and I think that is what is likely to continue in the years to come. On a mega scale, one thing that made me particularly satisfied, and this was an instance when I think 70 years since independence, public sector and private sector people came together because we had a common enemy in the form of COVID-19, and we worked in tandem. Oxygen plants became a necessity and a mandate for a hospital more than 200 beds in the state. Overall health policy planning evolved for better, and allocation to health sector has improved in both the center as well as in the state. Vaccine industry got a boost. But while these good things were happening, we also witnessed black marketing of drugs like remdesivir and even oxygen to a huge amount in Mumbai and in other metropolis. So what changed for future? A, priorities. B, allocation of finances. How will the money come? Will it come from the out-of-pocket expense of the patient, or will it be funded through some insurance? How will you prescribe drugs in a rational manner in a protocolized management format? Can we give a boost to Make in India movement for manufacture of implants, prostheses, joints, and even the drug molecules? And the most important thing, how will you reach to the poorest of the poor? These are the things which are drivers for our future. Society is changing. And if you took our metro cities like Mumbai, Navi Mumbai, Thane, Aurangabad, Nagpur and Pune, I think the network of metro rail lines is making a huge difference to our cities. Access to healthcare is improving with our Honorable Central Minister for Communication and Roads laying down almost about 22 kilometers of road a day, access to healthcare will improve. The question is whether the trust in healthcare will go along with that concurrently. In cities, you see that information explosion is a reality. For last, I think about 5 or 6 years, I have not seen a fresh patient coming to me. The patient who walks in the office is already seen by a couple of pediatric surgical colleagues earlier, or a urologist, and they walk in with bags full of MR, CT scans, PET scans, ultrasound and Dopplers. And the patient expects that I would then opine on these reports because he has himself experienced him in an era of information explosion. Google Mata, sab kuch aata. And therefore, your WhatsApp, even to a rural folk, is not an unknown thing that they will walk with a ready-made diagnosis to you and expect an instant cure. Dear friends, we are experiencing a society in transition. So what are the topmost challenges that you and me are facing today? They have been augmented by the post-corona phase, and we are likely to see it more. Technology is advancing, but technology is like a toy. How do we harness this advanced health technology and use it for our benefit? The topmost challenge. How do we cope up ourselves with the information explosion, right or wrong, and convince the patient that there is more to real life and surgery rather than Google and WhatsApp? We live in an era where the hospitals are becoming paperless. The hospital which I lead in Mumbai now is completely paperless. Everything is on an iPad. There are no servers and the data is stored somewhere in the skies. And therefore, the cloud security and cyber security relevant becoming to the patient data when it comes to storage and retrieval will be a topmost challenge to us. All these things will add to the healthcare cost. And you cannot say that, oh, I will continue by my old way, the way I was taught in my Miraj Medical 40 years ago. No, you just can't do that. You have to embrace the new technology, and along with that will come the cost. Payment processing and gateways will have to get into newer modes. No more payments under the table. And the earlier we accept this, the earlier we do away with the cash payments, the better it is for all of us and eventually for the health sector. There is a pressure on pharma prices, there is a competition innate in them, and along with that, two important challenges which we cannot forget. One is the changes in the regulatory sector, the laws, the enactments, the rules within which we will be expected to function, and the staffing shortages which we will continue to have in healthcare. So why do we have such problem with the manpower in the health sector? And it is not only that I am devoid of my qualified colleagues, but I am also terribly short of my colleagues in the form of technicians, in the form of nursing professionals, in the form of midwives, and even in the form of class 4 people. Now, if you employ too many, you are inviting unionism, and therefore you are inviting trouble in your own health organization. But if you manage and try to manage with lesser and lesser, someday you will fall terribly short of things. People tend to move. There is a significant amount of attrition. And that is because of few advancement opportunities, lack of mentoring, no scope of advancing their own careers, no visible promotions, work overload, burnout and low salaries, school loans and the bad work hours that they may have. And therefore, eventually, you are not able to spend enough amount of time with the patients. What are the issues from the patient's perspective? See, we always said an apple represents a health sector, and you would say an apple a day would keep a doctor away. But there are few A's beyond Apple's A. One is access to healthcare. You must be accessible to your folks in a radius of not more than about 10 kilometers. Whatever you are going to provide should be affordable, should be available round the clock, and absence of human manpower in the late hours or in the night cannot be a deterrence to the delivery of good health care. And whatever you do, you are accountable in your thoughts, in your actions, and even in your speech. There are certain forces which will navigate your and my work. The work or the care will eventually move towards value-based, individualized, personalized care. See, when we deal with oncology, gone are the days of standard protocolized management of chemotherapy drugs. In fact, we are slowly moving to individualized chemotherapy tailored protocols. So one size fits all is no more true, but we will going towards personalized care. We will have to accept changes. Whatever is prevalent today will become obsolete in the next few years. And what better example I can give it to you than our mobile phones. In early 90s, when the mobile phone came, the phones were heavy. We need at times both hands to hold them, and the tariff was too much. Today, the phones have become miniature. The tariff has become affordable that we don't mind it, and the applicability of the mobile phone has grown multiple times. Can there be any doctor who is not using WhatsApp, who is not using Telegram? It's not possible, because I get to see ECGs, rhythm disturbances, patterns, MRIs, PET images, and everything, real-time sonography, everything on my mobile phone, and if I am still further advanced, on my wristwatch. These are the changes. The changes disrupt our old habits. And dear friends, particularly people like me who passed their MBBS at least about 45, 46 years ago in 1983, most of us, Satish Patki, me, Ajit Singh Chadda, Mohan Magdum, all of us have passed together. And a generation which exists even earlier to us. What is difficult? Unlearning things are difficult. At times, learning new things is easy, but unlearning is very, very tough. What better example I can give it to you rather than the phase of my life in 1999 when I started learning laparoscopy. See, all these years for nearly about 2.5 decades, we had tied the knots with our own hands inside the abdomen and pelvis. This was for the first time we had to unlearn that and learn how to tie the knot inside the abdomen, not by using fingers, but by using instruments. This is change. And one has to be constantly prepared in our medical practice to embrace change and be prepared to get constantly disrupted. We have to embrace virtual healthcare. See, we all grew in an era when we were taught की आपण जर पेशंटशी बोललो नाही, आपण जर पेशंटच्या अंगाला स्पर्श केला नाही, त्याच्या पोटावर पाल्पेशन केलं नाही, त्याला जर PR केली नाही, तर आपली एक्झाम, आपली असेसमेंट ही इनकम्प्लीट आहे. आणि म्हणून पेशंटला आपल्याला भेटायला येणं गरजेचं आहे. Today, some of the branches, if I ask the patient, please come and see me, he will ask me, what for? I can communicate to you on a virtual network. I can photograph and show my external lesion to you. Can you not prescribe it in a virtual manner? This is true for dermatology, this is true for psychiatry, and this is also true in certain aspects with pediatric care. And therefore, embracing virtual healthcare is a necessity now in our practice. We must manage mergers effectively. We have all grown up in the medical colleges and in the subsequent early years of practice to work in silos. माझं स्वतःचं राज्य, पण या स्वतःच्या राज्याला कवटाळून बसण्याच्या प्रक्रियेमध्ये ती राज्य कधी खालसा होतात हे आपल्यालाच कळत नाही. And that is the reason when people need to come together, people need to form groups, and group practice is the most prudent way. It shares the responsibilities, it reduces the psychological tensions. You can get a better quality sleep in the night, and your practice never gets divided. Take it from my personal example, it adds and at times even multiplies. So therefore it is essential that we form groups and work in groups. What are the regulatory mechanisms within which we will have to function? Well, they keep on evolving. But as it stands in 2022, Consumer Protection Act is there. Clinical Establishment Act has been put into practice in some states. In Maharashtra, it is still tabled, but not yet clear. But that's not too far away that Clinical Establishment Act provisions will be applied to us. An Epidemic Act, which is now slowly being lifted, though the masks mandate is over, but advice still continues. Bombay Nursing Home Act, under which we have to register our establishments, is a mainstay of your regulatory influence. We will have to acquire several drug licenses, and those of us who are anesthetists or those of us who run pain clinics will have to go in for narcotics licenses also. But practically all of us will have to go in adhering to the strict rules of biomedical waste disposals. So these are the things that will influence our medical practice in the days to come. What kind of technology we can employ? You cannot say माझं छोटंसं क्लिनिक आहे, माझी छोटीशी प्रॅक्टिस आहे, मला काही टेक्नॉलॉजीची गरज नाही. We cannot say such things anymore. Technology is going to drive you, whether you are having a small 100 square foot clinic or even 100 beds hospital. The solutions will have to be innovative, sustainable and scalable. Can you make advantage of Arogya Setu and the apps like that? Can you map the patients around your clinic in a territory of say about 5 kilometers? See, for last 10 years, since 2012, I have been operating on all Sundays in a month in various districts of Maharashtra. Derwan is one of them, where I conduct on one Sunday every month a surgical camp. And I am proud of Derwan's mapping of patients. Sitting at Derwan, I know in a radius of 10 kilometers how many homes, which household has what type of members, which are the premenarchal, perimenopausal ladies, who is at risk for severe breast, who should be subjected for screening, what newborns, how many infants, who are the adolescents. This kind of mapping of patients, each one of you can do even in private practice. Online clinical support, it's not only that you can extend it to your patients, but you can also draw online clinical support from our revered professors like Professor Sotu, or our experts like Satish Khadilkar, who has been our own protege, or Mohan Magdum, and so many others. And yes, there is a time of smart wearable devices. It's gone saying that my fasting is so much, my postprandial is so much. I can have a real-time mapping of my blood sugar, of my cardiac rate, rhythm, if I am getting an extra systole, by just wearing a small device on my arm or having a modification in my wristwatch. And this can be connected to a practicing doctor for monitoring. Make in India movement, which has been thrust upon us and which has been given the right kind of momentum from center, is enabling us to prepare instruments, to make joints, to make implants, And the cost of this, we now get beautiful laparoscopic surgery equipment which are made in India, which are tailor-made as to our practice. And therefore, in the years to come, we need to give thrust to the Make in India and the digital program. There will have to be e-hospital programs, and Ayushman Bharat schemes will give a heavy toll on digital, cashless work, paperless work, and IT platforms, because that will give you the data analytics and the trends of the practice that are likely to come. Geospatial intelligence to analyze the health risk of a category people. For example, Sangli virus. Is filariasis prevalent? Is malaria prevalent? Why this is happening? E-Large. It's a smart clinic that has been created in Karnataka and Rajasthan, and we can use the technology for that. And what we successfully used in COVID was artificial intelligence to map the X-rays taken in mobile X-ray vans in slums, in RE, and identify the potential high-risk people. Drones has already become a reality. Vaccines were shifted from place A to place B. So when UAIMS was being inaugurated at Dhamni Road, I said, Milind Parikh, it's time that we get clearance of flight paths, and tomorrow if some patient needs blood at Jaisingpur or even in the interiors or a medicine, or in a reverse way, his blood sample is to be brought to the hospital for analysis, I think we should employ drones. And this will go in a very, very big way in India, and health sector cannot lag far behind. When it comes to private practice, you may say, sir, these are all high funda things. What about my private practice? What are the challenges that I am going to face? One, patients will still continue to come late. We are now in that phase of task force that we are analyzing the dates that happened. It was a continuous ongoing process, but one common factor that came up very, very prominently was that patients came at least 2 or 3 days late, and then no remdesivir, no amount of steroids could stall the cytokine storm. That will continue to happen to us even today, that patients will visit to you late in the private practice. And why will it happen? Well, they will go in for self-medication. शेजारच्या बंडोपंतांना हे औषध दिलं होतं, मी 2 दिवस ट्राय करतो, कशाला डॉक्टरकडे जायचं? And then quacks will waste initial prime period. Medical quackery existed from time immemorial, and that will continue to happen. Patients want investigations, but they will complain of expenses. That's a problem that all of us face. Patients want each one of them to be seen by the main doctor only and not by his assistant. This will put a lot of strain on you physically. Patients also want instant cure like Nescafe, and therefore they love injections and polyprescriptions which you may not desire to give. Patients want their story to be told to each one of their relatives. They will listen and then say, जरा आमच्या सासऱ्याला सांगा, किंवा सासरा will say, जरा आमच्या शेजारच्या देशपांड्यांना, ते आमच्या घरातल्यासारखेच आहेत, त्यांना पण सांगा. And this really tests your patience, because you have to repeat the same story twice, thrice, 4 times. This is a problem in your private practice, but we have to accept it. If you tell them to get admitted, and admission counseling will be viewed with suspect. If you refer it to someone else, referrals will be smelled of cut practice. Vitamin makes doctors' credibility unquestionable. Even today in my practice, every patient will ask, "Sir, मुलाची जरा शक्ती वाढवण्यासाठी काहीतरी औषध किंवा व्हिटॅमिन द्या." And if I don't write it, and if I say, "घरात केलेली पालकची भाजी खा," I think my credibility is questioned. When it comes to payments, patients will always complain of exorbitant bill. And this is an Indian mindset. Don't feel that only poor patients from Miraj, Sangli, Hatkanangle and areas around will complain you. Every patient might come in a Mercedes Benz, but he will tell you, money concession apo. So when it comes to payments, patient will complain of exorbitant bill. Post-COVID, I think 30% people have lost their jobs and remaining 40% have got salary reductions. There is hardly any disposable income. So therefore, there is a tendency of postponing the planned work such as hernia, hydrocele, and small cell lumps and bumps. What could not stop was deliveries, was stroke, heart attacks, malignancies, and dialysis and renal failure. But barring this, I can tell you, every hospital in Mumbai struggled miserably and is still struggling with about 50% occupancy. So therefore, when it comes to payments, patients will complain of exorbitant bill and be prepared towards that. And above all, local bhai, bhau, bhai dada, local channel media, they are omnipresent. The less I talk, the better it is, or this can be a separate topic for a separate meeting at the level of AIM. But what is required for you and me, that if we can form groups, we can start conducting camps, stepping out of our private practice domain and go to their doorsteps. Reaching at the doorsteps is one of the solutions. Bottom-up approach. Go to the mother, go to the woman of the household. She is the one who usually self-neglects and is also neglected by the rest of the members. So bottom-up approach, starting from the lowest strata in the household and then going to the main and others is a reasonable approach that one can take. We need to tell our younger colleagues that yes, we are well aware that you paid for your admissions, you paid for your fees, you struggled very hard, you burned the midnight oil, and therefore you want returns. But don't expect the returns on the first day of life. There are certain things in life which are not to be bought, but which are acquired. And you can acquire them only if you are going to wait for a few more years. So there is a change of attitude amongst young doctors which is essential for the health practice. Confidence and trust building amongst people. We must again go to that level which existed 30-35 years back. की घरात जर कोणाचं लग्न ठरायचं असेल तर आपल्या डॉक्टर काकांचाही सल्ला घेऊया. I think we need to gain that particular position in the hearts of our patients. I never call my patients clients or customers. I hate in all the MBA colleges which I profess this terminology being utilized. They are not the cause, they are the purpose of our existence. So the patient feedback, it can transform the healthcare. And therefore it can happen in a multi-speciality hospital that you can record those responses on an iPad and analyze them, or in your small practice, you can talk to people and get them the first-hand information as to what they felt about the whole service that you rendered to them. When it comes to my branch and pediatrics, if we employ the newborn screening, every baby that undergoes birth undergoes a screening program, 30% of problems can be diagnosed which go undiagnosed and which present late. So such programs, it doesn't cost a huge amount of money. What is required is not the money, but the mindset of instituting such mandatory programs. So employ health counseling. When we streamrolled UAIMS hospital at Dhamini Road, I conceptualized a person who is called as Usha. So it is Usha of UAIMS, and this Usha will meet you in an attire and will counsel you, will answer every small question that you might have in your mind. There are questions in patients' minds who they want to ask, but they are afraid of asking to the healthcare personnel. And therefore you need counselors even in your own clinic who will advise your patients of all the doubts that they have in their mind. Mental health is second to none. And therefore your psychiatric colleagues, your psychological assessors, psychoanalysts and other colleagues who would conceptualize mental health in your practice will be going a long way in extending and increasing your outreach. Rehabilitation and prevention. By all the technology that we have got, we can add years to the life of a patient. But what is important is adding life to those years. I have myself undergone a bad COVID, and then pulmonary fibrosis was setting in. I had little options in front of mine. Either to go in for that anti-fibrotic drugs which are horrible and which have dastardly side effects, or rehabilitate myself by changing my job, by going into a next innings of my life, by slowing down a bit. And I can tell you that rehab and prevention needed its dues, which I gave in my life, and therefore I am able to work. But that's not the story everywhere. So rehabilitation and rejuvenation go hand in hand, and we have to be more respectful towards rehabilitation concepts. How do you design your OPD, your clinics? Look at the aesthetics. I'm going to show you a couple of designs. It's not very expensive. It is just application of your mindset. A few potted plants, a few lamps, indirect lighting, a jute carpet or even a lawn carpet, and tiled desk. It is not fancy. It is not expensive, but it is decent, and it is giving a comforting, a soothing effect on the patients and their relatives who are waiting to meet you. Look at your OPD. It is uncluttered. In fact, there is more of space. No awards, no shields, no medals, no oration landmarks, nothing. Just a few reference books. In fact, empty shelf, open space, ample light, and the doctor who is willing to give all ears, all listening to the patient. That is what is important. An examination desk, not even a rickety old iron bed, a rolled up tissue paper, a pillow, a revolving stool, and 2 small chairs for the patient's relative to sit and relax. So the patient is relatively relaxed that his relatives are around. Nothing of this takes huge amount of money. What it takes is an attitude of change, and that I think we need to have in the years to come. So in the private practice, don't overlook hiring and retention. It is significant. You must have assistants. Don't focus on every step from end to end. Sab kuch main hi karunga. Don't do that. Take advantage of partnerships and technology available. Manage your administrative burden and streamline the patient communication. Data entry is significant. Whatever you see, you come to a conclusion, decisions, you must enter and keep the data with you. Don't keep to you yourself. You can share it, and you must share it with your colleagues, because by sharing, we all will grow together. Getting a private hospital into a mainstream for a community is the need of the hour, and we are making that change in UAIMS Sangli. There are formal community medicine departments. My own son works into a community preventive oncology department of Tata Memorial Center as a staff member. I can tell you the discussion that I have with my son on the dinner table. I think he tells me about trends. He tells me about what is likely to happen in India in the next 10 years in the field of oncology. And I think looking into the future is the key of success for your presence. Get out of this advertisement approach. Bala uski kameez, meri kameez se safed kaise. If you want to be competitive, you have to be competitive with your own past, not with your colleagues. Dear friends, I find a very disturbing trend. I was okay with the competition amongst doctors, but now I find that companies like Ola, Uber, and those who have nothing even to do with the healthcare, with the help of technology, with the help of e-models, are entering into healthcare. They have no compassion. They have no concept of care. They are not the medicals. They have not burned the midnight oil, and they do not know that beyond the deceased body, there is a mind that needs solace. There is a tear which may be unshed, but which needs to be clear. And I think we in the next years, unless and until become mindful of these changes, such companies who have nothing to do with healthcare will appoint you and me on their panel, and not only will send the patients to us, but even direct us of what we should do to them. I don't want to continue practice into that era. I have been grown and thrived by Miraj Medical College and Wonders Hospital and Samani Civil Hospital on the love, on the brotherhood, and on the care and compassion to the patients, and I will cherish that throughout my life. So dear friends, on a wider panorama, let's work towards sustainable innovations, science-based startups, artificial intelligence, quantum computing of data, and cities which care for the climate. I have never said you should not market yourself, but I will say don't sell yourself. There's a difference in selling and marketing, and you must put across your SWOT analysis and your strengths. You must look at the threats and opportunities that exist, and you must market your assets to the fullest of your potential. Future of the healthcare, dear friends, therefore lies in your own hands. Thank you.
Thank you, Dr. Oak, sir. And the topic is open for discussion. If anybody has any questions from the audience, I would request them to please ask. Meantime, I will ask Dr. Oak, sir, one question. Sir, this new upcoming of these apps, mobile apps, which are coming in like Ola and Uber, which is probably affecting the people in big cities like Mumbai, Bangalore and all that. Probably it will take some time to come to the periphery. But these people are getting government permissions to do this activity. Is this fair and is this legal?
Well, nothing is fair or unfair in love, war and medical practice. That is what has happened. And don't be under an illusion that this is only happening in metros. No. When we were preparing, myself and Milind, for last 1 year, every weekend we have sat together for UAIMS, and we were awestruck by the offers that were made to us. Dr. Saib, तुम्ही आमच्यावर एवढं कॉन्ट्रॅक्ट करा, आम्ही तुम्हाला एवढे पेशंट्स देऊ. I'm sure Mohan is experiencing this in Pune. Satish will have such referrals. आणि याच्यात काय होतंय की पेशंट्स आर बीइंग टेकन फॉर अ राईड. आय गिव्ह यू एक्झाम्पल. जेव्हा आपण सगळे कॉलेजमध्ये होतो तेव्हा पहिल्यांदा बिग बाजार आलो, आणि बिग बाजार वॉज ब्रॉट आउट बाय मिस्टर बियानी. सुंदर पुस्तक त्यांनी लिहिलंय, इट हॅपन्ड हिअर इन इंडिया. आज बिग बाजार इज सोल्ड आउट. बिग बाजार हॅज बिकम एन एक्सटिंक्ट. आणि आज जर तुम्ही युट्यूब वरती गेला तर देर आर सिरीज ऑफ फिल्म्स टेलिंग वाय बिग बाजार फेल्ड. म्हणजे इथं काय होतंय, आम्ही अमुक एक नवीन गोष्ट करताना डोल वाजवतो आणि ती गोष्ट फेल झाली तरी डोल वाजवतो. मरतो कोण याच्यामध्ये? मरतो पुअर पेशंट, आणि ज्यानं एवढ्या कष्टानं प्रॅक्टिस बिल्ड केलेली असते तो डॉक्टर मरतो. मी नाव घेत नाहीये, पण FM रेडिओवरती एव्हरी 3rd मिनिट you have a healthcare agency which is making an appeal for lay people to register themselves. आणि मग तुम्हाला काय पाईल्स आहेत, हिमोरॉइड्स आहेत, फिस्टुला आहेत, अमका आहे, ढमका आहे, आम्ही तुम्हाला डॉक्टरकडे पाठवू. म्हणजे लुक एट दिस सिच्युएशन की ज्यांचं मेडिकल कॉलेजशी गंध नाहीये अशी माणसं ठरवणार की पेशंटला सतीश पत्कीकडे जायचं, सतीश खाडीलकरकडे जायचं का संजय ओककडे जायचं. हे थांबायला हवं. आणि हे थांबायला तुम्ही म्हणता तसं गव्हर्नमेंट रूल्स अँड रेग्युलेशन्स, पण गव्हर्नमेंट ऑलवेज वेक्स अप 1 day आफ्टर. एवढं लक्षात ठेवा.
Dr. Sanjay, I would like to ask you 2 or 3 questions. The last thing you explained regarding these non-medical companies are entering into the medical field. Do you think they are going to create problems later on?
100%.
So what do you see as the future in that?
याला फ्युचर उत्तर एकच आहे, आपण काळाची पावलं ओळखून आपण एकत्र येऊन आपण हेल्थ सेक्टर म्हणून ती माझी जी शेवटची स्लाइड आहे की मार्केटिंगची गरज आहे. सेल नाही करायचं, आपण विकायचं नाही स्वत्व, परंतु मार्केटिंग मध्ये मॅनेजमेंट कॉलेजेसमध्ये किंवा मी जेव्हा MBA करत होतो हे नेहमीचे प्रश्न होते की सर व्हॉट इज द डिफरन्स बिटवीन सेलिंग अँड मार्केटिंग. सेलिंग इज अन आउटराईट, माझ्याकडे हे घड्याळ आहे 5,000 रुपयाला हे मी देतो, दिस इज सेलिंग. पण मार्केटिंग जेव्हा जेव्हा आपण म्हणतो तेव्हा त्याच्यामध्ये रिसर्च इन्व्हॉल्ड असतो की मी शिशिर गोसावींकडे का जावं, मी अमक्या डॉक्टरकडे का जावं, त्यांचं प्रोफाईल काय आहे, त्यांनी काय केलेलं आहे, मी 4 पेशंट्सना विचारतो. ह्या गोष्टी आजवर आपले रुग्ण करत आलेले आहेत शिशिर. आय फिअर की ह्या पुढच्या काळात ते राहणार नाही. हे अमेरिकेत झालं. मॅनेज्ड हेल्थ केअरचा ही सुरुवात होती. आज मोठी हॉस्पिटल्स, आज तुमच्या डॅडींनी हॉस्पिटल बांधलं, आपण सगळे शिकत असताना पुजारी सरांचं हॉस्पिटल, कुलकर्णी सरांचं हॉस्पिटल, वी हॅव ग्रोन ऑन दिस. आज हॉस्पिटल्स आर ओन्ड बाय पीपल हू कन्सिडर दॅट ॲज वन ऑफ द कमोडिटी. त्यांचा काही घंटा हेल्थ केअरशी संबंध नाहीये. दे वॉन्ट टू पुट मनी, दे वॉन्ट टू गेट इट बॅक. आणि हे हार्मफुल आहे पेशंट्स ऍज वेल एज आपल्या सर्वांच्यासाठी. एवढंच मला अंडरलाईन करायचं.
That's what I wanted to say. The only thing is here the people who are putting in money in the health sector, they are basically big industrialists or groups.
Absolutely.
Now doctors cannot invest so much of money as the industrialists or these big people or NRIs. They can invest and create the big hospitals, especially in tier 1 city or tier 2 cities. So ultimately the doctor is at their mercy that these people are helping so that we can create hospitals and give the, but these people are not interested in anything quality wise practice. They just want to, they will see that the money comes back to them.
Back. Yeah. Hey Shishir, we are on the same platform. तू तेच म्हणतोयस जे मी म्हणतोय आणि म्हणूनच मला असं वाटतं की UAIMS has been one example. पण मी अशा आणखीन 4 प्रोजेक्टसाठी महाराष्ट्रामध्ये आता मदत करतोय की जिथं सी देयर आर 2 मेन प्लेयर्स. वन इज गव्हर्नमेंट. गव्हर्नमेंटच्या इतकं श्रीमंत कोणी नसतं. गव्हर्नमेंटनी मनात आणलं तर मी गव्हर्नमेंटला सांगतोय तुम्ही टायर 2 आणि टायर 1 आता समजा पुणे आणि सातारा आहे, शिरवळ आहे किंवा आणखीन एखादं उडतारे आहे, अशा ठिकाणी टायर 2 लेवल आहे जिथे जमिनीचे भाव रिलेटिव्हली कमी आहेत ऍज कम्पेअर्ड टू मुंबई पुणे. 25 एकरची जमीन द्या आम्हाला. आपण इंजिनिअरिंग क्षेत्रासाठी स्पेशल इकॉनॉमिक सँक्शन झोन तयार केलेले आहेत. कोकणात जाताना लोटे परशुरामचा झोन आहे, औरंगाबादच्या बाहेर आहे, मनमाडच्या बाहेर आहे. हेल्थ सेक्टरसाठी ACZ द्या, तिथे पाण्याचा रेट वेगळा असू दे, इलेक्ट्रिसिटीचा रेट वेगळा असू दे. आम्ही 10 डॉक्टर एकत्र येऊन आमचं भांडवल घालून लोन्स काढून हॉस्पिटल्स बांधू. प्रत्येक हॉस्पिटल 200 बेड्सचं होण्याची पण गरज नाही. I think for a modest size of 75 to 100 beds is an ideal size. पण झाले काय शिशिर, माझा 10 बेड्सचं नर्सिंग होम चालवण्याचा काळ आता संपलेला आहे. आणि हे आपण जितकं लवकर ऍक्सेप्ट करू ना तेवढं आपण यातनं वाचू.
What you said is absolutely correct. आणखीन एक just one more point I want to ask you on your opinion. Now most of these people and doctors who are practicing in cities like Miraj, Sangli or Kolhapur, they are in private practice. They have their own clinics. There is not much of a group practice. And they face lot of difficulties dealing with government authorities and bureaucrats and the local city managements like corporations. So that's a big challenge. Rather than academical challenge, we are facing these problems more. And second thing, social media also, because of the WhatsApp and Facebook, everybody posts anything against the doctors and the doctors has to face, and that goes viral immediately. So what do you feel? Means there is no future.
तुझे मुद्दे अतिशय बरोबर आहेत. ओव्हरऑल कोणीच आपल्या बाजूनी नाही, हे सत्य आहे. ना समाज, ना मीडिया, ना राजकारणी, ना कोर्टात खुर्चीवर बसलेला जज. प्रत्येकाच्या दृष्टीनं डॉक्टर हा सर्वात मोठा कल्प्रिट, पैसे कमवायला बसलेला, ज्याचं मानवतेशी काही घेणं देणं नाही, अशी इमेज झालेली आहे. पण काही अंशी त्याला आपल्यातले काही भाऊबंद जबाबदार असतीलही, पण मोठ्या प्रमाणामध्ये अजूनही डॉक्टर मनापासून चांगलं काम करतात, हे सत्य आहे. आणि हे पटवून देण्याचा आटोकाट प्रयत्न मी माझ्या आयुष्यावर करतोय. गव्हर्नमेंटच्या लेवलला ज्या परमिशन्स आहेत, मी परत मिनिस्ट्रीमध्ये आणि ऑनरेबल सीएम ना सांगितलंय की ठीक आहे, तुम्ही आमच्याकडे 1 नाही 10 परमिशन्स घ्या, पण 1 विंडो करा आणि एका वेळेला 10च्या 10 गोष्टी मागा. आणि एक न्यूज दिल्यावरती तुम्ही दुसरा मागता आणि ह्याच्यात जी आमची ससे होरपट होते ही होऊ नये म्हणून 1 विंडो पद्धत, जसं टुरिझम इंडस्ट्रीला आता करतायत, इंडस्ट्रीमधल्या लायसन्सेस साठी करतायत, तसं मला वाटतं पुढच्या भविष्य काळामध्ये वैद्यकीय क्षेत्रासाठी आपण करून घेऊ, हे नक्की आहे.
Okay, sir. Dr. Soto speaking.
Sir.
See, nice to see and nice to hear. See, I have a question. A lot of government, for example, recently we heard UP मध्ये 15 colleges होते, आता 63 colleges केले. Is the number important or the infrastructure, the working, improving the existing facilities rather than number is increasing? What do you feel? Because we are connected with some government areas.
Sir, I agree with you, but I have a different opinion here which I am putting across to government. Sir, if you look at medical admissions and a candidate getting into a medical college, I have always told my parents that I thank you not for becoming a doctor, but for giving me birth before NEET came into being. सर, नीट एक्झाम असते ना तर मी तुमचा विद्यार्थी कधीच होऊ शकलो नसतो, मला मेडिकल ऍडमिशन मिळाली नसतीच. हे जे काही चालू आहे ना, ह्यातनं बाहेर येण्यासाठी हे एक आहे. दुसऱ्या बाजूला सर रिझर्वेशन पॉलिसीज, मला त्याच्याबद्दल काहीही म्हणायचं नाहीये, मी म्हणायला फार लहान माणूस आहे, पण सर ओपन मेरिट मध्ये अभ्यास करून ऍडमिशन मिळाले आणि त्याच्यावरती पुढे करिअर झाले, हे जे आमच्या आयुष्यात झालं सर, हे ह्याच्या पुढच्या पिढीमध्ये होते अशातला भाग नाहीये. मला माझे विद्यार्थी म्हणतात, सर सर्जरीत पहिला आलो, उपयोग काय, एमएसची ऍडमिशन कुठे मिळणार? सर, ह्या सगळ्या दुष्टचक्रातनं बाहेर यायचं असेल तर वी नीड टू इन्क्रीज. प्लस कोविडच्या वेळेला जे लक्षात आलं सर, डॉक्टर्सच राहिले नव्हते, आयसीयूत जायला कोणी तयार नाही, 60च्या वरच्या लोकांना आम्ही आज पाठवू शकत नव्हतो आणि जे यंगस्टर्स आहेत त्यांचे बळी दिले जातो. हे कशासाठी? सो फायनली सर मी असं म्हटलंय की आपल्याकडे 35 डिस्ट्रिक्ट आहेत महाराष्ट्रामध्ये. पालघर हॅज बीन द लास्ट ऍडिशन. प्रत्येक डिस्ट्रिक्ट मध्ये सर ऍटलीस्ट 150-200 बेड्सचं सिव्हिल हॉस्पिटल आहे. सर, व्हॉट एव्हर वी आर टुडे, वी आर बिकॉज ऑफ यू, सी थॉमस सर, एज आय मेन्शन्ड यू फ्यू days back when I met you, because of Purohit sir, Diwan sir, and we carry that gratitude in our mind. Civil hospital and mission has made us. So sir, मी जेव्हा आता शहापूर सिव्हिल मध्ये काम करतोय गेली 4 वर्ष, सी गव्हर्नमेंट took up the notice की तुम्ही काम करताय का, they made the theaters modular. Imagine sir, at a sub-district level hospital, improvements can be made. So therefore I am telling government, 35 medical colleges district level ला connect करा, 100 admissions द्या, 150-200च्या नादाला लागू नका. Now the next question is teaching staff कुठं आणायचा? So I am telling NMC, National Medical Council, relax your archaic resolutions and rules of recognition of a teacher. Employ technology. नवीन मेडिकल कॉलेज मध्ये व्हर्च्युअल क्लासरूम हॅज टू बी इंटिग्रेटेड. मग जे शिकवायचंय सर, तुम्ही मिरजेत बसून एखादं लेक्चर घ्या, महाराष्ट्रभर रिले करू. सगळ्या मेडिकल कॉलेजेस मध्ये दिवसात शिकवायला पाहिजे असं काही नाही. मेडिकल कॉलेजेस 2 शिफ्ट्स मध्ये चालू. सर, लुक ॲट माय केईएम, 2200 बेड्स विथ 110% ऑक्युपन्सी. बेडवर सकाळी एक पेशंट, संध्याकाळी दुसरा पेशंट असतो. But after 4 o'clock, no professors, no associate professors, and the patients are left to the mercy of a young trainee, lecturer and registrar. Can a medical college like this not run into 2 shifts? There will be a morning shift, there will be an evening shift. Can an honorary not come in the evening? Can a full-timer not come in the evening and do his private practice somewhere? All these permutations and combinations will change a lot of thought process and attitude. But there is no doubt, sir, we must increase the number of seats. We must give better weightage to our tier 2 cities and district hospitals. We must put technology in use for teaching also. Sir, when I was a vice chancellor of D.Y. Patil University, I created perhaps the best of the simulation laboratories in India and a virtual classroom, and they are using it, sir. These are the changes which should happen for our future.
Sanjay sir, you have touched a very sensitive issue regarding medical colleges and seats. Now that last year, 2021 PG admissions are not yet done. That you know very well. But almost 1 year has gone, and don't you think the courts are making too much of interference in medical college admissions? Because this year also,
everybody has a right to go to court. त्याच्यामुळे हे होणार आहे. मला पुढची डिफिकल्टी दिसते. अजून ऍडमिशन चालू आहेत. मॉपअप राउंड आता होतोय.
Even
I picked up a phone and talked to the vice chancellor of university कि madam, these students are getting in the medical college first year in the month of April, and we are planning an exit examination of first year in the month of October, November. What kind of anatomy, physiology they are going to learn? So these are the problems which are happening. कोर्ट आणि शिशिर आयुष्याच्या प्रत्येक परिघाला हल्ली कोर्ट स्पर्श करते असं झालेलं.
The thing is, the students have already joined. They have retained the seat. They have joined the colleges, and again the Supreme Court says that you go back to the round 1, round 2, whatever they have. So the student has to go from Miraj to Jalgaon, Miraj to Yavatmal, cancelling the check, then again get a new DD and go to the other college. It is very, very difficult for the students. Don't you think that because of only 140 seats?
It is difficult for the student. Shishir, it is difficult for the student. It at times becomes impossible for the parents. कारण 7 लाख 8 लाखाचा डीडी कॅन्सल करायचा, तो क्रेडिट होणार, नवीन डीडी काढायचा. इट्स नॉट इझी ॲट ऑल. पण ह्या गोष्टी विचारातच घेतल्या जात नाहीत असं होतं, किंवा यांचं रिप्रेझेंटेशन कमी पडतंय. मला तर हाइंडसाइट मध्ये असं वाटतं, आपल्या वेळेला जे होतं ना, ज्यानं त्यांना आपापल्या रिजन मध्ये मेडिकल कॉलेजमध्ये ऍडमिशन घ्यावी आणि शिकावं, आय थिंक दॅट वॉज बेटर, अँड यू शुड हॅव केप्ट ओनली सुपर स्पेशालिटी पॅन इंडिया. दुसरं काही नाही.
Hello.
Thank you.
Can we stop here, sir?
Yeah, I think, sir, in the interest of time, I think we'll close because it's an everlasting debate and which will never end. And it was great interacting with you. IMA will go back home thinking, and we had a wonderful time with you, sir. Thank you.
Thank you very much, sir.
Thank you to Soltu,
Thank you, Sanjay, sir.
Thank
you very much.
Ajit, all the best to you and your team.
I request our Honorable President, sir, to honor our chairpersons, Dr. Shishir Gosavi and Dr. Sharad Desai. Bouquets. Hello. Without wasting time, we'll go for the next lecture by Dr. Mohan Magdum. For this session, I request our eminent physician, Dr. Shirish Sawan sir, to be on the dais, and I also request Dr. D.G. Mote sir to come on the dais as chairpersons. The topic of Dr. Mohan Magdum is thyroid disorders. We are running by at least 15 to 20 minutes behind the schedule. I think by 2 o'clock or within 2 o'clock we should finish this because we are going to have one more lecture after that. I hand over the mic to Dr. Shirish sir and Dr. Mote sir.
Hello. I welcome Dr. Mohan Magdum, eminent endocrinologist from Pune. Dr. Mohan Magdum is a product of Miraj. He did his MBBS from Miraj Medical College, Government Medical College. Then post-graduation also from Government Medical College. He was working in Wanless Hospital as well as Sangli Civil Hospital. Then he did his super speciality in Lucknow Medical College, did his
DM endocrinology, and for last 15 to 20 years he is working in Pune as an endocrinologist, a very eminent figure in endocrinology. And the topic which has been given to him, okay, he has changed the topic, that's good. Because thyroid disorders was a broad topic which was actually given to him, but he has squeezed it to thyroid disorders in pregnancy. And so let us listen him.
Thank you, Chairperson. Good afternoon, everybody. I'm very pleased to come back to Miraj, which is my alma mater, as Dr. Shej already mentioned. My MBS MD is from here. And speaking over here after Dr. Oak's discussion, I remember my UG days. We used to call Sanjay, Dr. Oak, and thereafter our friend was Oswal. So every time he used to go for Viva, right from the anatomy, then second year, final year. Oswal, Ramesh Oswal used to face a lot of difficulties, and he used to always give him gali to him. अरे तुझ्यानंतर मला व्हायवा द्यायला लागते आणि सगळं प्रॉब्लेम होतो मला. तसं काहीच समथिंग आहे. आफ्टर सो ड्रामॅटिक अँड हाय व्होल्टेज टॉक बाय डॉक्टर ओक, I am here in front of me, and that also bring back many memories from my college days. मी अगदी फर्स्ट इयरला गेलो त्यावेळी फर्स्ट डे कॉलेजचा, आणि तिथं कॉलेजच्या गेटच्या बाहेर उभं होतो. थोडंसं घाबरत रॅगिंग वगैरे ह्या गोष्टी होत्या, आणि मला तिथे एक स्टुडंट भेटला. तर आय वॉज थिंकिंग पॉसिबली इज सिनियर. तो माझ्याजवळ आला, अरे काही घाबरू नको, मी तुमच्याबरोबरच आहे, माझी दाढी वगैरे म्हणून मोठा दिसतो मी, आणि तो म्हणजे आमचा अजित सिंग चड्डा. आणि देन मेस जॉईन केली. तर तिथे अगदी पहिला एक दुसरात मी डॉक्टर सतीश पत्की यूज टू हॅव मिल, गुजरात मेस होती ती. अशा अनेक मेमरी आहेत. PG मध्ये माझा रूम पार्टनर उदय पाठक होता. सो ही यूज टू बी देअर, आणि बऱ्याच वेळा होम स्टुडंट सिटी स्कॉलर्स प्रमाणे, त्यामुळे आय वॉज देअर ॲज अ होल ऑक्युपंट ऑफ द माय हॉस्टेल रूम. आणि आय वॉज व्हेरी हॅपी टुडे टू सी माय प्रोफेसर सोटूर सर, ज्यांच्याकडनं मी कितीतरी क्लिनिकल मेडिकल ॲक्युमेन शिकलो, आय विल से, अँड दॅट इज युजफुल थ्रू मेनी ॲस्पेक्ट्स ऑफ द मेडिकल प्रॅक्टिस. आणि माझे कितीतरी फ्रेंड्स सुद्धा आहेत. डॉक्टर बापट दिसले मला अवधूत, आणि सो मेनी फ्रेंड्स सिनियर्स. सो आय एम व्हेरी हॅपी टू बी हिअर. मला टॉपिक वॉज सजेस्टेड थायरॉइड डिसऑर्डर, बस आय थॉट की इट वुड बी टू ब्रॉड आणि काही जस्टिस होणार नाही, तर मी एक त्यातल्या त्यात थोडा एक एरिया फोकस केला, अँड दॅट इज थायरॉइड डिसऑर्डर्स इन प्रेग्नन्सी. As you know, thyroid is a very important hormone, and it is there with us from womb to tomb, I would say, and it works right from head to toe, from the hair to the nails, everywhere it has work. It is something like शेगडीमध्ये चुलीमध्ये जसा काकडा असतो तसं ते to start that furnace, तसं थायरॉइड हार्मोनचं काम आहे. आणि थायरॉइड हार्मोन एंटर्स इन एव्हरी बॉडी ऑर्गन, एव्हरी बॉडी सेल, आणि सेलमध्ये ॲट न्यूक्लिअर लेवल्स इट एंटर्स, आणि जिथे DNA पासून ट्रान्सक्रिप्शन नंतर ट्रान्सलेशन होतं, प्रोटीन्स बनतात त्या ऑर्गन स्पेसिफिक, त्या एव्हरी स्टेपला थायरॉइड हार्मोन इज अ कॅटलायझर, अँड दॅट इज व्हेरी, इट्स प्रेझन्स इज इम्पॉर्टंट. आणि थायरॉइड हार्मोन नसेल तर बऱ्याचशा आपली बॉडी स्लोज डाऊन, इट बिकम्स आपली जशी एखादी भट्टी शांत होईल इंधनाशिवाय, तसं इट इज अ एनाबॉलिक हार्मोन, एक्सेसमध्ये कॅटाबॉलिक होतं. सो आय विल restrict and discuss thyroid disorders in pregnancy. So briefly, thyroid physiology. Thyroid pregnancy is like is a natural stress test for a thyroid gland. त्यामध्ये usually pregnancy estrogen levels are up. It leads to increasing thyroid binding globulin, and that's why binded hormones, that is total T3 T4 increases. And we see in pregnancy T3 T4 increase up to 1.5 fold. It is normal. We need not repeat it. Rather than doing the pre T3 T4, many assays are difficult to do in day-to-day labs. We can do just T3 T4 assay, total T3 T4, which is quite reliable. And up to 1.5 higher range we can accept is normal in pregnancy, rather than relying on some unreliable pre T3 T4 assay. Then one of the important hormone, that is human chorionic gonadotropin, which comes from placenta, that has a structural homology with the TSH, and because it starts working like TSH, and TSH stimulates release of T3, T4 hormone, and because of that, what happens that the pituitary gland perceives there is no need of TSH secretion, and TSH secretion goes down in the first trimester, especially between 8 to 14 weeks. And many times, most of the times we find in early pregnancy, we do thyroid screening and TSH is low. And then patients are referred to us, which are physiology. So low TSH in first trimester, we usually should not worry unless patient is symptomatic and you suspect, then you can go further testing. When the peripheral metazolam thyroid hormones increase, T3, T4 clearance is then, plasma volume is high, and then non-function of fetal thyroid is there. So altogether this puts the increased demand of thyroid hormones for a pregnant lady in up to 30 to 50% of thyroid hormone requirement would be increased. So normally a lady whose thyroid is normal, functioning well, there she can compensate with that increased thyroid function. But a lady who is hypothyroid and taking thyroxine hormone, so we should remember we have to increase the dose of thyroxine. So immediately rule is that diagnosed pregnancy, thyroxine dose 1 tablet per week has to be increased, and then as per the reports you can decide. So because of the HCG homology with the TSH, the changes occur, and by the end of first trimester usually HCG levels are high, and that time usually around 12th week TSH goes down. So this is a graphic presentation. The solid line is TSH secretion and dotted line is the HCG secretion. As you can see, HCG keeps on increasing. By the end of first trimester, it is at peak, that time TSH is low. So that is the physiology. And especially the ladies who are having hyperemesis gravidarum during first trimester, which naturally occurs there, it is more pronounced. And with that, sometimes that HCG can even stimulate thyroid gland, and patient actually can become thyrotoxic, what we call hashitoxicosis. So that is transient, but proper thyrotoxicosis can also very, very rarely develop. We may have to treat sometimes. Then we have to screen for thyroid disorders during pregnancy, and there are various studies, and depending on the what TSH cutoff was done, number of women with thyroid disorders were picked up. So if cutoff is high, more than 4, so more number of pregnancies or women were missed that are having thyroid disorder. So almost 50% of pregnant women with thyroid dysfunction can be missed if the TSH cutoff is something like more than 4.55, which we consider for non-pregnant women. So one of the survey like American Thyroid Association, it was taken members like whether we should do universal survey or case based. So 74% were for the universal survey, 18 engaged and 8 undecided. So most majority of thyroid specialists feel that it should be the universal screening. And why universal screening? Because it is a cost effective, beneficial in screening, and with that we can improve fetal and maternal outcomes. And even if we err and treat with a small dose of thyroxine, that is not going to harm the patient. But if we err and give thyroxine small dose in subclinical hypothyroidism also, so that should not, that would help in reducing the complications. So Indian Thyroid Association, Thyroid Society and FOXI, they have recommendations, and we go by recommendation and evidence-based practice we follow. So all pregnant females should be screened at first antenatal visit by measuring TSH level, that is ultra-sensitive TSH, and it is a level 2 evidence. So that means the various studies support to that. So all the females who become pregnant in antenatal first visit only, they should be screened for TSH. And what are the values for the TSH in pregnancy? If you look at second line, that is European Thyroid Association guidelines, then Indian Thyroid guidelines, they say first trimester it should be 2.5 cutoff, second, third it should be 3 cutoff. While American Thyroid Association says that the reference range that should be established for that particular population, suppose we are Western Maharashtra, the reference should be established for Western Maharashtra, like all over the country. Since India is a very big country, it would require various studies to establish cutoff for the particular levels. As long as those levels are not available, what we can do, to take the upper limit. So for upper limit is 4 of TSH level, then reduce by 1 and take 3 as the upper cutoff. So somewhere it would come around 3 only, and first trimester it is guided by 2.5. But if we take cutoff line of 4.5, then we can diagnose only 10 to 15% of the ladies with hypothyroidism, and we may miss many hypothyroidism which may evolve over a period of time during pregnancy. Vis-a-vis, if we consider levels of 2.5 in first or 3 in second, then we can pick up more patients, and that way we can, and this is a Indian study with across the almost 11 cities, 9 states, so that India specific, so that we can pick up more borderline patients with hypothyroidism, and we should. So that's why the ITS Proxy guidelines, the recommendation is first trimester TSH cutoff is 2.5, second and third is 3. Now, when we consider thyroid disorders, two broadly disorders would come to our mind is hypothyroidism and hyperthyroidism and maybe thyroid nodules. And if hypothyroid remains untreated during the pregnancy, it can lead to complications. It can be maternal complications, fetal complications, neonatal complications like maternal anemia, preeclampsia, placental abnormality, placental abruption, hemorrhage, and so on. And fetal, if it is a gross hypothyroidism, then cognitive impairment, neurological abnormalities, there can be drop of IQ up to say 7 digits. So 7 digit may sound small, but for average child, if 7 digit, 100 minus 7 digit IQ, so that may be a detrimental throughout life in career opportunities, how smart that child becomes. Then there can be neurological abnormalities like communication skills may be different in the children who are born. So this is the biggest study was there where the retrospective samples were tested, and it was seen after their children were followed for 2 years, 8 years, and their emotional and intelligent quotients were and neurological development was assessed, and from that it was deduced. And development abnormalities can be there, and some other abnormalities can also be there. So overall and subclinical thyroid dysfunction among pregnant women, that is Indian study, if we look that the overt hypothyroidism, that is the violet, so complication like pregnancy induced hypertension, gestational diabetes, IUGR, intrauterine death, they are higher as compared to control who are not having hypothyroidism during pregnancy. And as well, the delivery outcomes, neonatal outcomes, variables, they are also altered, and with overt hypothyroidism, subclinical hypothyroidism, cesarean section rate would increase, distress, fetal distress leading to cesarean section, that will increase, Apgar at 1 minute, that is reduced, and neonatal complications would be there. So it is very important to pick our patients in terms of hypothyroidism, as I mentioned from the first antenatal visit only, and if we follow the cutoffs 2.5 and 3, and by that doing that, even if we err in treating some patients which possibly may not require, even then we are not harming them, but definitely we are giving much beneficial outcome. Then there is entity called subclinical hypothyroidism where borderline TSH is raised but T3, T4 is normal, so that we call subclinical hypothyroidism. So whether we should treat that, so pregnancy in women subclinical hypothyroidism more likely complicated with placental abruption, and they have almost 2% higher chances of preterm birth. So various studies have shown that if you look at carefully the yellow bracket, that is relative risk. So relative risk increases with subclinical hypothyroidism untreated. Entities like pregnancy loss, placental abruption, neonatal death, they are higher. Relative risk is almost double, 2. So subclinical hypothyroidism during pregnancy is associated with these kind of fetal and maternal complications. That's why we need to treat it. So if we go nitty-gritty and do the antibody, one antibody we can do that we all are aware, and it is widely available now, anti-thyroid peroxidate, or what we call TPO antibody, or anti-microsomal antibody. It is available something 600, 800, not very costly. And those women with TSH 2.5 to 4 and TPO negative, there is no significant change. But if TPO antibody is positive or TSH is more than 4 and we treat it, then we are going to reduce the outcomes like pregnancy loss or preterm birth, which we can prevent by treating them. So how should we manage the hypothyroidism during pregnancy? During pregnancy, like overt hypothyroidism, TSH more than 2.5 or more than that, we should treat it. And overt hypothyroidism, when TSH is quite high, T3, T4 is low, then becomes hypothyroidism, overt. And we should treat, as we know, adult dose is 1.6 microgram per kg a day. So for 50 kg, it would come something like 75 to 80 microgram dose would be there. And then target should be less than 2.5. And for pre-existing hypothyroidism, as I mentioned, if patient already on taking thyroxine, we should increase at least 1 dose per week, around up to 30% dose may be required to increase. The dose increment keeps on going till say maybe 5th month of pregnancy, and till then we should follow every 4 to 6 weeks, and thereafter maybe at 28 weeks. So at least till 5th month of pregnancy we should follow monthly, at least we should do the TSH, follow the patient. Patient's subclinical hypothyroidism, it is recommended when TSH is more than 10 or antibody is positive, and it should be considered, even though it is not say compulsory, it should be considered in where TSH is more than 4, so patient becomes subclinical hypothyroidism. And as I mentioned, by a ring and giving a small dose of thyroxine, we are not going to harm the patient and fetal, but if at all we are going to prevent some of the neonatal and maternal complications. And if TPO positive, TSH more than 2.5, we should 2.5 to 4 also we can treat it to prevent these complications, or at least we should follow these patients say monthly to do TSH, so that we should not miss that, because TPO positive means they are having autoimmunity, thyroid autoimmunity ongoing in the body, and that may lead to overt hypothyroidism or advancement of hypothyroidism during the course of pregnancy, so we should follow them. Then postpartum period, suppose post-delivery, we can reduce the dose back to the normal what was pre-pregnant, and then repeat the test after about 6 weeks. That is pre-existing hypothyroidism. But if it is subclinical hypothyroidism diagnosed during pregnancy, then we should start, we started the dose maybe 25, 37, 50, and that dose if less than 50, then we can even stop after the delivery, and then we can assess the TSH after 6 weeks. But those who are having autoimmunity, that is thyroid antibodies, TPO antibodies most commonly done, but thyroglobulin antibodies also there, which may indicate that some maybe 10-15% of people who are TPO antibody, microsomal antibodies negative, they still may have thyroglobulin antibody positive. So if autoantibody is there, then we have to monitor them maybe initial postpartum period after 6 months, 3 months, 6 months, and then yearly. So women who are having a thyroid autoimmunity, but they are euthyroid, and what was seen that their outcomes of preterm delivery is slightly on higher side. These are various studies. Relative risk, that is one you can see, that is say you can say is normal. So anything which is on the right side, that shows that there is increased risk of delivery risk, though almost all the study horizontal bar are at the crossing midline. So that means that it is not statistically significant. But the overall trend, if you see, it is on the right side. The fixed line effect is coming on right side. That means the meta-analysis varies almost 11 studies. They show that preterm delivery risk is there when woman is having thyroid antibodies. That's why it is said that a woman is having during pregnancy antithyroid antibodies positive strongly. And positive means they are strongly positive. Suppose cutoff is 35 and our value is 60 or something. That is not, that we can see in general population also, in the relatives also. But when positive means it goes in 100, more than 700, more than 1000, like that. That is the real positivity, and that kind of positivity is there. There is some risk involved in terms of preterm delivery, even miscarriage. Why? Possibly when autoimmunity is going against thyroid, it is not only against thyroid, overall autoimmunity goes in the body, and the fetus is not part of only mother, it is part of father also. And any foreign object, so father's part foreign object, any foreign object is tried to rejected by the pregnant lady's body. So that way fetus might get rejected if any other autoimmune process is also going on. By and large, autoimmune processes are cooled down during second, third trimester in the pregnancy. But women who are euthyroid and they are antibody, they are the miscarriage, preterm delivery, that is there. But if we give small dose of thyroxine, this is one study of course, with small number of patients, still the double blind and big study is not done, but one study suggests that those people who are women who are treated with a small dose of thyroxine, as you see with the green bar, vis-a-vis those who are not treated and antibody positive, red bar. So preterm delivery as well as miscarriage incidence is much less. And again, by erring and giving small dose of thyroxine during pregnancy in antibody positive, you are doing no harm, but possibly will give benefit to the lady. Earlier there used to be many pregnancies, 3, 4, half dozen, 1 dozen, maybe 2, 3 generations back, but now every pregnancy is very valuable. Couples go for maybe only 1 pregnancy or 2 pregnancies. So all these things we have to consider. So pregnancy outcomes like preterm delivery and neonatal, with those who are not treated, slightly increase. So the pregnancy should be monitored with the TSH at least every trimester and up to 2nd trimester, and then this small dose of thyroxine therapy we can consider. So apart from hypothyroidism, hypothyroidism is a major chunk of thyroid disorders. Smaller chunk of the thyroid problems is hyperthyroidism, and it is very minimal, but still that can be in pregnancy. It is as low as 0.05 to 0.2% in pregnancy. So very small proportion of pregnancies they may counter hyperthyroidism, and mainly it is due to Graves' disease, 80 to 85%. Other maybe a toxic nodule or something, and subclinical hyperthyroidism may be a bit common, and it can be because of the rising HCG level during early pregnancy, so that may worsen the problem which is pre-existing. And hyperemesis gravidarum, where HCG levels are high, that may be associated with subclinical hyperthyroidism. So a pre-existing Graves' disease in pregnancy, what happens? During the first trimester, the symptoms of Graves' disease are aggravated, but the HCG levels are up from the placenta, and HCG acts like a TSH, stimulate thyroid, and T3, T4 would increase. So pre-existing Graves' disease in first trimester may actually worsen. Then 2nd and 3rd trimester, it may cool down because the TSH stimulating antibodies go down. Most of the autoimmune disorders, they are cooled down during the 2nd and 3rd trimester. But after delivery, that protection from the autoimmune disorder goes off, and after delivery, that is postpartum, again the flare of the hyperthyroidism can be there. So all the obstetric medical complications, they are directly related to control of maternal hyperthyroidism. Depends how good hyperthyroidism is in control and how long patient was euthyroid prior to pregnancy and throughout pregnancy. So that will decide the outcome. If patient was thyrotoxic, as not very good control, then various complications as we discussed earlier, PIH, prematurity, low birth, intrauterine restriction, growth restriction, stillbirth, and all those can happen. Then we have to treat the pregnant lady who is having hyperthyroidism. If hyperthyroidism is there, there is no recommendation that we should advise termination of pregnancy. No. If hypothyroidism is there, there is no recommendation we should advise termination. No. Recommendation is not there. But we should make aware patient that these are the possibilities and complications. So patient has to take decision. But when we treat with anti-thyroid medicine, thyromide derivatives, like what we call routinely used carbimazole, then methimazole is also available, and now PTU is also available. So with these medicines, the various complications like skin complication is common, aplasia cutis. So that is non-formation of the scalps. It is like something like burned scalp, it may appear, but over a period of time it heals. Then choanal atresia is one of the common thing. What does it mean? Means the nasal bone, rather nasal hole in the skull, that is not formed. It may be unilateral, it may be bilateral. So if unilateral it is okay, but bilateral, then the nasal infection, cyanosis, and on those things can develop, tracheoesophageal fistula. Other complications can be unforwarded anus, microcolon, like GI complication can be there. Then facial asymmetry, zygomatic arch asymmetries can be there. Ventricular septal defects can be there. Though they are rare, these are the possibilities with anti-thyroid therapies. So if patient is planning pregnancy during hyperthyroidism, we should advise they should plan pregnancy once the dose comes down to minimal, maybe 5 to 10 milligram of carbimazole and methimazole, and then voluntary we can switch them to PTO, which crosses the placenta to least. But best advice is, if hyperthyroid is not controlled, best advice would be to administer radioactive iodine 131 therapy, render patient hypothyroid, and then after 6 months a patient can plan pregnancy. But in day-to-day practice, I see many young ladies, they are not accepting radioactive iodine therapy. They perceive that they are going to become hypothyroid for lifelong, and that is not good. So they don't accept, they stick to anti-thyroid therapy. So at least we should continue them treating, gradually tighter down the doses from say 30 milligram to 40 milligram, you maximum dose. Gradually every 1-2 months we can tighter 25, 20, 15, 10, 5 like that, and when dose is minimal, at that stage they should plan the pregnancy. Best would be when they plan, that time we can switch from carbimazole or methimazole to PTU. But remember, PTU is associated with some of the cases of fulminant hepatitis. So PTU only recommendation is during first trimester of the pregnancy, plus about 14 weeks. So PTU existence is restricted only to first trimester of pregnancy, and once patient pregnancy is beyond first trimester, then they should be switched to the carbimazole, methimazole. Even though first trimester they are tolerating, that is the recommendation, because some pulmonary hepatitis are there, and which happens to the person, for that person it would be 100%. So this is one of the paper from Denmark which talks about the various anomalies. All birth defects are higher, malformation of face, neck and digestive system which was missing, even aplasia of the gallbladder, anal, rectal dysplasias, they are known. So these anti-thyroid therapies we have to give with a caution and with the smallest possible dose. So for overt hyperthyroidism diagnosis during pregnancy, we give this medicine, and with a smaller dose after first trimester we should switch from PTU to carbimazole. But if dose is very small, pre-existing dose, say 5 to 10 milligram carbimazole or methimazole or 100 to 100 milligram PTU, then possibly one patient conceive, we can even stop, because very unlikely they will relapse during the pregnancy. Those patients who are not controlled, even surgery is indicated in second trimester, but 131 iodine therapy, radioablation is totally contraindicated during pregnancy as well as the lactation. Then mother is euthyroid, but anti-thyroid thyroid receptor antibody. This is a different antibody from TPO antibody or TG antibody. This is thyroid receptor, TSH receptor antibody, that is TRAB what we call. And if it is high, that means the autoimmunity from Gave's point of disease is there. And then if fetus is having thyrotoxicosis, mother is euthyroid, so that we can guess if fetus tachycardia is there more than 160, then we should suspect. Here we give, ultimately we have to treat mother to treat the fetus. So we give methimazole or carbimazole to the mother, so it can cross the placental barrier, go to fetus and treat fetal hyperthyroidism. And maternal hypothyroid will develop because of the anti-thyroid medicines. We should give thyroxine. And subclinical hyperthyroidism, then we need not treat it. Then thyroid nodules, they can be there, whether it is pre-existing or some new nodules may be available. Routine investigation, what we do routinely, that is TSH, sonography and FNAC should be done. And some may be just colloid, some may be adenomas, carcinomas. If at all we have to operate, then we can operate in the second trimester. So the routine investigations are only done. And the suspected ultrasonographic pictures we follow from Tirade scores, any nodule which is vascular, parenchymal vascularity, not the capsular vascularity, which is hypoechoic, which is taller than the broader, which has a calcification. These nodules we look at the suspicion, and there should be FNAC. FNAC, if is suspicious, then if nodule is not growing, then we can wait till end of the pregnancy. If nodule is growing or clear malignancy is there, as per patient choice, we can operate in the second trimester. If hypothyroidism there, we can treat with the thyroxine. Then again, range patients who are having malignancy and were treated like papillary, follicular, we give them thyroxine suppression therapy. There we suppress the TSH, and here in pregnancy also we need to keep their TSH between 0.1 to 0.5, I would say. And those medullary thyroid carcinoma, it is not active, it is not responding to the TSH, there we can keep below 2.5. And this therapy is monitored every 6 weeks with T4 and TSH. But what we routinely do, iodine scan and ablation therapy, again, it is not done during the pregnancy. Then infertility may be associated because there are changes between hypothalamo-pituitary thyroid axis, and they may interfere with the axis of hypothalamo-pituitary gonadal axis changes. They may also get altered. So the TSH, which has structural homology with the FSH, will have effect on the inhibition, effect on LH FSH. They may go down, and the prolactin may go up. GnRH response to the LH, which is responsible for the ovulation, that may be disturbed. So many aspects of hypothyroidism during in the conception period, one who is planning may get disturbed. So these are the changes which are possible, and by and large menstrual disorders are there during thyroid. Earlier studies showed very high incidence of menstrual disorder, irregularities, but recent study after proper treatment show less menstrual irregularity. So for subclinical hypothyroidism infertility, we should treat it, because some of the study shows that by treating them, the chances of full-term pregnancy increase, delivery rate increase. What Dr. Patki was talking, one of the aspects. So it doesn't increase chances of conception during the artificially assisted reproductive therapy, but whatever pregnancy achievement is there, it will progress to full-term pregnancy, which is actually important. So for that, thyroxine therapy would be required. So subclinical hypothyroidism, that is TSH borderline raised, T3-T4 normal, or autoimmune thyroid disorders. Patient may be euthyroid, but antibodies are there, autoimmunity is going on, and they are planning for assisted reproduction therapy or infertility therapy. There we should treat it, and by treating that, we are going to reduce the miscarriage rate as well as preterm birth rate, as seen with the meta-analysis of the various studies. So during IVF or ICSI or whatever therapy, not for the higher incidence pregnancy, but completion to the full term, it is very important. So when infertility patient comes for workup, that time only TSH should be checked, and overt hypothyroidism as well as the subclinical hypothyroidism, we should treat with the thyroxine. Even those who are planning natural conception and autoimmunity is there, we can treat with a small dose of thyroxine. So this Indian Thyroid Society FOXI guidelines, they recommend this therapy to TSH keep below 2.5, and thereby by treating that, we are going to help that with minimum risk. Then postpartum thyroiditis after delivery is one of the entity. It is a variant of Hashimoto's thyroiditis, that is atom thyroiditis leading to hypothyroid, quite common, 1 to 17%. It may be previous history of postpartum, after previous delivery might be there. Thyroid parasite antibody titers might be there in some patients. They are prone to develop postpartum thyroiditis, or type 1 diabetic women, because they are having autoimmunity. Type 1 is autoimmune disorder, so those women may have postpartum thyroiditis. So they may have transient hypothyroid phase after pregnancy, or transient hyperthyroid or thyrotoxic phase, or thyrotoxic phase going to hypothyroid phase during the postpartum period. So usually it occurs between 3 to 6 months after delivery. Because of the disruption of the follicle, the thyroiditis, disruption of follicle, T3-T4 is released, thyroglobulin exhausted, becomes hypothyroid because of high levels of T3-T4, signal goes to pituitary, so TSH would be low, and ultimately they would, once the process is getting down, they become hypothyroid, but healing would be there, and ultimately they would recover. They may have reduced production of the milk, but sometimes subclinical hyperthyroidism and Graves' disease in postpartum period may be confusing, because I mentioned Graves' disease, that is going to quiescent phase in second and third trimester, it may flare up after delivery, and postpartum thyroiditis, they will say transient hyperthyroid, TSH is low. How to differentiate? Usually around earlier postpartum thyroid around 3 months, while Graves' disease will develop somewhere around 6 months. Mild symptoms are there in the postpartum thyroiditis, while Graves' disease symptoms would be higher, thyroid enlargement may be there, weight loss might be there. Very important feature is, because postpartum thyroiditis is not actually overproduction, it is disruption of thyroid follicles leading to release of stored hormone, leading to hormones from the thyroglobulin. T3-T4 hormones are stored in the thyroglobulin, which is inside the follicle. Thyroglobulin, the follicles are disrupted, thyroglobulin is released, T3, T4 hormones are released, they go up. What is more storage is T4. Almost 98% storage is T4. So T4 levels would be high and T3 levels would be normal or just borderline high. So whenever disproportionately T4 is high, then suspect hypothyroiditis, not hyperthyroidism. Hyperthyroidism is actual production. Their production of T3 would be high. And the particular antibody, that is thyrotropin receptor antibody or TRAP, that is elevated in the Graves' disease. That won't be elevated in the thyroiditis. Routine screening may pick up serum TSH measurement, then we should do at 3 to 6 months after postpartum, and that should be repeated. If TSH is low, then T3, T4 we can do, and if T4 is relatively high, then it is possibly thyroiditis. If T3 is significantly high, then it is Graves' disease. And to advise the TSH, so suppose patient is already on thyroxine therapy, you can stop therapy and then look after about say 6 weeks. So patient may fully recover from postpartum thyroiditis, but those who are having antibodies positive, we have to keep them lifelong surveillance. So asymptomatic mild abnormal TFT, again monitoring would be required, and TSH up to 10, then unless they are planning pregnancy, we not treat it. So subclinical hypothyroidism only treated during pregnancy or somebody is planning pregnancy. All other men, women of not reproductive age, postpartum period, we need not treat TSH say from say 3 to 10. Even TSH is 8, 9, we need not treat it, we have to just follow. And especially senior people, those beyond 65, their TSH is naturally on higher side. So them also we need not treat it. But symptomatic hyperthyroidism is there, then in this particular postpartum thyroiditis, we can give symptomatic beta blocker. If breastfeeding is there, we can give a shorter beta blocker like propranolol. And if lady at all develops hypothyroidism, then we can start on small dose of thyroxine, and subsequently at 1 year we can stop the therapy and see. So vigilance would be required. So thyroid, hormone right from the womb to tomb and right from the hair to nail in our body, and it is omnipresent. So it's disorders and treatment just I discussed during the pregnancy. Thank you.
It was a very elaborative lecture by Dr. Mohan Magdum. He has covered everything related to hypothyroidism during pregnancy, pregnancy-related thyroid disorders. I think questions we can be asked at the lunch hours. So you must be remembering your hypoglycemia while listening hypothyroidism. So.
This is a nice informative lecture by Dr. Mohan Magdum sir. I request Chairman Dr. Shri Chauhan sir and Dr. D.G. Murthy sir to hand over a bouquet and memento to the sir, Dr. Mohan Magdum sir. Request President Dr. Aziz Singh Chadha sir to hand over bouquet to our chairmen Dr. Shri Chauhan sir and Dr. D.G. Murthy sir. I request all delegates to join lunch. This is a lunch break of 1 hour, and after that we have one lecture of ulcerative colitis by Dr. Siddharth Dharamsi sir, and after that there is entertaining program in Marathi. सादर करते प्राध्यापक श्री अजित कुमार कोष्टी हसवणूक. Thank you very much. by Dr. Siddharth Dharamsi Sangli. And for this session, we have chairpersons. I will invite chairpersons Dr. Sujay Kulkarni and Dr. Abhiman Pawar on the stage. I request chairpersons to introduce Dr. Siddharth Dharamsi.
Good afternoon, everybody. Dr. Siddharth Dharamsi has done his post-graduation from Bharati Vidyapit Medical College, Pune. Then he did his DM Gastroenterology from PSG Institute, Coimbatore. He has additional qualifications as fellowship in advanced endoscopy under world-renowned endoscopy expert and innovator Dr. Amol Bapai from Pune, and he is affiliated to Dharamsi Hospital and Liver Institute, Sangli, and he has many publications on his name.
Thank you, Sujay. Very kind introduction. At the behest, I'll first like to thank Dr. Chadda sir for inviting me here. It's an honor to present something on such a big stage. IMA Miraj. I'm not aware of most of the people here. I'm new. I've been working here in Sangli since 2 years, and unfortunately because of COVID, there were hardly any meetings, so interaction was limited. So I say thank you for inviting me. IMA Miraj, Chadda sir. And I am speaking on today's topic which is given to me, ulcerative colitis. I plan to simplify this mystic disease. It is a highly complicated disease. There is a lot of research going on in inflammatory bowel disease. It can be sometimes very complicated to understand. I will try to simplify the concepts, and I'll make it as short and as easy to understand as possible. So, as Sujay said, I did my DM Gastroenterology in PSG Hospital, Coimbatore, and following that I did an advanced endoscopy fellowship with Dr. Bape for 1 year in Pune, and now I'm working at Dharamsi Hospital, and we are also coming up with a new project called Dharamsi Digestive World, which is slated to open early next year. So, what is ulcerative colitis? It's always nice to have a definition first so that the concept is clear. It is a chronic inflammatory disorder that affects the rectum, and then it extends proximally to affect a variable extent of the colon. We might have heard of other diseases like Crohn's disease. So basically, ulcerative colitis and Crohn's disease are clubbed together in a disease entity called inflammatory bowel disease. So there are two spectrums. So there's one side is ulcerative colitis, the other end is Crohn's disease, and then there are few indeterminate cases that has also been given a nomenclature as indeterminate colitis, where the features are not typical of either. So how does ulcerative colitis differ from Crohn's disease? The number one hallmark is ulcerative colitis always starts from the rectum and goes proximally in a continuous fashion, whereas in Crohn's disease generally rectum is paired. In Crohn's disease, any part of the intestine, in fact right from the mouth till the anus, can be involved, whereas ulcerative colitis affects predominantly the colon and sometimes the terminal ileum. In ulcerative colitis, the disease process is continuous, whereas in Crohn's disease, there can be a lot of skip areas, normal areas and then there are associated deformed areas between the normal areas. So there is a skip area in Crohn's disease, which is atypical in ulcerative colitis. So this is a very busy slide. I don't want to bore you with all the pathophysiology. There's huge amount of research in the understanding of this disease. But the simple thing is, it is a multifactorial disease, and there is a lot of interaction between genetics, immunity, microbiome, that is the gut microbiome, and the diet and nutrients. I will just highlight one point of each part. So genetics, of course, there are a lot of genes, especially NOT2 mutation. Also there is IL-27, ATG. So some of these genes have been extensively researched, and but there's one classical thing that in hereditary ulcerative colitis, not every child or not every parent will be affected by the ulcerative colitis. So there's not only a genetic component, there has to be a multifactorial component. So what else is there? So of course there's a big part of immunity, the innate immunity of the person, which is determined by the mucosal barrier functions, the autophagy and the cytokine response. All that also play a very important role in this disease. Along with that, microbiome. Microbiome is also very important because different bacteria produce different toxins, and especially short chain fatty acids, which is produced by the harmful kind, are actually not very good for the colon, which can lead to the inflammatory process. And also very important is the diet factors. So initially, many years ago, when my father was practicing, it was said that ulcerative colitis is not very common in India. It is a rare disease. People used to think it is a disease of the Western world. Basically because they considered that the low fiber diet or the high meat diet in Western culture was the cause for ulcerative colitis. But slowly that myth has been busted. I think India also has a significant amount of ulcerative colitis. So it's not only the fiber content, but also the westernization of our diet has also affected this. So these are some of the key headings, and there's an interaction between all these components which can lead to ulcerative colitis. So coming to the distribution of the disease, for nomenclature's sake, we have kept it E1, E2, E3 is what is the standard nomenclature. So basically E1 is proctitis, that is it only involves the rectum. That is always the classical hallmark that the disease always starts in the rectum and then goes proximally. E2 is, it is involved the rectum and then it is also affecting the proximal part of the colon, that is the sigmoid colon and the descending colon. So E2 is up to the splenic flexure, is considered as left-sided colitis. And then there can be beyond the splenic flexure, that is proximal to the splenic flexure. It may be pancolitis or extensive colitis. Sometimes even the terminal ileum can be affected, that is called as backwash ileitis. But typically the small bowel is not involved other than the terminal ileum in ulcerative colitis. The age distribution. The most common age group is 16 to 40 years, which is A2. The lesser incidence is in less than 16 years and more than 40 years. The less than 16 years and more than 40 years tend to have a more difficult treatment, difficult course in terms of the disease can be very aggressive and may not respond very quickly to the treatment. And especially in the elderly, it is known to have a lot of severe complications as well as malignancy potential. Again, in the younger, less than 16 years, because of the chronic duration, they have a higher malignancy potential eventually. The most common age group is 16 to 40. Clinical features. The most predominant symptoms which a patient may say is rectal bleeding, passing of fresh blood, either separately from the stool or just streaked over the surface of the stool. The patient with proctitis will also complain of frequent and urgent need to defecate, and he will only pass small quantities of blood and mucus without any fecal matter. So this is called as tenesmus. Basically, rectum is like a reservoir of the colon, so it allows stool to accumulate, and then it allows when there is sufficient distension of the rectum, then the urge to defecate comes. But in this, the rectum is involved, the rectum is inflamed, so that reservoir capacity of the rectum doesn't function normally. So there is constant urge to defecate. So even if there is small volume of stools in the rectum, the patient feels the need to defecate. But eventually nothing comes, or maybe very little stool comes, and a lot of blood and mucus comes because of the inflammation. So this is tenesmus. Second common symptoms is diarrhea. There is frequent passage of liquid, small volume stools. As we said that rectum is a reservoir, so because of the inflammation of the rectum, there are small volume stools and sometimes associated with nocturnal diarrhea. There is fecal urgency, sensation of incomplete fecal evacuation and fecal incontinence, again because of the same pathology. Around 20 to 30% patients with proctitis or proctosigmoiditis may also complain of constipation. The next feature is abdominal pain. There will be a vague lower abdominal pain in the left iliac fossa. It will be a spasmodic intermittent type of pain, cramping type of pain, and it generally precedes the bowel movement and then relieves temporarily after the bowels are passed. And this keeps happening in cycles. That's the typical features. Other symptoms which may be associated is fever, anorexia, nausea, bloating and weight loss. I'll be very worried if a patient has fever in ulcerative colitis. That means there is some infection or peritonitis or perforation. Also, anorexia and weight loss, very worrisome feature, especially in a chronic case of ulcerative colitis, we look for malignancy. Or there is a severe inflammation which can also cause weight loss. Ulcerative colitis is a disease with multiple extraintestinal manifestations. So some of these I have discussed here. These are not all, there are many more, but these are some of the common ones. And they may be associated with a flare of ulcerative colitis. Sometimes it is, we as gastroenterologists forget to look at other systems, but it is important, especially in ulcerative colitis, to know all other organs also. So skin, they can produce erythema nodosum or pyoderma gangrenosum. They are not very common, only 2 to 4% is erythema nodosum. The first picture on the left is erythema nodosum. There are multiple tender inflamed nodules on the extensor surface of the limbs and other parts. This generally happens synchronous with the flares of the ulcerative colitis. The second image on the right side is pyoderma gangrenosum, which is quite rare. There are multiple small pustules form on the leg and trunk, which break down, ulcerate and coalesce together to form a necrotic area. Other organs, which is mouth, there may be aphthous ulcers, there may be stomatitis. This may or may not be directly related to disease. This is most often associated with the vitamin deficiencies because of chronic disease. Eye may be involved with episcleritis and anterior uveitis. Joints may be involved with acute arthropathy, sacroiliitis and ankylosing spondylosis. And vascular involvement may be with, there may be thromboembolism in cases of severe acute ulcerative colitis. Another interesting association of ulcerative colitis is primary sclerosing cholangitis, PSC. In patients with ulcerative colitis, there is a risk of 5% of patients developing primary sclerosing cholangitis. But in a patient diagnosed first with primary sclerosing cholangitis, there is almost a 70% incidence of patient having ulcerative colitis at the same time. So especially in diagnosis of PSC, it is very essential to look for ulcerative colitis. PSC also can go on to develop malignancy, liver malignancy also. So there is an additional risk of that. Coming to clinical examination ulcerative colitis, I have just clubbed the signs and the causes together. Here, starting from the mouth, there may be aphthous oral ulcers and stomatitis due to vitamin deficiencies. There can be clubbing of the fingernails due to chronic disease. Peripheral edema secondary to hypoalbuminemia, that may be because of the chronic disease. Pallor secondary to the blood loss. There may be icterus, which may be associated with primary sclerosing cholangitis. Tenderness in the sacroiliac joint, and on digital rectal examination, it is frequently normal, but sometimes the mucosa will feel very velvety. So always in a patient with diarrhea, bleeding in the per rectum, always very important to do a proper per rectal examination and look for the signs. Patient may directly come to you with complications of ulcerative colitis. So what they may be? They may be severe hemorrhage, per rectal hemorrhage. There can be toxic megacolon, that is basically an acute colonic dilatation of the transverse colon with a diameter of more than 6 centimeter and loss of ostration. This is an acute medical emergency because the colon needs to be decompressed, otherwise it may lead to perforation. There may be stricture. Of course, in a case of generally ulcerative colitis doesn't very often have stricture. It is more common with the Crohn's disease. If there is a stricture in the ulcerative colitis, we have to always be suspicious of malignancy, and always a biopsy is a must in a stricturized part of the colon. Especially when the stricture is located proximal to the splenic flexure, there is a high risk of malignancy. And last but not the least, there is colorectal cancer, which is a dreaded complication in this. So what is the association with colorectal cancer? The incidence depends on the duration and the extent of the disease. After 20 years of ulcerative colitis, there is a risk of 7 to 10% incidence of colorectal cancer. And after 35 years of disease, there is a risk of 30%. There is of course a role of doing surveillance colonoscopy in patients of chronic ulcerative colitis. We generally do every 2 to 3 years, we keep doing surveillance colonoscopies, and especially if there is a risk of family history of colonic cancer, then we may have to do it every 1 year. The goal is to catch the malignancy early so that the morbidity can be reduced with early treatment. So how will I investigate these cases? So first and foremost, hemogram is very important. It may show anemia due to blood loss. There may be leukocytosis or leukopenia if there is a severe ulcerative colitis, and there can be thrombocytosis in active disease, which may be also related to dehydration in the patient because of chronic diarrhea. There can be megaloblastic anemia on peripheral smear. This is secondary to the vitamin B12 and folic acid deficiencies because of chronic diarrhea and inflammation of the terminal ileum. There may be anemia which may be secondary to bone marrow suppression resulting from chronic inflammation, and also very importantly, drugs like azathioprine and sulfasalazine, which are very commonly used in ulcerative colitis, can lead to bone marrow suppression. So they need to be watched out for. There can be hemoconcentration due to dehydration and inflammation of the colon, and there is increased risk of thromboembolism in severe ulcerative colitis and also bowel ischemia. Some of the inflammatory markers which may be tested, ESR and CRP, whether previously used to be done very often. CRP is little bit more sensitive than ESR because it has a shorter half-life than CRP, but both of them are not very specific for ulcerative colitis, so it's not commonly done, but it may be done. The newer inflammatory markers is fecal calprotectin. Calprotectin is basically a degradation product of neutrophils, which is released into the fecal matter when there is active severe ulcerative colitis. So it helps in distinguishing inflammatory bowel disease from another similar, another disease called inflammatory bowel syndrome, which may mimic some of the symptoms of inflammatory bowel disease. But of course, there will be no bloody diarrhea in IBS. But bloating, pain, fullness, constipation, diarrhea, all this can happen in inflammatory, irritable bowel syndrome. So fecal calprotectin elevated levels is more in favor of inflammatory bowel disease than IBS. It is also very important to assess the treatment and look for the response to the treatment. So in this matter, fecal calprotectin can help us in whether the levels are decreasing or not after treatment. That may help us in identifying whether the treatment response is adequate or we need to change the treatment. It can also predict relapses or flares of the disease. It may be falsely elevated, false positive, when there is a history of proton pump inhibitor intake, especially omeprazole. Stool examination is a must. We have to rule out other infections which may cause bloody diarrhea, especially amoebiasis, worms. And in severe ulcerative colitis, we also look for stool for Clostridium difficile toxin, which can also cause severe colitis, and this happens normally in immunocompromised patients with a history of a lot of antibiotic usage. The biochemical tests that we need to do is renal function tests. Patients may have acute kidney injury due to chronic diarrhea and severity of the disease. Liver function test to look for primary sclerosing cholangitis with the elevated alkaline phosphatase. Hypoalbuminemia, as we discussed, chronic disease can cause low albumin. D-dimer in suspected cases of thromboembolism due to severe ulcerative colitis. Blood and stool cultures may be sent when we suspect infective colitis. Sometimes, as I told earlier, that it is very difficult to differentiate sometimes ulcerative colitis from Crohn's disease. So we can use serological markers rarely, such as this P-ANCA, to differentiate ulcerative colitis from Crohn's disease, although not commonly routinely done. Abdominal imaging. Before the advent of colonoscopy, I was just speaking today to Dr. Sotu sir, and as that time there were no investigations like colonoscopy and higher CT imaging. They used to diagnose ulcerative colitis on X-ray. He was telling me that at that time it was a different era where they had to be very good clinicians. So it's of course very important to do an X-ray, especially when we are suspecting there is severe ulcerative colitis, when there is severe abdominal pain, tenesmus, and bleeding and fever. We have to always rule out if there is a perforation. So look for air under diaphragm, and secondly look for toxic megacolon, where the transverse colon diameter is more than 6 centimeters in width. How to identify that? You can see the spine behind the colon. In each vertebral body is roughly 2.5 centimeters. So you can see that transverse colon is dilated. It is more than 2 vertebral bodies. It is definitely more than 5 centimeters, almost going to 6 centimeters. And you can see there is loss of frustrations of the colon. So this is a typical picture of a toxic megacolon. And of course it can lead to perforation. Some additional imaging which may or may not be used all the time. Ultrasonography can be used to distinguish it from other causes of similar symptoms, such as, again, as I discussed, inflammatory IBS, irritable bowel syndrome, and intestinal tuberculosis. In intestinal tuberculosis, generally there will be mesenteric thickening, there will be lymph nodes, there will be strictures. So this can be distinguished even on ultrasonography. But of course, colonoscopy and a biopsy is the most important test. Also, we may identify some complications of ulcerative colitis on imaging, such as stricture, perforation, and malignancy. Rarely, color Doppler ultrasonography or a CT angiography may be done in cases of severe ulcerative colitis to look for DVT or for pulmonary embolism. So, the main test in ulcerative colitis is, of course, colonoscopy and biopsy. The hallmark of UC is symmetrical and continuous inflammation that begins in the rectum and it extends proximally without interruption for the entire extent of the disease. The earliest sign is of loss of the normal mucosal vascular pattern. So the vessels, which are small vessels which are normally seen on the colonic mucosal wall, they are lost and there is edema. This is the first sign. So on the left, in the first image, you can see that the colonic mucosa is inflamed, reddish. There is subepithelial hemorrhage, and there is no vascular, there is no veins seen on this mucosa because of the edema. So this is one of the first signs of ulcerative colitis. On the right image, you can see a severe form where there is a lot of ulcerations, there is no vascularity seen, there is a lot of hemorrhage, and there is a lot of pus. So this is the mild and severe pictures. There is a grading system to make it easier for explaining our findings. So there is a Barron grading which is commonly used for endoscopic disease activity. There are three degrees, that is mild, moderate, and severe. In the first one, the mild one, there is a granularity of the mucosa. The mucosa has a pimpled appearance. There is a lot of edema and there is loss of the normal vascular pattern. In the middle image, you can see there is a moderate disease activity. There is coarsely granular area with small ulcerations throughout, and the mucosa is quite friable. Even when we put the colonoscope, the touching of the scope can cause a lot of erythema and hemorrhage. So that is moderate, and even more than that is severe. On the right image, you can see there are frank ulcerations, deep ulcers, and there is spontaneous hemorrhage in the colon. So that is severe. Of course, we take biopsies every time. Colonoscopy is not the end. We have to always confirm with the pathologist what we are seeing is true. So the four important points in histopathology which can differentiate from normal histology is disruption of the glandular architecture. So I'll just explain here quickly. I've put arrows for simplicity. So the top image is a normal colonic mucosa and the bottom was the ulcerative colitis severe form. So in the normal, you can see nice long glandular architecture of the colon. In the lower image, there are the glands are completely distorted. There is no uniformity. It's all haphazard. So you can see the glandular architecture is, I have put the arrows, you can see the glandular architecture is totally haphazard. There is a lot of inflammatory infiltrates into the colonic mucosa here. One other classical feature is cryptitis and crypt abscesses. The crypts of colonic wall are totally distorted, there is inflammation and there is a lot of abscesses, micro and macro granulomas, and there is surface epithelium ulcerations which I have pointed out in the slide here. Of course, this is a classical picture. Not all varieties of ulcerative colitis will have all of these. It's always in correlation with a normal mucosa. What do we find? That will differentiate from a mild, moderate, severe ulcerative colitis from a normal histology. There's a grading system, as I just mentioned. There are four grades. 0 is normal. 1 is no significant inflammation. 2 is mild to moderate edema with altered vascularity and increase in acute and chronic inflammatory cells, but intact epithelium. And 3 is heavy infiltration with crypt abscesses and ulcerations and exudates. So this is the age-old classification for clinical, for classification of severity of ulcerative colitis, True Love Wits. This has been used, I think, for more than 30 years. So there's mild, moderate, and severe. This is based on only clinical picture. So in mild, less than 4 stools per day, with or with small, without or with small amounts of blood. In moderate, there is intermediate between severe, and in severe there are more than 6 stools per day, with most of them being bloody. If there is fever, it comes into severe. There is temperature more than 37.8 degrees, that is fever. If there is tachycardia, again it is mark of severe. If the HB is less than 10.5, and if ESR or CRP is elevated, these are again markers of severity. in recent years, a combined classification entity has come into being, which is based on the True Love Weights and also a Mayo score system, and it takes best of both the worlds. So this combines the clinical and endoscopic assessment of the colon. So this is a more accurate and more commonly used severity scoring index. So it has 4 parameters: stool frequency, rectal bleeding, mucosal appearance, and physician's global assessment. Each has 0 to 3 scores with a total of 12. A severe disease is score more than 10 and remission is score less than 3. Also, a change on the scale on follow-up of this patient on treatment can also help us guide whether the disease is adequately, whether the therapy is adequately responsive or not. So, this is the scoring system that we commonly use. So, some of the definitions regarding therapy. So, what is meant by response in ulcerative colitis? Response is clinical and endoscopic improvement. There is no pathological word here, so it's only clinical and endoscopic improvement with a decrease in rectal bleeding and a greater than 30% decrease in the activity index. Response does not include pathological improvements. So what is remission? Remission is a stronger surety marker where there is complete resolution of symptoms along with endoscopic mucosal healing and most importantly confirmation on histopathology that the disease is having remission. So this requires a histopathological input. Remission is defined by individual patients which it has a sensitivity of 86% and specificity of 76%. So the goal is actually remission. What is relapse? It is a flare of symptoms in a patient with established ulcerative colitis who is already in a clinical remission, either spontaneously or after medical treatment. Early relapse is a period of less than 3 months after achieving the first remission or previous therapy. Infrequent is less than 1 flare in a year. Frequent is more than 2 relapses in a year. And continuous is where there is no complete correction of the disease process at all. There is a continuously active inflammation. So what are the goals of therapy in ulcerative colitis? And what treatment is to be given is to be determined on what parameters. So first the goal is to induce remission and to maintain that remission is the first and foremost important thing. And other things are to maintain adequate nutrition, to minimize the disease and treatment related complications and to improve the patient's quality of life. So the medication choice, there are a lot of medicines in ulcerative colitis. The medication choice is dependent on 3 main things. That is how severe is the disease, mild, moderate or severe. What is the distribution of the disease, whether it's distal or extensive, that determines whether we go for topical or whether we go for oral or systemic therapy, depending on the distribution. And what is the response to the prior therapy, whether any side effects were there, whether there's a compliance issue. So the choice is basically a combination of all these 3 parameters. There's no set determined guideline that every patient will respond to this only. It is a clinical judgment and a combination of all these 3 things. So starting with the history of all these drugs, first and foremost was sulfasalazine and steroids. Right from 1970, 1980s, it has been available. Actually, the history is such that ulcerative colitis was a rather unknown entity in 70s. What happened was people were just starting to know this disease, and so happened that rheumatoid arthritis patients who are also suffering from ulcerative colitis, who are already on sulfasalazine, they saw that these patients are responding. So that's how rheumatoid arthritis treatment started getting more and more, into the ulcerative colitis management. So there's a lot of, all of these drugs are in some way or other related to rheumatoid arthritis treatment, and so that has been always the case here because the treatment is very similar. So sulfasalazine and steroids have been there from the 80s. So also azathioprine and 6-mercaptopurine. Then came 5-aminosalicylic acid in 1992, 1993 it came. Then came the era of biologicals, that is infliximab, it's a biological. It came in 1998. And then came newer generation of biologicals such as adalimumab in 2004. In 2020, that is quite recently, we got budesonide MMX. What is MMX? It is a multi-matrix, that is, it is basically a different chemical process which allows distribution of this locally acting steroid into the colon. I will discuss about this later in my next slides. And then came recently in 2021 JAK inhibitors, that is Janus kinase inhibitors. And the only available drug so far is tofacitinib. And it is expected that later in this year or probably by early next year we will have vedolizumab for treatment in India. As of now it is used as a research molecule. So just summarizing the therapy options here. In mild disease, we use 5 aminosalicylates. It can be topical or oral. Topical is typically used for distal colitis where these medicines are given rectally, and oral is used for the more extensive colitis. In moderate diseases, we can give 5 ASAs as well as we can give glucocorticoids, which may be again oral, which is for extensive colitis, and it may be also given rectally as topical preparation for distal colitis. Then there is oral azathioprine and 6-mercaptopurine. In severe disease, there is options of IV glucocorticoids, cyclosporin, and of course biologicals such as infliximab, adalimumab, and maybe later vedolizumab, and the recently launched JAK inhibitors, which is tofacitinib. So normally the induction phase is with steroids and 5 aminosalicylates. If there is inadequate response or if the disease is not improving as expected, then we use rescue therapy, which includes biologicals and JAK inhibitor. And then we go to the once the disease is improving, we switch to the maintenance phase where we try to reduce steroids, we try to stop the steroids to limit the side effects to the patient. So we use maintenance therapy basically with azathioprine and 5-ASA and sometimes biologicals. So discussing each one here, aminosalicylates, the first molecule. Sulfasalazine consists of an antibacterial component. Basically sulfapyridine is the antibacterial component. It is bonded by an azo bond to a salicylate, which forms the 5-aminosalicylic acid, also called as mesalamine. So this antibiotic component, that is sulfapyridine, it serves as an inactive carrier, and it prevents absorption of the actual active metabolite in the small intestine. We want the 5-ASA to reach the colon, but if you give it without the sulfapyridine component, it will never reach the colon. So the sulfapyridine components prevents its degradation into the small intestine. Approximately 90% of the sulfasalazine reaches the colon, and only a small amount is absorbed in the small intestine. On reaching the colonic mucosa has an enzyme called azoreductase. This azoreductase cleaves this bond, the azo bond, and it is elaborated basically by the colonic bacteria. So colonic bacteria releases this azoreductase enzyme, and it cleaves the azo bond to release the active component, which is the 5-ASA, into the colon. So the doses of mesalamine has been a series of debates for many decades. The most prominent trials has been the ASCEND trials, series of trials on mesalamine. Doses of 2.4 and 4.8 grams were compared, and they showed similar efficacy in patients with mild active disease. But the higher dose, that is the 4.8 gram dose, is absolutely much more efficacious in patients with moderate to severe disease. The side effects of aminosalicylates is of course folate malabsorption. The folate absorption in the terminal ileum is affected by this molecule, so always make sure that folic acid supplementation is given. Another side effect is agranulocytosis and hemolytic anemia. Some rare side effects are arthralgia. Quite rare side effect is hepatitis. Very rare side effect is pancreatitis. So most common is of course folate malabsorption, which you need to keep watch for. Some of the topical preparations of aminosalicylates, they may be enemas or they may be suppositories. The enemas deliver it up to the level of spleen fracture. Actually, spleen fracture is, I would say, it relays up to the sigmoid colon. Descending colon may or may not get that effective dosage. So I would say it is more till the sigmoid colon rather than spleen fracture. The enema is useful in ulcerative colitis, which is affecting only the rectum and the sigmoid colon. Suppositories can be used, but this is only for the disease involving the rectum. It doesn't affect the sigmoid colon disease at all. And this can be used for mild to moderately active distal disease. The dosage is, there is a 5-ASA enema. Various brands are there. They come in dosage of 1 to 4 gram. I think the 4 gram one is the most commonly available. We give it nightly. Then there is suppositories. Mesalamine suppositories can be given for the proctitis. 1 to 1.5 gram is required in either nightly or divided doses. In the market, we get both 500 milligram and 1 gram suppositories, which may be used as per convenience. Glucocorticoids, very important and mainstay of the treatment for many decades, especially in the induction phase. So prednisolone 40 to 60 milligrams per day is the effective first-line therapy for moderate to severe flares of UC. And once there is a disease remission, we can taper or the symptoms are better, we can taper the dosage by 5 milligram every week after control of the flare. There is no role of continuing steroids for maintenance because the side effects outweigh the benefits here. So always better to stop the steroids when the flare is over. Budesonide is another type of a steroid, but it has got a very topical effect. Basically, it has a presence of an acetyl side chain, which allows for enhanced topical anti-inflammatory activity, and it only affects the glucocorticoid receptors in the colon rather than in the systemic areas. So it has approximately 90% first-class metabolism in the liver and erythrocytes, and it is converted to metabolites which have little or no biological activity, hence less toxicity. So it is relatively safe compared to systemic steroids. Some of the earlier molecules was a brand called Entocort. It is a controlled release budesonide, which releases the budesonide in the ileal and the ascending colon, and it is coated with microgranules with an internal ethyl cellulose component. So it releases budesonide at a pH of greater than 5.5, and about 80%, 50 to 80% is released in the ileocecal region. So this is commonly used in Crohn's disease, which is the ileocecal area is the most commonly affected area. But in ulcerative colitis, this may not be the target area. You want the budesonide to reach the distal colon, which is the most common area affected by ulcerative colitis. So then came a new molecule called as budesonide MMX. It is basically multi-matrix technology, which allows the release of the drug in the distal colon. So now this new molecule is being used for even ulcerative colitis. Next important group of drugs is immunomodulators. This is basically azathioprine and 6-mercaptopurine. These are purine analogs which interfere with nucleic acid metabolism and cell growth, and hence exert a cytotoxic effect on the lymphoid cells. Azathioprine is non-enzymatically converted to the active moiety, which is 6-mercaptopurine. The two primary metabolites of 6-mercaptopurine are 6-thioguanine nucleotides, 6-TGN, and 6-methyl-mercaptopurine, which is 6-MMP. So these two components, that is 6-TGN and 6-MMP, are the products here, primary metabolite products here. So the 6-TGN component is the one which has immunomodulation effect, which is beneficial for us. It also causes bone marrow toxicity, which is a side effect. And the 6-MMP is a not useful product, which causes hepatotoxicity. So the enzyme thiopurine methyltransferase, in short TPMT, is a key enzyme which converts the 6-mercaptopurine to its inactive metabolites 6-MMP and 6-methyl-mercaptopurine ribonucleotides. So there is a lot of debate on this TPMT polymorphism. Actually in India it is not very common. It is more on the western countries where the TPMT gene is mutated. So there's a decrease in the TPMT enzyme activity which can cause more toxicity, especially to the liver. So this TPMT polymorphism may be in homozygous wild type TPMP, that is normal TPMT activity which you give normal dosage. There is no need to change the dosage of azathioprine. There may be heterozygous TPMT mutation where there is the intermediate enzyme activity causing excess toxicity by the metabolites, and the dose has to be reduced to 50% of the optimal dose. And then there is a homozygous TPMT mutation which can cause severe problems. So in this, azathioprine is contraindicated. We do not use this. In India, actually, TPMT mutation is very rare. It is less than 3%. So if you ask me, it is not necessary to check in all the patients. But yes, of course, if you feel that the response is not correct or the response is not adequate or if patient is having some unexpected results, always better to check for TPMT mutation analysis. The dosage of azathioprine is 2 to 3 milligrams per kg per day. Generally, we start with 2 milligrams per kg and then gradually escalate after 6 to 8 weeks if we see that there is no side effects of azathioprine such as bone marrow suppression. And the dosage of 6-mercaptopurine is 1 to 1.5 milligram per kg per day. The side effects of azathioprine and 6-mercaptopurine, of course, is, as I just discussed, hepatotoxicity, because one of the products is a hepatotoxic agent, and so that has to be watched out for. Very important to see for bone marrow suppression. Always do a CBC after starting azathioprine at the end of 4 weeks. See if there is any pancytopenia, anemia, leukopenia. That is the early marker that the dosage has to be changed. Rarely some hypersensitive reactions happen, fever, rash, arthralgia. Of course, infections have to be ruled out before starting azathioprine, and also lymphomas. These are strict contraindications before starting azathioprine. Always also rule out in India, especially always rule out tuberculosis, hepatitis B, hepatitis C. So always we get a X-ray, chest X-ray, we check this before starting any immunotherapy. And rarely but quite severe, we have seen quite a few cases of azathioprine-induced pancreatitis. So in that case, azathioprine is completely contraindicated. How do we monitor the response? Of course, again, as I just mentioned, CBC has to be monitored frequently, and levels should be determined at 4 weeks following any dose adjustment. What other additional medications may be given along with the treatment? Antibiotics may be given to manage any infections, suppurative complications. Prebiotics and probiotics have been, as I discussed in the initial part, that there is an association of dysbiosis of the gut bacteria, which can cause inflammation and inflammatory bowel disease. So again, probiotics have been shown in some research to enhance local immune response. So a good probiotic always benefits. Also supplement vitamin B12 and folic acid. As I discussed, 5-ASA and this can cause folic acid absorption problems, and also chronic diarrhea can cause vitamin B12 deficiency. So always make sure you are supplementing the vitamins. In severe ulcerative colitis, they are at high risk of thrombosis, thromboembolism, DVT, and very often we have to use heparin. A lot of people ask me, why are you using heparin in a patient where patient is bleeding with ulcerative colitis? There's been extensive research on this, and it has shown that heparin does not actually increase the bleeding in severe ulcerative colitis, but rather it is helpful in decreasing the inflammation and also reduces the complications. So in severe UC, a lot of people feel it's weird, but in severe UC, we do use low molecular heparin for maintenance, for prevention of DVT. Also blood products as and when necessary for anemia. There has been a lot of research in nicotine. In textbooks, it has been shown that smoking is beneficial for ulcerative colitis. So there has been research in transdermal nicotine, but it is in very nascent stage. There is no concrete evidence whether it is beneficial, and even if it is, there is no role for it as of now, because there are significantly better medicines with lesser side effects. There has also been a lot of talk on fecal microbiota transplant. Basically, it comes with dysbiosis. The healthy patient's fecal matter contains good amount of bacteria, which can reduce inflammation in the affected patient. So a lot of research has been done, and there has been some positive things seen with FMT, but still it is very nascent stage. So it is as of now only experimental therapy. Maybe future it may be used as a treatment for severe ulcerative colitis. Coming to the biological therapy. The first and foremost is the anti-TNF alpha antibodies, which have initially been used for rheumatoid arthritis and then also started for use in ulcerative colitis. So what is TNF alpha? TNF alpha is an inflammatory protein. It activates multiple systems in the body. It activates macrophages, it activates endothelial cells, fibroblasts, epithelium. All in all, it basically activates all kind of channels which increase the inflammation in the colon. So anti-TNF antibody is basically the reverse of this, so it decreases the inflammation cascade and hence helps in reduction of the disease. So the first molecule which was approved was infliximab. It is a chimeric monoclonal antibody. It was derived from the rat blood. So it is a chimeric monoclonal antibody. It binds to both free and membrane bound TNF, and it leads to apoptosis of TNF producing cells. Hence, it litigates the leukocyte migration and reduces the inflammation. The dosage is by IV infusion. 5 milligram per kg is the dosage required. The initial loading dose is at 3 infusions, first at 0, then second at 2 weeks, and third at 6 weeks, followed by maintenance infusion of 5 milligram per kg every 8 weeks. Then also addition of azathioprine along with infliximab has been shown to be better than just infliximab. So azathioprine is always added to decrease the dosage required of infliximab, and it helps in maintenance therapy. Contraindications, of course, as we discussed earlier, rule out all infections, especially tuberculosis, hepatitis B, hepatitis C, lymphoma, neoplasms, demyelinating diseases, and severe heart failure are also contraindications for infliximab. A similar molecule came few years later, which also has a similar action. It is called adalimumab. It is a humanized or a recombinant human monoclonal antibody. So the advantage of using a human sera is that hypersensitivity reactions are much less compared to infliximab. So this has this is better tolerated in patients. It blocks inflammatory activity of TNF alpha, as we discussed, same as infliximab, and leads to apoptosis of TNF expressing cells and decreases inflammation. The initial dose is 160 milligram subcutaneously in divided doses over 2 days, followed by 80 milligram 2 weeks later, and then a maintenance dose of 40 milligram every 2 weeks. This is a subcutaneous injection, so relatively patient need not get admitted. Infliximab is an infusion. This is a subcutaneous injection. So after the first admission, after first dosage, maybe one day he has to get admitted, but after that it can be taken on an OPD basis, or even the patient can be taught to take it at home. It is just like an insulin syringe system. Again, same addition of azathioprine is beneficial for maintenance, and the contraindication is also similar like infliximab, that you have to rule out infections, neoplasms, demyelinating disease, and heart failure. Next in the line comes vedolizumab, which is expected to be launched in India probably by this year end or early next year. A lot of companies have taken the rights for manufacturing this. It looks very promising. Again, it is a recombinant humanized monoclonal antibody, but this is not anti-TNF. This binds to a different inflammatory molecule called alpha-4 beta-7 integrin. This is a protein molecule which basically leads to, again, inflammatory cascade, and its role is mainly in the cell adhesion cascade of inflammation. So there is a MADCAM1, it blocks the MADCAM1 molecule, leading to impairment of migration of T lymphocytes. The dose is 300 milligram IV at weeks 0, 2 and 6 by infusion, and then every 8 weeks. The contraindications again similar to the other biologicals like infection, lymphoma, demyelinating disease, and hypersensitivity. There has been, most of the research has shown that vedolizumab has an excellent therapeutic potential, and this drug is eagerly awaited. Another recently launched miracle drug is tofacitinib. It is a JAK, that is Janus kinase inhibitor. It is not a biological. It is a different kind of a molecule. It is called as oral small molecule selective inhibitor of JAK1 and JAK3. So what is this JAK? JAK is the signal transduction system which leads to cytokine response, and interleukins are activated by this system. There are various interleukins, as I mentioned here in the slide. These get activated, leading to inflammation. So this new molecule is a selective inhibitor of JAK1 and JAK2. It is an oral medication, and the dose is to be started with 10 milligram twice daily for 8 to 16 weeks. Look for the response. If the response is adequate, then you continue with maintenance dose of 5 milligram twice daily and taper slowly to the lowest effective dose required to maintain response. So this is something new molecule which has come recently, and we have been quite happy with this molecule. It has shown a good response, especially in steroid refractory cases where patient is not having adequate response. We have had good success with this molecule, and relatively well tolerated, and rarely seen any side effects of this. Again, the contraindications are similar to the biologicals. You have to rule out infections, lymphomas, malignancies, and cardiovascular disease. One different contraindication is dyslipidemia. So you have to watch out for this. After starting JAK inhibitor, before starting also we always do a lipid profile, and even after starting we check lipid profile after 8 to 16 weeks always, to see how the cholesterol levels are increasing or not. Sometimes we have to discontinue this drug if cholesterol levels are excess. Briefly discussing surgical, I am not an expert in this. A lot of surgeons here who can guide me better with this, but I will just briefly discuss the surgical part of it. So what are the indications of surgery in ulcerative colitis? One, of course, very obvious, carcinoma, colonic dysplasia. Obviously, there is no role of medical therapy here. Second is uncontrollable hemorrhage. We have had quite a few cases where whatever treatment we give, it is probably too late for the response to get corrected, for the disease to get corrected. So many times the surgery may be required in such cases. Colonic perforation, of course, there has to be a surgical role. Very rarely medically refractory disease. This has become quite rare because advent of newer drugs, biologicals, this is quite rare to have a refractory disease. Systemic complications that are recurrent and unmanageable because of the medications, that is also a rare indication. And of course, toxic megacolon, not necessarily every toxic megacolon needs to go for surgery. We can give a trial of medical management, see how the response is, and then decide whether surgery is required or not. Prophylactic colectomy is absolutely not recommended. So what are some of the methods of surgery that is utilized. So in emergency cases where there is a perforation or where there is toxic megacolon or there is refractory disease, the most commonly used method is subtotal colectomy with ileostomy. So most of the colon is removed, but the rectal pouch or a mucous fistula is created, Hartmann pouch is created for the remaining colon, and the end ileostomy is created. In a more elective scenario, colectomy with ileorectal anastomosis can be done. It is similar to the subtotal colectomy with ileostomy, but in this, the ileum is attached to the rectum, so there is a bowel continuity. Then another method is total proctocolectomy with a permanent brook end ileostomy. I don't know if this is very commonly used, but there is removal of entire colon and rectum, and hence there is elimination of entire risk of future development of colorectal cancer. And disadvantage is there is a permanent ileostomy. Another method is proctocolectomy with continent ileostomy, that is a cock pouch is created, and in this a loop of small bowel is used to create an intra-abdominal pouch and with an intussuscepted wall, it like a nipple, so it has some retention capacity and it allows storage of stool, and it is attached to the abdominal wall with a flush ostomy opening, and the stool is emptied by suction catheter. I think the most probably commonly used is the proctocolectomy with IPA, ileal pouch anal anastomosis. This is the operation of choice for most patients, and the entire colon and rectum is removed. Anal sphincters are preserved, and the pouch is constructed using 20 centimeters of distal ileum, and the bowel continuity is there by anastomotic pouch with anal canal. It's done in 2 stages generally. First stage is the temporary diverting ileostomy, and the second stage is ileostomy, which is reversed after 2 to 4 months. I conclude here. Thank you, IMA Miraj, once again, and I am free to any questions, any doubts which anyone wants to ask.
Very nice and lucid lecture, starting from the definition and clinical features, risk stratification and treatment. I think very nice lecture.
We are open for any doubts or questions. I think I have just a question. Like after event launch of tofacitinib, how often in your practice you use Remicade or infliximab?
I have been using it only as a rescue therapy as of now. I never started it as first line therapy. In fact, most of the research has been more in the favor of rescue therapy only. So I always start with more simple steroids, 5-ASA, and I wait for response, let's say for a few weeks. And if I feel the response is inadequate, then I start tofacitinib. So I use it only as purely rescue molecule, but it has given me good results. So I am not, it's too early to say whether it can be started as first line, but as of now I am not comfortable with first line therapy.
Okay. Like tofacitinib in acute severe ulcerative colitis, what 10 mg TDS dose? What
10 mg BID I give.
In severe cases like acute severe ulcerative colitis, they recommend 10 mg TDS. Do you have any experience on?
No, I have not tried. I have tried only 10 mg BID and I have had good response with that dose. So I don't personally know if 10 mg TDS is superior or not. But I have been happy with 10 mg BID. I have not had any failures.
Thanks.
What is the maintenance dose you think tofacitinib of?
What I've read and what we are doing currently is we start with 10 mg BID. We give it for at least 8 weeks. If at 8 weeks if we feel the response is good, then we continue and taper it to 5 mg BID. If at 8 weeks if we feel the response is not good, then we switch to some other drug. And then we keep it for 5 mg BID. The literature says that it can be continued for a year or more, but so far it has been a new molecule. So I have, at the max, I have given any patient not more than 6 months so far, and I have had good response. Maybe in the future I will taper it down and probably try to stop it.
I have a quick, can I ask?
Yes, please.
I have a question for you. Usually, as a surgeon, when we are referred cases of ulcerative colitis, they are mostly because of complications, bleeding not getting controlled, or toxic megacolon with perforation, or malignancy. Sometimes what happens is that after starting steroids, 48 hours patient is waited upon. The next choice is usually biologicals, not surgery. But giving biologicals against prolonging, if it is not responding, by the time patient comes to surgeon, patients become sicker and weaker.
Correct.
So the recovery is affected a lot.
Correct, definitely.
So what point in time you consider taking the surgeon in loop?
It's a very gray area, very correctly said. The idea is if we, it's actually based on clinical response purely. if you feel that giving 72 hours of steroids or biologicals, actually biologicals also need at least, it is said, at least 5 days of therapy time to see any response. So I would say 3 to 5 days is the minimum time required to see if there's any response. And after that, then we have to take a call whether there's any impending complication which may require surgery. But at the moment, I would say that because of the newer drugs, tofacitinib, say vedolizumab, which is coming in the market, so probably unless there is an obvious complication like impending perforation or there's uncontrolled hemorrhage, I would rather wait for some time before subjecting to surgery. But of course, I agree with you that by the time a patient comes to surgery, he is quite sick, and that definitely decreases the mortality, increases the mortality and morbidity. So I totally agree with you. Yes.
Thank you. You covered the rest of the things quite excellent.
Thank you, sir.
What about diet restrictions?
Milk is the first diet restriction, very important. Actually, I forgot to mention that, but milk has to be totally avoided in ulcerative colitis. And we also give a lot of importance to cleanliness, hygiene, because we don't want the patient to get recurrent infections. Infections can be very troublesome in a patient on treatment. So clean water, clean food, clean hands, washing of hands frequently, and of course then not eating outside, and avoiding of milk completely. Curds and yogurts and buttermilk is okay, but not milk. That's the only that's the only absolute contraindication. There's no other contraindication as such. If the patient can tolerate non-vegetarian food, he may take it. It's not a contraindication. Basically, it has been shown that there is lactase deficiency in most of this inflammatory colitis, which increases the inflammation. And it is not very clear as to what exactly leads to this, because curds are tolerated, but milk is not. But it has been shown that milk worsens the disease.
How often would you ask for a colonoscopic review?
Sorry, I didn't get it.
How often would you ask for a colonoscopic review?
Colonoscopy review, if the patient is doing well, of course at the onset I will do a colonoscopy to confirm the disease and do a biopsy. If the clinical response seems adequate, then there is no need to do a colonoscopy frequently, maybe repeat a colonoscopy every 2-3 years or so to look for first whether there is a histopathological correlation with the patient is better, but actually whether the mucosa is improved or not. So always take a biopsy and see whether there is healing, so that we can decrease the drugs and decrease the side effects of those drugs. And of course, if the ulcerative colitis has suddenly worsened, there's a flare, then I always do a colonoscopy to rule out other infections, especially. So that is very important. And of course, in patients with long-standing chronic ulcerative colitis, to look for malignancy. So in about 10 years of therapy, definitely every 2 years is required to monitor for malignancy. So it depends actually. In the initial phase, we can be less. We can do it less often, but after 10 years, definitely every 2 to 3 years we have to check.
If there are no more questions, can we conclude with permission of sir?
Okay, thank you very much for this informative and nice lecture. I request Chairperson to felicitate Dr. Siddharth Dharamsingh with bouquet and memento. I request President Dr. Rajesh Singh Chadha sir to felicitate chairman of this session, Dr. Sujay Kulkarni, Dr. Abhiman Pawar. नमस्कार. यानंतरचा आपला सगळ्यात शेवटचं लेक्चर, शेवटचा प्रोग्राम प्राध्यापक अजित कुमार कोष्टी यांच्यातर्फे सादर करीत आहेत हसवणूक. 5 मिनिटातच त्यांचं आगमन या ठिकाणी होत आहे. मिरज IMA तर्फे आयोजित कोरोनाच्या कटू आठवणींना गुड बाय करत आनंदी व मन ताजेतवाने करणारा प्रेरणादायी कार्यक्रम म्हणजे हसवणूक. तत्पूर्वी आपण एक सोवेनियरमध्ये प्रश्नमंजुषा घेतलेले होते. स्वर्गीय लता मंगेशकर यांच्याविषयी काही प्रश्न आपण या ठिकाणी विचारलेले होते. त्याची उत्तरं जरी त्या सोवेनियरमध्ये असतील तरी मी आपल्याला काही मॉडिफाय करून प्रश्न विचारत आहे. फर्स्ट क्वेश्चन, व्हॉट वॉज द बर्थ प्लेस ऑफ लता मंगेशकर? इंदोर. दॅट इज द करेक्ट आन्सर. हॅलो, हां बरोबर, बँक ऑफ इंडियाच्या वरती. त्यांचं आगमन झालेलं आहे. आपण थोड्याशा कार्यक्रम सुरुवात करतो. सुधांशु फाटक यांचे उत्तर अगदी बरोबर आहे. तर माझा प्रश्न असा आहे की सांगलीमध्ये मग कुठल्या भगिनीचा जन्म झालेला होता? लता मंगेशकर यांचा जन्म इंदोरमध्ये झाला असेल तर सांगलीमध्ये कोणाचा जन्म झालेला होता? आशा भोसले, मनीषा पाटील, डॉक्टर मनीषा पाटीलने उत्तर बरोबर दिलेलं आहे. लता मंगेशकर यांनी कोणत्या नावानं मराठी चित्रपटसृष्टीमध्ये संगीत दिलेलं होतं? आनंदन उत्तर बरोबर आहे. मराठा तितका मेळवावा, मोत्यांची मंजुळा, साधी माणसं, माळ्याच्या माळ्यामध्ये पाटाचं पाणी जातं, किंवा ऐरणीच्या देवा तुला थिंगी थिंगी वाहू दे, आभाळा जात माया तुझी अम्मावरी राहू दे. लताजी recorded maximum numbers of songs with one of the following music director: लक्ष्मीकांत प्यारेलाल, शंकर जयकिशन, R.D. बर्मन, S.D. बर्मन. Any idea? लक्ष्मीकांत करेक्ट. आन्सर इज करेक्ट. लक्ष्मीकांत प्यारेलाल.
750हून अधिक गाणी फक्त लक्ष्मीकांत प्यारेलाल यांच्याकडे म्हटलेत. नुसतं लता मंगेशकर नाही तर किशोर कुमार आणि मोहम्मद रफी यांची देखील मॅक्झिमम रेकॉर्डेड सॉंग्स लक्ष्मीकांत प्यारेलालकडे आहेत. म्हणजे सगळ्याच्या बाबतीने लक्ष्मीकांत प्यारेलालने आतापर्यंत म्हणजे जवळजवळ 98च्या अखेरपर्यंत, जोपर्यंत लक्ष्मीकांत जिवंत होते तोपर्यंत 750हून अधिक फिल्म्स फक्त लक्ष्मीकांत प्यारेलालने केलेले आहेत. बॉलिवूडमध्ये त्यांचे विक्रम खूप मोठे आहेत.
लताजी नेव्हर सॅंग विथ म्युझिक डायरेक्टर. कोणत्या म्युझिक डायरेक्टर बरोबर लता मंगेशकरनी एक ही पिक्चर
हॅलो 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 हॅलो.
प्राध्यापक अजित कुमार कोष्टी यांचं या ठिकाणी आगमन झालेलं आहे. त्यांचं खूप खूप स्वागत. सर, तुम्हाला काही वेगळी व्यवस्था लागणार आहे? मी मिरज IMAचे अध्यक्ष डॉक्टर अजित सिंग चड्डा सर यांना विनंती करतो, आजच्या कार्यक्रमाचे प्रस्तुत करते प्राध्यापक अजित कुमार कोष्टी सर यांना स्टेजवर घेऊन यावे.
पब्लिक असली
बंद करा जरा.
मी मिरज आयएमएचे डॉक्टर अजित सिंह चड्डा सर यांना विनंती करतो की त्यांनी प्राध्यापक अजित कुमार कोष्टी सर यांना स्टेजवर येऊन यावे. तसेच प्रेसिडेंट सरांनी सुद्धा स्टेजवर स्थानापन्न व्हावे. तिथं बस. थोड्या वेळ 2 मिनिटं.
दोन सूचना आहेत. वरांडामध्ये आणि वरच्या बाजूला जर प्रेक्षक येईल तर त्यांनी कृपया सभागृहामध्ये स्थानापन्न व्हायचं आहे. आणि जे प्रेक्षक मागे असतील त्यांनी कार्यक्रमाचा आस्वाद घेण्यासाठी आणखीन थोडंसं पुढे यायचं आहे. जेवढे म्हणून मागे बसलेले असतील त्या सर्वांनी इथं पुढे येऊन स्थानापन्न व्हायचं आहे. मागच्या जागा थोड्याशा रिकामा करूया आणि जे काही कॉरिडॉरमध्ये किंवा वरच्या बाजूला जे कोणी असतील त्या सर्वांनी खाली यायचं. कार्यक्रम 2च मिनिटात आपण आता सुरुवात करायची आहे.
हॅलो. मी मिरज आयएमएचे सचिव डॉक्टर रियाज मुजावर सर यांना सुद्धा स्टेजवर येण्याची विनंती करतो. मी मिरज आयएमएचे अध्यक्ष डॉक्टर अजित सिंह चड्डा सर यांना आजचे आपले प्रमुख पाहुणे आणि वक्ते प्राध्यापक अजित कुमार कोष्टी सर यांचा पुष्पगुच्छ देऊन स्वागत करण्याची विनंती करतो. नमस्कार. आजच्या CME मधील शेवटचं लेक्चर मेडिसिनवर नव्हे तर बेस्ट मेडिसिनवर आहे. घाबरू नका. बेस्ट मेडिसिन म्हणजे लाफ्टर. असं म्हटलं जातं की लाफ्टर इज दी बेस्ट मेडिसिन. कोरोनाची लाट गेली. कोरोनाची लाट गेली आणि आता हसण्याची लाट आलेली आहे. कोरोनामध्ये जे डॉक्टरांवर जे काम करत होते ते सर्व प्राथमिक स्वरूपात आपल्यामध्ये उपस्थित आहे. डॉक्टर तर आहेत, त्याचबरोबर काही साहित्यिक, काही पत्रकार या ठिकाणी थोड्याच वेळात उपस्थित होणार आहे. त्या सर्वांचं खूप खूप स्वागत. आमच्या मीटिंगमध्ये